Okay, good. Thank you.
Good morning. Good morning. My name is Andrew Stevens. I'm the Chief Medical Officer for Life Molecular Imaging. I'm one of the moderators of this session. I'd like to thank the organizers for inviting me and for inviting all the guests. I think we have a really exciting session today. This is going to focus on imaging in dementias. And so we'll have lectures both on a sort of a general overview. Then I'll talk about PET, then we'll have conversations about FDG and metabolism imaging. We're really fortunate to have Mike Weiner. We'll give a virtual talk from UCSF on ADNI, and then we'll talk also about MRI. So I think that these are very, very pertinent topics today, and I'm excited to be a moderator. So for the first speaker, I'd like to invite up Dr. Mohammed Dohar, who is the staff physician and section head of neuroradiology at the Cleveland Clinic in Abu Dhabi. He graduated from King Edward Medical University in Lahore, Pakistan, and has done radiology training in Iowa, followed by staff positions in Minnesota and the King Faisal Hospital in Riyadh. And we'd like to welcome him to speak about imaging on dementia. Thank you very much.
Assalamu alaikum and good morning. Thank you for the invitation. And especially I'm thankful all to the audience who are here for the very first lecture. And it's early in the morning. 20 minutes, you cannot cover the dementia, but I will give you, inshallah, a comprehensive outline, a framework so you can fit most of the disorders. So I have no disclosure, but I will say imaging alone is nothing without the clinical perspective. And I'm not talking about the clinical perspective. You guys all know about it, and you will have many lectures. So all will be the radiology. And this is literally my outline. We are going to divide dementia disorders in 5 buckets, and we'll try to fit into one of the category. So the first category is like miscellaneous causes. We can have like a mass lesion, NPH, and some other diseases. So this is literally the history. I screenshot from our packs. 45-year-old rule out early changes of dementia or atrophy. And this was the MRI. So this is the first presentation. So you see a large mass lesion. It's distorting the brain parenchyma, resulting in symptoms like dementia. And this was meningioma. So this is another cause we need to rule out, NPH. So you have disproportionate prominence of the sulci. You can see the ventricles are big. If you go to the vertex, the sulci are not visible. Everyday routine practice, we face this challenge. Is it NPH or is it atrophy? If you look at these 2 signs, you will be confident to say what it is. So here, if you look at the sulci at the top, in the NPH, all these sulci are effaced, and if you look at the atrophy patient, the sulci are prominent at the vertex. Second thing, we look at the closal angle. If closal angle is acute, less than 90, most likely we are dealing with NPH, and if it is obtuse angle, we are dealing with atrophy. So that was our first bucket. Our second bucket is the vascular disorders, and these can be like a 20% of the cases of dementia. And you can see these findings. If the white matter is involved, like more than 25%, or you have the Physica grading 3. If you have lacunar infarct, which are more than 2 outside the brainstem, that can also be a vascular cause. And then what we call like a strategic infarcts, like in the medial thalami, or if you have a large vessels infarcts. So here is the Physica scale for the deep white matter. If you have scattered foci, that will be Physica 1. If you have early confluence, that will be Physica 2. And if there is a lot of confluence, that will be Physica 3. Physica 1 is most of the time normal, and the other 2 can be associated with vascular disorders. So here is one of the patient. You can see there's a confluent hyperintensity in the white matter. So this is Physica 3, and that is likely the vascular dementia. And here this patient has these multiple small dark foci in the brainstem, which are usually seen with hypertension. This is one of our patients, and you see the infarcts in the medial thalami. So this is a artery of Percheron infarct, and this patient can present with dementia. As I said, we are going to divide this topic into 5 buckets. So this is the third bucket here. This one is very important, and the radiology can play a big role here. So these are the dementia which are associated with speech disorders. So these are 3 of those. You can have semantic progressive aphasia, you can have non-fluent variant, and then you have logopenic variant of primary progressive aphasia. Then imaging can differentiate all these 3 disorders. If you look at the logopenic variant, this is actually AD pathology, and the other 2 are the FTD pathology. And we have some specific findings here. If you look at these images, on one side, the Sylvian fissure is bigger, and you can see the sulci prominent in the parietal area. So if you see volume loss in the posterior peri-insular area and one side parietal lobe, this is most likely logopenic variant of primary progressive aphasia. And if you do the PET scan, you can see the hypometabolism on one side in the temporal lobe and in the parietal lobe. Here is the second semantic variant of primary progressive aphasia. These patients has usually more atrophy in the anterior temporal lobe, which can be asymmetric. And if you see here on the left side where the arrow is, there is a lot of atrophy on the left side. And if you do the PET scan, you can see the hypometabolism anteriorly is bilateral, but more on the left side. So this will be the semantic variant of primary progressive aphasia. And this is a non-fluent variant. Again, you see the prominence of the Sylvian fissure. So what is the difference between the first one from the logopenic variant? Here you have more volume loss in the frontal operculum. In the logopenic, you have a more volume loss in the parietal.
Recording in
So this one
progress.
is the non-fluent variant. So that was our third bucket. And now the fourth bucket is the dementia with the movement disorders. And you know the most common disease with a movement disorder is the Parkinsonism, like the typical Parkinson disease. And then you can have atypical Parkinsonian disorder, and then you can have also other like hyperkinetic disorders. For these, we do the DAT scan, and in all of these, the DAT scan will be positive. But it doesn't tell you whether you are dealing with Parkinsonism or you're dealing with atypical Parkinsonism. But it can differentiate from the other dementias. In the UAE, we have this technetium DAT scan that also works the same as your DAT scan, and this is one of the patient, and you can see in the basal ganglia, there is no uptake. MRI usually is negative or non-specific in your Parkinsonian, the typical Parkinson disease, but it has some feature in the atypical Parkinsonian disorders. So look at this one. So this one is the PSP. We do this sagittal image. On the very first image, you see we look at the superior aspect of the midbrain. Normally it should be convex like here. And in the early changes, it becomes flat. And if in the severe cases, on the next image, you can see now it is concave. So this is suggestive of volume loss of the midbrain, which is seen with the PSP. And some people like to call it hummingbird sign. You can see here there's a lot of atrophy of the midbrain. Some people like the penguins, like this one, it is the same concept. You have a loss of volume of the midbrain with the concavity of the superior aspect. And then on the axial images, you can see this sign, which is called the morning glory sign. If you look at the lateral aspect of the midbrain, the margins are concave. Normally they are more straight. And in this case, the margins are concave. Some people like to call it a Mickey Mouse ear sign. So this one is the, again, suggestive of PSP. And if you go to the sagittal image, and if you measure on the midline image, if the diameter is less than 14 millimeter, so that is also suggestive of atrophy of the midbrain. And then we have the MSAP. Usually the MRA is negative, but sometimes you see this linear hyperintensity at the periphery of the lentiform nucleus or the putamen here. So that is suggestive of MSAP. And then in the MSAC, there's a lot of volume loss in the pons and medulla. And in the advanced cases, we don't see this in early cases, you can see this hot cross bun sign. And And then in the corticobasal degeneration, MRI can be negative, but you can see this asymmetric volume loss in the frontoparietal lobe. I know the clinical symptoms are specific, but MRI can be suggestive. So if you look at these images, on the left side, you see the prominent sulci only on one side in the parietal lobe. So if you have asymmetric prominence in this area, so that can be suggestive of CBD. And if you look at the T2 images here and the coronal flare, it is all on the one side. And then in the hyperkinetic disorder, one is the Huntington disease, and you can see here, there's a lot of atrophy of the caudate head and the frontal horns are prominent. This is one of our patient. The PCON, we used to call it Haloverden-Spatz disease. In this, on the gradient echo images, you can see the lentiform nucleus is more dark than normal. And in the center, you see this bright area. So that is called tiger eye sign. And actually, we have treated few patients. Dr. Shivam has treated and given them the chelating agent. And we have seen on the MRI, there's improvement in the appearance as well as improvement of the clinical symptoms. So that is classic tiger eye sign for the PCON. So now we move to the last bucket, which is the more extensive and the most common one which you are going to see. So in this, you have a typical Alzheimer disease, atypical Alzheimer disease. You can have a behavioral variant, and then you can have this frontal temporal dementia. Again, Lewy body dementia can come here. Vascular dementia can also present with these symptoms. So this is the group which has the memory problem. So for the people who came late, so I can again summarize this. We are going to divide the vascular disorders in 5 groups. First was the miscellaneous, to rule out those causes. Second, we can rule out the patient with have like a primary progressive aphasia, then the patient with the movement disorders, and now we are dealing with those patients who are predominantly the symptoms is memory loss or the cognitive impairment. So Alzheimer's disease, there's so many variants. So you can have a typical AD, you can have atypical posterior cortical atrophy, logopenic variant, which we already saw, and then you can have the behavioral variant of Alzheimer's disease. Many times you might not see anything. You may see just non-specific MRI appearance. But if you see the volume loss in the temporal lobe, especially hippocampi and the parietal lobes, so that is suggestive of typical AD. And similarly, you can have a hypometabolism on the PET scan. And the other thing is amyloid will be positive. So right now we have all these medication. If you want to put the patient on those medication, you should have some biological marker which tells you the patient has Alzheimer's disease. If the amyloid is negative, basically, or practically, I would say the patient does not have Alzheimer's disease. So there's a different rating scales here. So for the generalized brain volume loss or the atrophy, we have this global cortical atrophy score or the GCA. So we look at the sulci and we look at the thickness of the gyri. If both are normal, so that is 0. If you have just mild prominence of the sulci and the gyri are normal, we are going to call that GCA1. If you have more prominence of the sulci, some volume loss of the gyri, so that will be GCA2. And if you have severe atrophy, like a knife blade kind of gyri and too much prominence of the sulci, that will be GCA3. So like here you can see all the examples. So the first one is GCA0, no prominence of the sulci. In the second one, GCA1, mild prominence of the sulci. GCA2, you have more prominence of the sulci and some volume loss of the gyri. In the last one, you can see the knife blade kind of pattern, too much volume loss in the parietal lobe. So below 75, GCA2 is abnormal and the GCA3 is abnormal all the time. Then we also look at the MTA score. So here we are looking at the hippocampus. The red arrow is pointing to the hippocampus. We look at the height of the hippocampus. We look at the width of the choroidal fissure. So here if the choroidal fissure is normal, temporal horn is normal, and the height of the hippocampus is normal, so that will be MTA 0. In the MTA1, you have prominence of the choroidal fissure. The temporal horn is normal, and the height of the hippocampus is normal. In MTA2, you have moderate prominence of the choroidal fissure. Now you also have widening of the temporal horn and some volume loss of the hippocampus. So that will be your MTA2. In the MTA3, you have more widening of the choroidal fissure, more widening of the temporal horn, and some more volume loss of the hippocampus. And in the MTA4, everything is more advanced. We have the volumetric software which we are using, but you can use this visual rating score. So here you can see the example of all of these on the MRI as well as CT. So in the 0, you don't see like any prominence of the choroidal fissure. In the next one, you see like a prominence of the choroidal fissure, so that will be our MTA1. Here you can see the prominence of choroidal fissure as well as temporal horn, so that will be your MTA2. And here, MTA3, you have some volume loss of the hippocampus. And in the same patient on the other side, you can have a different scoring on one patient. And here you have the MTA4, where there's a lot of volume loss. And the same thing you can see on the CT scan. But before you do this measurement, make sure you are looking the coronal image, which is oblique. Basically, it is at right angle to the axis of the, you can say the hippocampus or the ACPC line. And it should be at the level of memory bodies or the anterior pons. You cannot measure MTA score on any coronal image. First, it should be oblique. And second, it should be at the level of memory bodies. And then there is another score for the medial temporal lobe, is the ERICA score. So we are looking at the volume loss of the medial temporal lobe, including parahippocampus. So if there is no atrophy, so that will be 0. In the 1, you will have mild atrophy. And in the 2, it's a moderate, and 3 is the severe. I will show you the rating scale here. So in the first one, here's the collateral sulcus. If it is normal, ERICA score is 0. In the second one, if there is only prominence of the collateral sulcus, so the ERICA score will be 1. In this patient, these arrows are pointing to a cleft sign, which is, you see the CSF space between the brain parenchyma and the tentorium. So that will be ERICA 2. And in the ERICA 3, you have more prominence of this cleft, and you see the volume loss of the parahippocampal gyrus. So this is your typical AD. You have the volume loss in the parietal lobe, and there's a volume loss of the hippocampus. And on the PET scan, the Z score, you can see the hypometabolism in the parietal lobe as well as temporal lobe. And then we're going to go through this atypical variant. So the atypical, these patients are more young. They have less volume loss in the temporal lobe, and they have more volume loss in the parietal lobes. So usually the precuneus is involved. So if you look at this patient is less than 65. So that is atypical for Alzheimer. This arrow is the parasagittal image. It is the image right next to the midline, and it is pointing to the precuneus. And if the other arrow on the coronal image is pointing to the hippocampus, so the hippocampus is normal, there is a volume loss of precuneus, so that is your atypical. Here's another patient showing the same thing. And this is a frontal variant. You see the volume loss in the frontal and parietal lobe, the hippocampi are normal. Here's the amyloid scan. You see the negative scan on the left side and the positive scan where we have uptake in the cortex. So in the frontotemporal dementia, we have more volume loss in the frontal lobes and the temporal lobes, and this temporal lobe volume loss can be asymmetric. If you do, the PET scan play a big role here. Clinically, sometimes it is very difficult to differentiate these, whether we are dealing with the behavior variant of Alzheimer's disease, which happen in younger patients, frontotemporal dementia, and the PET play a big role here. If there's the hypometabolism anteriorly, you are dealing with frontotemporal dementia. If the hypometabolism is posteriorly, you are dealing with Alzheimer's disease. And then the dementia with Lewy body, MRI is negative, but the DAT scan will be positive. You can have some peculiar findings on the PET scan, and the amyloid PET scan can be positive 50% of the time. So here the MRI is negative. And if you see on this PET scan, you have this cingulate island sign. There's a hypometabolism in the surrounding area, but preserved in the posterior cingulate. So that is typical of dementia with Lewy body. This one is important. Some people are not familiar with this. The late limbic predominant age-related TDP encephalopathy. They may resemble clinically Alzheimer's disease, but on the imaging, so these people are more than 80 years old. They have a lot of volume loss in the hippocampi, but not the rest of the brain. So like this patient is more than 80 years old. You have a lot of volume loss in the hippocampi, and the rest of the brain is just for age appropriate. In this patient, amyloid is negative, PET is negative, but the MRI can show you typical features. So these patients are older than 80, lot of volume loss in the hippocampi, and the parietal lobes are spared. So here's the summary for the talk. We're going through all of this. So these are the 5 buckets. So these are now full. and I will show you the image is the summary. So first we look for the miscellaneous patient, then we look for the vascular dementia, and then the dementia with the speech disorder, dementia with the movement disorder, and dementia with a lot of the memory symptoms are more prominent. So here is the first group, the dementia with the memory disorder. So in the first example, this is a typical AD. You can see volume loss in the parietal lobe, volume loss in the hippocampi. The second one is atypical AD. It is a younger patient. Hippocampi are normal. You have a volume loss in the precuneus. Here on the top, you have the frontotemporal dementia, volume loss in the frontal lobes. In the bottom here, you have the late, where you have an older patient, lot of volume loss in the hippocampi. These are the patient, the second bucket, dementia with the movement disorder. In the non-fluent variant, the first one, you have asymmetric prominence of the Sylvian fissure, but the volume loss is in the frontal upper column also. In the semantic variant, only the anterior temporal lobes are more involved. In the logopenic variant, again, you have asymmetric prominence of Sylvian fissure, but you also have the prominence of the parietal lobe. And here's the dementia with movement disorder. So the first patient, you can see the PSP. This is a volume loss of the midbrain, the penguin sign. Here is the MSAP. You have this bright line at the periphery of the putamen. Here is the pecan. You have this tiger eye sign. In the MSAC, you have this hot bun sign. In the CBD, you have this asymmetric prominence. And in the Huntington disease, you have this atrophy there. So these are all the references here. So you're done with the presentation. And just one last word. If you rule out on the imaging Alzheimer disease and vascular disorder, you have ruled out more than 90% of them. So if those are the two ones I need to rule out first, and then I go through the next of those. Thank you.
Thank you, Dr. Jobar. Thank you, Dr. Jobar. We're very honored to have you at Cleveland Clinic. I have to give him the great credit in implementing volumetric reading, dementia-specific. He pioneered it in the UAE for our brain health program, so truly thankful. And now we're having our next honorable speaker, Dr. Andrew Stevens. Dr. Stevens has more than 30 years experience in the pharmaceutical industry, primarily in the areas of neurodegenerative diseases, oncology, and diagnostic imaging previously. He was a chief medical officer at Paramount Imaging and VP head of experimental medicine, oncology, and diagnostic imaging for Bayer Pharma. He has held position of increasing responsibility at NE Hexagon, if I'm not sure if this is the right way to say it. Is that correct? Okay, NE Star, Gilead, Sharing AG, and OSI Pharmaceutical. He received his BA cum laude in chemistry from University of Colorado, Boulder. He also received an MD with honors and PhD in biochemistry, biophysics, and genetics from University of Colorado, Boulder. Dr. Stevens is a board-certified internist and had clinical practice before entering the pharmaceutical development. Please help me welcome Dr. Andrew Stevens.
So thank you again for inviting me and for the organizers. So what I want to talk today about is PET imaging, and primarily I want to talk about amyloid imaging because I think it plays a key role today, especially in the light of the disease modifying therapies. And then I'll go into a little bit some of the newer more research-driven tracers that are out there. So just by disclosure, I'm a full-time employee of Life Molecular Imaging, and we have the imaging or the marketing authorization in a number of places in the EU and the US, and now in Saudi Arabia is registered. And importantly, I think for this group is that flobetabine is approved in Saudi Arabia and manufactured and distributed by Oryx Isotopes, and they were here yesterday. I hope they come today. And so flobetabine, they're here. Please talk to them. They are so flobetabine amyloid PET imaging is available in UAE today, and we look forward to that. Just very quickly, we came out of Bayer in 2012. We were part of Piramal Imaging. We focus on not just neuroimaging, but also cardiology and more oncology. And recently we've been acquired by Lantheus Molecular Imaging, and that'll be the next chart. I won't go through this. Okay, now for the real stuff. So as we've just heard, and as you know, dementia is an umbrella diagnosis of people who are unable to who are no longer independent of activities of daily living, and it comes into many different buckets that we've heard: Alzheimer's, Lewy body disease, vascular dementia, frontal temporal, and others. About 60 to 80% of this is Alzheimer's, and we're learning more and more that much of the Alzheimer's, especially in the elderly, is mixed disease. So you have a mixed Alzheimer's and vascular disease, or you'll have a lot of alpha-synuclein in the older diseases. And so typically what we're seeing is we're now seeing a little bit of a differentiation between what the pathological disease is, either by biomarkers or pathology, and what the clinical symptoms are. And so people will have mixed diseases but present with a dominant Alzheimer's or present with a dominant Lewy body, things like that, and that's how it'll be called clinically. In terms of one of the other things learning about Alzheimer's disease is it's a spectrum disease. It obviously, amyloid plaques start developing up to 20 years before symptoms develop. And so now we're having earlier disease classifications such as mild cognitive impairment and even subjective memory complaints. And so as we move, as we have more biomarkers, we're able to move earlier and earlier and start talking about primary prevention perhaps in the future. Whoops. Just very quickly is to say that dementia is not normal. You know, some people say, oh, people get old and they lose their ability to think and to cognate. This is not true. There is some diminution in normal aging, but clearly dementias and Alzheimer's in particularly is a much more aggressive disease, and it is pathological, and it warrants treatment and study. Despite significant progress in the last decades, it's underdiagnosed still in greater than 75% of dementia patients globally. The diagnosis is made many years after onset of symptoms. The latest data I saw was about 3.5 years after onset of symptoms is when the diagnosis is finally made, and it's misdiagnosed, and it's still misdiagnosed at a remarkably high rate, even amongst experts in the field. 20 to 30% of patients at the dementia stage are misdiagnosed, and greater than 50% with mild cognitive impairment. And I think that speaks to as we've heard, the very different presentations that people have, and the lack of attention that's been paid, and the lack of biomarkers in the future. And so biomarkers have really revolutionized the field in terms of defining the disease, and I think that we'll hear, that's where we're going today, and will allow for earlier and earlier treatment, which hopefully will have better outcomes. AD gets worse over time. That's important, and it's not a static disease, and amyloid accumulation can begin, as I've said, up to 20 years before symptoms. Fortunately, and what we've seen even in the hallway today is that there are 2 drugs available which are considered disease-modifying treatments. These are antibodies that remove amyloid from the brain, and it's Leqembi and donanemab, or Leqembi and Kisunla. And this is the very early stage. These are the first disease-modifying agents ever, and the first new drugs in Alzheimer's disease for the last 20 years. So it's an exciting time in our field, and I think that we're all looking forward to seeing how this will progress. In terms of biomarking testing options, there are 3 main buckets that we can talk about. There's traditionally is cerebral spinal fluid, which is to stick a needle in the spinal canal and withdraw fluid. There's now an increasing interest in plasma biomarkers, and there's the PET brain scans, which I think most people would agree is still the gold standard for diagnosis of amyloid disease in the brain. This is just a slide showing showing sort of the progression of Alzheimer's disease by virtue of biomarkers. And one of the things you can see is that Alzheimer's, the A beta, the amyloid disease starts very early, and by the time you get to dementia, you have, this is a 58-year-old with an MMSE of 23. You see that this person has robust deposition of amyloid across all regions of the brain. Tau, it comes up next, and what you see is that it has a different distribution. It starts in the entorhinal cortex and progresses to the the temporal zones and then into precuneus and then frontal later. That's followed very closely by neuronal or synaptic dysfunction. This is measured by FDG, where you see metabolic dysfunction in very much the same regions as you see with tau, but a little bit delayed. And then with MRI, you can see cortical atrophy, which happens again in the same regions, but is delayed again. And so there's sort of this hierarchy of biomarkers that allows you to sort of start to begin to stage patients, particularly with tau. And one of the things that I talk about, and it's probably not the best analogy, but to say is that amyloid is necessary but not sufficient. It's the gun but not the bullet, and tau is really the bullet which causes the neuronal damage, along with many other factors. But tau is the primary driver. But the two amyloid plaques and tau tangles is the definition of Alzheimer's disease as we know it today. Okay, there are 3 amyloid tracers out there that have been approved in the U.S. and Europe and throughout the world. The first is by Eli Lilly, is Amivid. The second is Neuraseq by Life Molecular Imaging, and the third is Vizamyl by GE Healthcare. They are very similar in their structures. They're very similar in their behavior. We've worked within the AMIPAT consortium in Europe to show that these drugs, or these imaging agents, can be harmonized in terms of their quantification and their interpretations. So although they have different ways to read them, in many ways they're similar, and they're different flavors of the same thing. This is just an example of flubetabine, and you can see here's a negative scan by pathology, and you can see that you see prominent white matter, you see good white matter, gray matter differentiation, and this looks like a white matter map because these bind to myelin. All of these tracers do. And here is a positive scan where you can see blurring of the gray white matter boundaries and sort of a fullness and a fluffiness, which is quite in traditional easy cases, which is about 85% of the time. These are quite straightforward to read. Okay. So one of the things that's been a challenge for us is that the regulatory agencies have told us that what they're interested in is a dichotomous yes/no read, positive, negative. So we have criteria. There are reading methodologies for all 3 tracers that say this is a negative scan, this is a positive scan. That being said, we all know that this is a spectrum disease. Is that you start with none, you get a little bit, then you get a little bit more, then you get a lot. And so it's a spectrum, and we've put an artificial sort of line in it and said this is positive and this is negative, and that's not the natural history of the disease. So what we've done within here. All right. So what we've done within AMIPAD and others and other groups is to come up with a harmonization scale, a quantification scale called centiloids. And what centiloids has done is to standardize the regions of interest we're looking at, and to standardize all 3 approved F18 tracers against the C11 PIB tracer, which is really the first and the gold standard. This allows it scans with either Amivid, Neuraseq, or Vizamyl to be read out as on a centiloid scale, and so 17 centiloids of Amivid is essentially 17 centiloids of Neuraseq, etc. So it allows you to use different tracers. It allows you to compare populations where different tracers have been used, and as we're learning more and more, it allows you to use different tracers longitudinally, so that if you have a Neuraseq scan at the beginning, you can switch to an Amivid scan if that's what's appropriate, and you can still read quantification. The second reason that quantification is very important is the onset of disease-modifying therapies, is that you need to know, one, what the level of amyloid is quantitatively at the time of onset of treatment, and then to be able to look at it later on in treatment monitoring to say whether you've done anything, whether you've removed that amyloid, and where on the journey you are of clearing amyloid completely from the patient's brain. So here's the centiloid in a spectrum. This came from AMIPAT, and what you can see is that you have a region of negative scans from 0 to somewhere around 20 centiloids. Then you have sort of this gray zone between 20 and 35. Different publications call it differently. And then you have clearly positive. And you can see how this progresses from a white matter map in the negative cases to a slightly more positive to full-blown positive. And this allows you to do quantitation over time within each patient and to look at different populations and to do different studies in different populations and understand where you are. We're also beginning to understand that if you have, depending on what your centiloid level is at the onset of disease-modifying therapy, it affects how long those patients need to be on therapy. So that if you have a centiloid of, say, 50, 75% of those patients will be cleared after 9 months on Kizulna. If you have 150 centiloids, then those patients, only less than 25% of those will be fully cleared after 9 months of Kizulna. So how much amyloid they have at baseline directs you in terms of how long these patients are going to have to be on therapy and how you're going to talk to the patients and how you're going to think about them. Okay, in terms of just the clinical pathway, and I think that we'll hear more about this later, but the idea is you have an initial thinking problem, you go visit your primary care physician, that person will do maybe a MOCA or an MMSE or start looking very basically. If they think that there's something there, refer to a specialist, a neurologist or a geriatrician who will do more formal cognitive testing, referral for biomarker testing. After they have the combination of cognitive testing and biomarker testing, there can be a decision-making process and a conversation with a physician to come up with a final diagnosis and the decision to treat the patient. This, in some places, we've heard different operations. This can take up to 6 months in different hospitals, depending on scheduling. It also can be done within a week. Okay, we've seen this is actually shrinking, and the process of having a patient referred to the specialist to coming to a treatment decision can be very much truncated, depending on the structure and the infrastructure that's available within the hospitals. Oops. Yeah, this is just to say that this is again the spectrum of amyloid deposition. This is no symptoms and no cognitive impairment, mild cognitive impairment due to AD and full AD dementia. Currently, the window for approval of the drugs is in the mild cognitive impairment and early Alzheimer's disease, but we're always looking for therapies that might treat later on. We have a new drug out for behavioral problems in dementia, which has just been approved, and we're hoping very much to move into even secondary prevention. So this is quite exciting. These are the drugs. I don't have time to go through them all, but lecanemab and donanemab are the two new kids on the block, which were just approved. We heard that lecanemab was approved in Europe just last week, so we're quite excited about that. This is sort of what we expect to see is you have in the disease continuum is you have no amyloid, then you get up to a full head of amyloid, and then you start some amyloid lowering drug, and what we see is it drops down and you start getting a negative scan, and you can return patients to a negative amyloid scan over the course of 9 to 18 months. Okay, just a quick word on blood-based biomarkers. This was a study that we did comparing phlobetabine with blood-based biomarkers in an autopsy cohort that we did. And so these are patients that had PET scans and blood draw prior to death on their passing. We did pathology and necropsy and harvested their brains and looked at amyloid and tau in the brain. So we have really standard of truth. And one of the things that we see, the take-home message, and I'm moving very quickly and I apologize, is that the phlobetabine visual reads were more specific and as sensitive as P217, and that what you have is that you have a higher number of higher number of false positive cases for plasma p-tau217. So what this indicates to us is that p-tau217 is a wonderful screening tool, but is probably not the right tool to use prior to initiation of disease-modifying therapy because you have too many false positives. The second reason why the p-tau is not yet ready to be the only agent is in terms of disease or treatment monitoring, it's really quite poor at measuring decreases in amyloid levels over time. So this is just, I have to move very quickly, just to say, and I think this is important, we were talking about this yesterday, there are new criteria out. There's a new AUC. Here you can read it, take a picture of it, by Philip Kuo in the Society of Nuclear Medicine, looking at, so we do have new AUCs and new criteria in the US. This is coming out in Europe, and hopefully it'll be spread around the world. There is a new diagnostic criteria for AD in the U.S. with Cliff Jack and Company, where it's very, very interesting. They're moving towards really trying to get to primary prevention, and so they've defined Alzheimer's disease by it was traditionally an ATN, amyloid, tau, and neurodegeneration, and now they've added inflammation, vascular injury, and alpha-synuclein markers as modifiers to this. But the idea is that you can make a diagnosis of AD simply with biomarker differentiation of A and T, primarily with Alzheimer's disease. This is controversial. In Europe, there's a feeling that we still need a clinical exam and a clinical symptomatology consistent with Alzheimer's disease before you make that diagnosis. So there's a little split between the Europeans and the U.S. about the role of clinical function. Is the point, I think, to this particular criteria is it does allow you to move earlier and earlier into minimally symptomatic or asymptomatic patients, which the European model doesn't quite allow yet. Then just in sort of very quickly, there are other tracers beyond amyloid. So there's tau that we've heard a little bit about. There's one tracer approved in the United States, which is called flotalcipir, and there are several second-generation tracers in clinical trials, and I'll talk to you about ours. There's neuroinflammation, which is a very hot area right now. It's very, very exciting. TSPO, there have been many used over the years that have not made it into clinical development, mainly because there's a genetic isoform such that only half the patients get a good signal with these tracers. There's still more work being done on those. There's astrocytes markers, MAOB ligands for activated astrocytes. There's two. There's an F18 deprenyl analog, and also this SMBT1 from Japan. There's more work going into synaptic vesicle density markers, SV2A. We heard a little bit about this yesterday. The classic is UCBJ, C11 compound, and now there's an F18 version called SynVest-T in clinical research. The holy grail has been an alpha-synuclein marker. There are several candidates. None are clearly validated at this time. Some look good for MSA, but none have really shown a tremendous amount of progress in Parkinson's disease. This is a very, very difficult disease. Alpha-synuclein is a complicated molecule with lots of different folds up into lots of different ways. And then recently we've gotten into TDP-43. We heard earlier about late disease, and half of FTDs are actually based on TDP-43, and so there's a great interest in coming up with TDP-43 markers. And at ADPD, we saw one of the first ones from AC Immune that looks promising. It's not yet deeply in clinical trials. It's very, very early, but I think that things are moving, and I think as we go further on, if you wait for a few years, you'll see more tracers, more ability to differentiate diseases to affect both diagnosis, characterization, and prognostics. So this is just one example of a tau tracer that we're using with 2620 that has very low uptake in a normal brain. What we see is that in 4R tauopathies, you see a dramatic uptake in the midbrain structures and basal ganglia. In CBD, you can see something similar, also with some cortical structures, and then in AD, obviously, quite different again. So this is a particular 4R tracer that's in phase 3 trials. Dr. Sabah is actually running one of the trials in which we can see tau, both the 3R, 4R of Alzheimer's disease and also the 4R tau of PSP and CBD. This is a deprenyl analog, which is used for astrocytes, and there's data from the Karolinska and others showing that there's an astrocytic burst just prior to the onset of tau deposition. And here's the first data that we have out of Munich showing that patients who are A plus T plus show a dramatic increase in white matter astrocyte deposition as opposed to the A minus T minus healthy controls. So this is coming. We're pursuing this. It's been in several hundred patients now, and we're quite excited not just about Alzheimer's disease, but obviously this is a downstream marker of all sorts of cause of neuroinflammation. It's been used in epilepsy, in traumatic brain disorders we're looking at in a number of different diseases. And that's just an image. So in summary, I'd just like to say that the AD is a major unmet need in the world today and is projected to grow. AD represents 60 to 70% of all dementias. Early diagnosis is important but difficult given the heterogeneity of presentation. New disease-modifying drugs are available. Therapy requires the proof of brain amyloid and probably tracking of amyloid removal. PET quantification is validated and is the best way to monitor therapy. And many PET imaging for neurodegenerative disease is an active field of research, and many new tracers will become available in the future, and hopefully these new targets and tracers will lead to new therapeutic options. Thank you very much.
Thank you for this fantastic talk, and I like the latest three slides. They were wonderful. So now our next very own Cleveland Clinic Chief Nuclear Imaging. It is my pleasure to introduce Dr. Hidayat Ansari. Dr. Hidayat Ansari is a consultant radiologist and chief of nuclear medicine at the Imaging Institute of Cleveland Clinic Abu Dhabi and medical director of Cleveland Clinic Alliance branch. Prior to his career in UAE, Dr. Ansari worked as a consultant radiologist and a clinical director for the Department of Radiology at the University Hospital of Morecambe Bay NHS Trust in Lancaster, UK. And as a chair of the radiology at Lancashire Cancer Network, So he completed residency fellowship in specialist radiology training at Manchester with PET CT fellowship at the University Hospital Zurich in Switzerland. His area of specialist expertise includes PET CT in nuclear medicine, CT in colonography, and MR and interrography. Please help me applaud Dr. Ansari for also his wonderful pioneering effort to lead the amyloid PET in UAE. We're going to start soon. This is no longer a secret anymore. Okay, thank you.
Thank you. Assalamu alaikum and good morning. Thank you, Hanan, for the kind introduction. Thank you, organizers, for the kind invite. So, without any further ado, I'll start off with my talk. I just want to make sure this will. I have no disclosures. My outline today for you folks is to try and show imaging findings in neurodegenerative disease, discuss various biomarkers, and focus particularly on role of FDG PET because that's something which we are doing all day in and out, and talk about the new isotopes which you're going to bring in very soon, and review some pearls and pitfalls. So, firstly, to talk about FDG. FDG is a fluorodeoxyglucose, which is a kind of bread and butter of PET CT scanners. It is extremely useful for diagnosis of neurodegenerative disorders. FDG is nothing but a glucose analog. What we do is we ask the patients to fast for 4 hours so that it does not compete with the internal glucose, and then we inject them in a way that the internal blood glucose is not more than 140 milligrams per deciliter. The standard dose of FDG we use is about 5 millicuries, and the idea is to get this kind of excellent PET, CT, and fused PET CT images. The patients are instructed not to close the eyes because we do not want to fall into the gap of pitfalls with hypometabolism in occipital lobes and confuse them with the diagnosis of dementia of Lewy body. And if there are any medications, we would like to know that. So the way how we read this is in multiple ways. So we have this fantastic images which we can process both attenuation corrected and non-attenuation corrected images. We can have them in grayscale, we can have them in multicolored images. The idea is to try and lay out these images in multiple formats, in multi-planes, and identify what the cortical matter, gray matter uptake looks like and what the white matter uptake looks like. And we know exactly where there is increased uptake, where there is decreased uptake, and what we are trying to look out for. And the next way how to look at these images is to quantify these images. We have excellent softwares to try and quantify different parts of the brain and try and analyze whether unilateral abnormalities or bilateral abnormalities and take it from there. And the next stage of analysis, what we call as SSPD, stereotactic surface projection displays. So we can do fused PET CT and we can do fused PET MR co-registration. And when we look at this middle row with so that's a stereotactic surface projection, three-dimensional displays, and we can have two-dimensional displays and analyze exactly what the normal brain looks like in this particular patient. And then we have a set of normal database loaded on our computers, firstly through our vendors, and now we're trying to get our own data set loaded. And the idea behind that is when you subtract this with a normal database, does it show a decrease in uptake, and therefore try and get those Z-score values. It is not as easy as it might look, but we have to try and be aware of what are the factors affecting the FDG uptake. FDG uptake may decrease with age, particularly in the frontal lobes. What is not usually affected is the uptake in the cerebellum, basal ganglion, and the sensory-motor cortex. So, but we have some pitfalls, and I'll come to that in a minute. But you can have hypometabolism, for example, in occipital lobes. A straightforward infarct will cause decrease in the uptake, as you can see in this part of the cerebellum on the right side, and gliosis there. So we have to be very careful about these things, try and get the good details about whether the patients have dementia of Lewy body, whether it's a PCA variant of Alzheimer's disease. The same thing applies to patients with cerebellar hypometabolism. This can be seen in patients with infarcts. It can be seen in patients with multisystem atrophy, chronic alcohol abuse, and patients with anti-epileptic medication. So these are things which we do before we start reading our cases. So coming to the dementia imaging pathway, thank you to my previous speakers who have already talked and touched upon this, and I'm going to be reinforcing some facts. So as it happens, when you have patients with suspicion of dementia in your clinics, they have metabolic and psychiatric assessments, and then they have the structural assessments in form of CT, MR, and then usually many months pass by, sometimes years in some of the patients, depending upon which part of the world they are being cared for, and then they may pull in advanced MR techniques, whether it is volumetry, arterial spin labeling, or diffusion tensor imaging, but that usually again comes quite late. And then even further down, when dementia is well established, comes the role of introduction of PET CT imaging, A, because it's not available, and B, that's where people start trying to put this into the diagnostic algorithm. As my previous speakers have already mentioned, this is a big spectrum coming from MCI to Alzheimer's and from vascular dementia to Alzheimer's. So this is what we want to do, is try and get PET CT somewhere in the middle of the spectrum and add value to this patient's care so that we can identify who is the person who needs these disease-modifying drugs and take the modification and of their patient health journey. So very quickly, I'll go through some cases we have done at our institution in different categories. So we have MCI, mild cognitive impairment. Approximately on an annual basis, 10 to 15% of these patients progress to Alzheimer's dementia. When you do MR in these patients, they may not demonstrate anything. In some cases, volumetry may be useful. SPECT and PET is useful because it demonstrates hypoperfusion and hypometabolism in both a bitemporal and biparietal distribution, and I'll go through some cases. So if you see this patient here, you can see that there is the asymmetrical decrease uptake in relation to the temporal lobe and parietal lobe there, and this was a patient with a mild cognitive impairment. Clearly, FDG PET is more sensitive and superior to SPECT and MR studies, but as we know, we have even better tracers with amyloid and tau PET, which we are trying to get into the market as soon as possible. So more on another couple of examples. If you see this patient who had cognitive decline and an MMS score of 22, you can see that possibly there is some asymmetrical decrease in cortical atrophy and in the cortex there, and this is a parasagittal image probably affecting the region of the precuneus. So if you look at the PET image, it shows bitemporal and biparietal decrease in uptake around there, paracentral decrease in both sides, that side. And then if you go to the Z-score images, it shows that there is indeed a decrease uptake in that region. And then we have the advantage of doing quantification of these images, and that's how we are more precise in trying to give a diagnosis. And this shows that there is asymmetrical uptake in precuneus, which is probably one of the earliest signs of mild cognitive impairment. Another case trying to demonstrate the same impact, you can see that there is decreased temporoparietal uptake, particularly on the left side. This is red is normal, green and blues are decreased uptake there. So if you move on to the SSPD images, it confirms the same thing. The right side is pretty much normal. The left side shows asymmetrical decrease uptake in the temporoparietal distribution confirmed with Z-score maps. Moving on to Alzheimer's disease, as you folks know, it's the commonest cause of dementia is almost 80% of the patients with the pathological hallmark of beta amyloid plaques and neurofibrillary tangles. MRI may show focal atrophy, but again, we have used FDG enough to show that this is a good enough biomarker if you do not have amyloid, but amyloid is more superior and that will take over the place. In this particular landscape, I'm not sure how many of our patients can all benefit from amyloid, so I think this will be parallel isotopes which we will be using for a long time. In FDG, it shows hypometabolism clearly in the temporoparietal distribution, and it can be asymmetrical, it can be unilateral, and I'll go through with some examples very soon. So this is a patient with cognitive decline and a slum score of 8 and mini mental status assessment of 16/30. And this is the image. Very clearly, there is bilateral asymmetrical distribution. This red is normal, green and blue is abnormal, decrease uptake. And these SSPD images show bilateral decrease in temporoparietal distribution. And clearly, it is very useful in trying to quantify dementia in these kind of patients. Next slide, this shows more of a quantification. And AI-generated images, you can see that this is how it shows us exactly where there is decreased uptake, and this shows abnormal decrease in precuneus region and the posterior cingulate gyrus, which is pretty much the hallmark of decrease in these patients with Alzheimer's dementia. Like Dr. Dogar mentioned, we'd go into a spectrum. We can have logopenic Alzheimer's dementia, and this is a patient who had, again, bilateral temporoparietal distribution, but at the same time, you can see it is more posterior temporal, and this patient had clinical features of logopenic dementia. The next spectrum after this is the same patient. The next spectrum is frontotemporal dementia. You can see this frontotemporal dementia is, I understand, a big group of patients. Again, the second commonest cause of dementia, and it comes up with patients who have behavioral issues with impulsive disinhibition and all kinds of emotional issues there. So in MRI, you can have atrophy affecting the frontal lobes and the anterior temporal lobes. And we have different variants. We have behavioral variant, non-fluent, and semantic dementia. I'll go through some example. This is a patient with frontotemporal dementia. You can see clearly decreased uptake in the frontal lobes and anterior temporal lobe, and the CT does not show any significant changes. Perhaps there's some prominence of sulci there, but allowing for that, there is no other changes. But this PET and fused PET CT images very elegantly demonstrates the advantage of trying to diagnose frontotemporal dementia in this patient. This is an example of a patient with slum score of 5. You can see that there is a clear decreased uptake in relation to the frontal lobes there. And So we have a standard practice and template. Our idea is to try and analyze attenuation corrected images, non-attenuation corrected images. Then we jump into the SSPDs and the Z-score images, and then we have this AI generated maps and report, which we kind of utilize in our as a screenshot for our physicians. They can try and interact with the patients where necessary. This is another patient with behavioral subtype. Again, you can see that there is decreased uptake in relation to the frontal lobes. And the AI mapping shows that there is prefrontal decreased uptake more so on the right side. This is a patient with non-fluent aphasia. You can again see that there is decrease here, more so in the posterior frontal lobe in kind of pre-central area around the sensory motor cortex. Then the next bucket comes to the vascular dementia. This is again a very big group of dementia, third most commonest cause. And you can see that in some of these vasculitis, the PET may not be necessary, as CT or MR may do the information. But again, I'll show you with some examples how PET adds value. You can see that there is decreased uptake. The CT shows gliosis, and that's a fused PET CT image. Some more examples here. You can see a PET CT image of decreased uptake on the right side, loss of cortical gray white matter differentiation, and then when you do the MR in this patient, you have a subacute infarct in that patient. And this is another example of watershed territory ischemia, and this is a patient with chronic ischemia and porencephalic cyst. The next group, the dementia of Lewy body. This is again a classic triad with cognitive decline, visual hallucinations, and Parkinsonism. And my colleague again talked about the cingulate island sign. We have decreased temporoparietal decreased uptake and preservation of uptake around the precuneus, which gives the cingulate island sign. So let's look at this particular case. We have a clear decrease in bilateral temporoparietal distribution, and then when we have the axial images, you can see that the precuneus and paracentral gyrus is not involved, and the lateral occipital lobes are involved. This was a patient with dementia of Lewy body, and these are the quantification images of the same patient showing the paracentral volume loss. So an example to show that MR may not be useful in these patients with Parkinsonian dementia. So when we look at the the SPECT image, this is the TRODAT scan which we do. It shows the comma sign has disappeared, and instead we have a full stop sign with uptake in the caudate nucleus and loss of uptake in the putamen. And then we can do, this is how the normal would look like, and then we can do AMI-BG scan to look at cardiac denervation and autonomic symptoms, but at the same time we can also pull in a DOPA scan. This is something which we have locally available in UAE. F18 DOPA very clearly and very elegantly demonstrates the entire spectrum of the substantia nigra with the normal uptake in this particular patient. And the way how it works is the mechanism is through binding of the dopamine receptors. This is also used for non-Parkinsonism in cases of brain tumors. So let me very quickly go through the other neurodegenerative disorders we have been able to characterize. For example, corticobacillar degeneration. Again, we have features of patients with asymmetrical sensory motor decreased uptake. You can see the right frontal lobe is decreased. The basal ganglion with eye of faith is decreased compared to the left side. And this is how these patients present. And when we do the volumetric mapping and SSPDs, we can come up to that conclusion with decreased uptake in the frontal lobes. Again, the pointer showing the same, and the decreased quantification leading to same. The MRI does not show or add any value in this case, but a DAT scan shows again there's a loss of uptake in the putamen. This is going into the spectrum of Parkinsonian dementias. We have the similar case with posterior cerebral atrophy, in which patients present with complex visual symptoms and dramatic decline in their visual association skills. You can see that this patient has asymmetrical decrease uptake in the left occipital lobe. So the lateral visual occipital association cortex is usually involved in this patient, and we can be able to support the clinical diagnosis of PCA in these patients. The other one is clearly the PSP. It affects the brainstem and the frontal lobes, and you can see some examples here where you have asymmetrical decrease uptake in the frontal lobe, there is decrease uptake in the brainstem, and this was a patient with PSP, and they have some features on the MR as well with flattening of that angle there. Right, so this is the PSP which we talked about with again. So in summary, we can analyze multiple cases with dementia and map it accordingly. We can look at whether the patient has a Alzheimer's dementia pattern or a Lewy body dementia pattern or frontotemporal dementia pattern. This is what we can add, and we can do the same thing for Parkinsonian dementias, whether it's a patient with PD, multisystem atrophy, CBD, or PSP. Amyloid imaging, as my previous colleague has talked about, is excellent. It is to come, and it's probably going to replace a lot. As Hanan said, it's no longer a secret. Next week, we're trying to do the first time in Abu Dhabi with about 5 cases. And once that is done, I think there will be a lot of traction to move forward with what is right for our patients. And this is from my previous practice with a patient with negative amyloid scan. And this is a patient from literature with a positive amyloid scan. So pearls and pitfalls is important because it's extremely necessary to assess the clinical information and the structural imaging. It is important to rule out whether it is tumors, extraaxial collections, or chronic and volume loss. And along with that, we have to watch out for any false positives. With the advantage of having AI comes the disadvantage of having artifacts. So you have to be very careful that we are not overcalling things when we start reading these cases. And I will go through some examples. Very first thing is these patients cannot lie still because they have problem. That's why they are here for their assessment. And that can cause what we call the movement and misregistration artifacts. It almost looks like there is abnormal decrease uptake in this side, whereas the CT looks normal. And then when we look at the fused image, the reason why you are having that is because of this misregistration artifact. So we have the ability to go back to the non-attenuation corrected data, which shows that there is symmetrical uptake. So this is important for the readers. It's also important, as I said, to exclude the structural artifacts and problems, and we can see in this patient you have a big photopenic defect. So is this decreased uptake? No, it's not. It's actually it's an arachnoid cyst in this particular patient posteriorly, and we have one more in the left temporal fossa on the left of that image, and we can have other post-treatment related cystic changes and encephalomalacia. So we have to be very cognizant about these findings can happen. Artifacts can sometimes happen due to volume loss and the way how these images are reconstructed. So this fused image just shows that there is decreased uptake in this particular patient in the anterior cingulate gyrus. But when you look at the non-fused separate images and reconstructed in a different pattern, you can see that there's clearly volume loss, and that's causing this artifact in that particular patient. Artifacts can also happen due to mass lesions. So, example, these post-processed image shows that there is an abnormality or an abnormal Z-score there, and a fused image also shows the same. But if you look at the detail, there is an abnormal mass lesion in the anterior cranial fossa, and this was a meningioma. So, and I think I have one more example. You can see that on the raw data, it shows there is photopenic change or a decrease uptake in the left frontal lobe. But if you look at the CT, there's an extraaxial high density lesion. This was also a meningioma. So this is extremely important. So I hope in summary I've tried to show you what added value FDG has added to these patients with dementia. We do this routinely at Cleveland Clinic, and we're trying to get new isotopes so that we can armor ourselves to try and support our patients with as many biomarkers we can do in routine clinical practice. So within that, I would like to summarize by saying PET-CT has an extremely important role in the neurodegenerative disorders, and we can separate them based on their pattern of uptake. The role of novel isotopes is well established and is yet to come to UAE, but and particularly in Abu Dhabi, we're trying to get. We've been working for a very long time, but there are logistical issues, supply issues, and vendor-related issues. But I hope very soon we are going to overcome all of these. I hope I have explained the interesting pitfalls and pearls. And with that, I would like to close my talk. Thank you. happy to take. That's fine.
Thank you.
Thank you.
So I apologize. Yeah, it's a shame we don't have enough time for talking, but I would suggest that we really meet the speakers in the coffee break and ask all your questions. So then, very quickly, we're very honored today to have a virtual. It's a video, right? It's to have a video of a presentation by Dr. Mike Weiner. Mike Weiner is a professor emeritus from UCSF, and I think most of us know him as really the father of ADNI. ADNI is the largest multi-center populational study looking at biomarkers in Alzheimer's disease, and it's been going on for over 16 years now. We're in ADNI 4. We're at the beginning of the fourth 5-year grant proposal time for him. So it's really amazing what he's done, and it's set up ADNI sessions all over the world now. And so I think that he'd just like to talk about the progress that's being made within ADNI. So thank you.
Well, thank you very much. It's really a pleasure to talk to the Middle East Alzheimer's conference. I really wish I could be there, and maybe I'll be able to attend future meetings. Today, I'm going to be talking about the Alzheimer's Disease Neuroimaging Initiative and what we've learned. The Alzheimer's Disease Neuroimaging Initiative, or ADNI, is now, in fact, 21 years old. It was started in 2004. These are my disclosures. And really, the story of our grant, ADNI, is the story of the progress made in Alzheimer's disease over the past 20 years. 20 years ago, we had no way really to diagnose Alzheimer's disease pathology. It was a clinical diagnosis with ruling out other causes. There were no treatments slowing the progression of Alzheimer's disease. And we had a need to plan out disease-modifying trials. We needed to figure out how to detect and monitor the disease and its pathology. And in 2001, all knowledge about biomarker performance really came from single-center studies, each focused on its own modality. For example, my lab was working on structural MRI. Other people were doing FDG PET, and other groups were doing CSF. But there was no comprehensive study using all of the available biomarkers. We also needed to standardize measurements for multi-site longitudinal studies, that is, for clinical trials. And we needed to compare the performance of the different biomarkers to correlate them with cognitive decline. And this is what really led to ADNI. So the overall vision and goals of ADNI were first and primarily to validate biomarkers for Alzheimer's disease clinical trials. Secondly, to share all our data immediately without any embargo to the entire world, to the entire scientific community, and to enable development of diagnostic tests and effective treatments. And from a very big picture, ADNI really was a new way of thinking between the interaction between academics, biotech, and pharma and government, leading to the development of diagnostics and therapeutics. We all know that we in our university centers acquire knowledge, but the actual treatments and diagnostic tests that are commercialized have to be done by the private sector. So there was a need for better interactions between the academic groups and the private groups, and ADNI helped create a new model for public-private partnerships. And this lists some of the other groups that have other projects which have essentially taken the ADNI model of public-private partnerships, the PPMI study, the Dominantly Inherited Alzheimer's Network, the LEAD study, all FTD. And there actually were a whole series of ADNI projects all around the world, in Australia, Korea, Japan, etc. Here are some of the studies that have used this kind of model. And here's a world map showing that ADNI's in Europe and Australia and Japan and so forth, Korea. And these are the companies which are currently involved with ADNI and serve on our private partner scientific.
One of the brilliant innovations of ADNI was bridging together public and partnership companies and government and academics in a way to collect data that was available to everyone. That seemed like a crazy dream, but it actually worked out. It is the go-to data sets and sample set for all kinds of scientific explorations that we do. that's also become a role model on several fronts. ADNI has provided a common data source, a common language, a collaborative approach to research, to accelerate drug development, to understand the disease better, to develop biomarkers for diagnosis and tracking progression. It continues to drive the field and be the tip of the spear of Alzheimer's research.
So ADNI is a naturalistic study of the Alzheimer's disease progression, simulating a clinical trial. Well over 2,500 participants have now been enrolled at 60 sites across the country and followed for many years. And all the data is in a public database shown here. There's no embargo of the data, and now there's more than 7,000, probably 7,500 publications from ADNI data because we've shared it. The participant procedures are shown on the next few slides. I've been a participant in the study as well as directing the study since it began. So we have cognitive tests, we have blood and genetics, we do lumbar punctures, we do MRIs of all types, FDG PET, amyloid PET, tau PET, and it's been a very successful study. There's been a huge amount of data that's been acquired. The problem with ADNI has been a lack of diversity. And initially when in ADNI 1, you could see that this shows the percentage of people who are white, and this shows the people of color who were enrolled in ADNI 1, ADNI 2, and ADNI 3. And this shows the census of the United States, demonstrating that the census shows that the white population is about maybe 65% of the population. So ADNI has definitely been overrepresenting well-educated whites and underrepresenting people who are Asian or Black or Latino. So to address that, we formed the Diversity Task Force with Ozio Moncaco and Monica Rivera Mint. And basically, during ADNI 3, they greatly increased the enrollments of underrepresented people, so that 25% of the new enrollments were from underrepresented populations. And you can see here that finally ADNI 3, the percentage of whites is approximately that in the census. So that was took a lot of effort, and we've carried forward that approach in ADNI 4. But the big problem with ADNI continues to be that the socioeconomic status of ADNI participants is high. And this is not just for ADNI. This is the vast majority of clinical research and clinical trials have this problem. So if you look at the United States population census data, you see that 32% have a high school diploma and 35% have a high school diploma or less. Okay, so we have essentially 67% of the population really has a high school, or over 65 has a high school education or less. Whereas in ADNI, you can see that high school and high school diploma or less is 13% of the population. So ADNI, in other words, ADNI greatly over-enrolls people with college education. 19% have some college, 25% have a bachelor's degree, and 43% have more than a bachelor's degree, master's and PhD and MD degrees. The people who volunteer to get involved in this kind of arduous research tend to be people who go to academic centers for their care. They're more knowledgeable about what research, why research is important, and they have the time and the resources to participate in research. So we need to address that. I'm going to talk about that in a couple of minutes, how we've addressed that issue. So what are the contributions of ADNI? How has ADNI really made a difference to the field in specifics? I mean, not just say all these publications. First of all, there are now in the United States 2 FDA-approved CSF diagnostic tests. That is, you do a lumbar puncture, you get cerebrospinal fluid, it's analyzed for amyloid and tau, and it's a diagnostic test for Alzheimer's disease pathology. And there are two kits, Fuji-Bio and Roche, two platforms that are FDA approved, and they did the large part of their validation for FDA with ADNI. Secondly, the PET tracers, which are most used today for amyloid, for beta-Peer, and for tau Sapir, both from the Avid Pharmaceuticals, which was acquired by Lilly. Those PET scans, they're FDA approved now, and ADNI data was used for their FDA approval. Thirdly, there were early clinical trials which failed, were designed using ADNI data, bapineuzumab, solanezumab, and crenezumab. But then we had some successful trials. Aducanumab was a plus-minus successful trial, had its problems, was ultimately FDA approved, but aducanumab was not approved for Medicare in the United States and has not been approved by other countries for reimbursement. In contrast, both lecanemab, which is Eisai's monoclonal antibody, which removes amyloid plaques, and donanemab, which is Lilly's monoclonal antibody, which removes amyloid plaques. Both of these are now approved by FDA and approved by the Center for Medicare Services. So they're reimbursed. And those companies used ADNI data to design their trials. And you're going to hear about that more in a minute. Furthermore, there are now two major prevention trials going forward. One is called AHEAD, and it uses lecanemab. And the other is Trailblazer ALZ 3, which is Lilly, which uses donanemab. And these prevention trials are clinical randomized controlled trials on seniors who are cognitively normal, but who have evidence of abnormal levels of amyloid in their brain. They have preclinical Alzheimer's disease pathology. And the goal of these prevention trials is to determine if amyloid plaque removal with the monoclonal antibodies will delay onset of the symptoms of mild-cognitive impairment and the problems with dementia. And we expect that some results from Trailblazer ALZ 3 may come out as soon as the end of this year, 2025. And maybe 6 or 9 months from now, we may know the results of that. So in the next few minutes, you're going to hear from the companies of these diagnostic tests and the companies from Eisai and Lilly about how important ADNI was to their work.
At Avid Radiopharmaceuticals, we collaborated closely with ADNI initially to understand how amyloid imaging could work to identify patients and track patients longitudinally over time in clinical trials. If not for that advance, I think we still wouldn't have effective amyloid lowering mechanisms. It's also enabled subsequent generations of biomarkers. If we didn't have amyloid imaging in ADNI, we would have been able to do the tau scans in ADNI. If we didn't have amyloid and tau, we would have been able to develop the blood biomarkers. When the science started to break in amyloid imaging, then that unlocked all of these subsequent advances that ultimately led to clinical trials that have now shown effective therapies for Alzheimer's disease.
ADNI was a very important part of Fuji Radio's journey to achieve the first FDA authorization for our CSF amyloid ratio test. Without ADNI, this would have set us back years.
The ADNI study, including the samples and the data that's publicly available, have been absolutely instrumental in Roche developing this assay, bringing it to the market and getting regulatory approval. Without ADNI, this would have been much, much harder, would have taken much longer, and would have cost a lot more money in order to get the assay approved.
ADNI was very important in terms of the successful development and approval of lecanemab, both in terms of the phase 2 proof of concept study and the phase 3 confirmatory study, by helping us understand the right patient population, the right dose, and the right outcomes to ensure that we had a successful clinical development program. This meant that our phase 3 study was optimally designed to confirm the efficacy and safety of lecanemab.
The clinical trials for donanemab
built on data, including data from ADNI, used amyloid imaging to select patients for therapy, and used tau scans to stratify patients. That was based on data from ADNI. And we did something that I think was really unique and remarkable, which is we stopped treatment with the amyloid-lowering drug once the plaques were clear, because we knew about the very slow rate of accumulation or reaccumulation of amyloid plaques in patients. Everybody in the Alzheimer's field would agree that there's no chance that we could be where we are today with the development of advanced therapeutics, with the development of new biomarkers for diagnosing and tracking the disease. We wouldn't have been able to get where we are today if not for the data that was built on the foundation from ADNI. Without ADNI, treatments would be delayed. Patients would have to wait further, not only for current treatments, but future treatments. And ADNI is the cornerstone of this noble endeavor.
Well, so we believe that ADNI has really made a substantial contribution thanks to our funding from the National Institute of Aging over the last 21 years. And we are now just entering the fourth year of so-called ADNI 4, which will continue to run until 2028. But we don't want to rest on our laurels. We want ADNI to really help the field. And to do that, we have to really be honest about what our limitations are and then think to the future for how clinical trials can be improved. So the major limitations of ADNI are summarized here. First of all, ADNI simulates a clinical trial focusing on biomarkers. It is not an epidemiologic study. Clearly, the ADNI population does not truly represent the entire United States. Overall, that is a big limitation. And that's because when clinical trials are done, there's a lot of exclusions. People with moderate to severe cerebrovascular disease and Lewy body disease, and people with seizures and Parkinson's disease, people who have severe cancer and heart failure, they're all people who are on substance abuse, people who are crazy with schizophrenia or severely depressed people. They're all excluded. So in summary, we have a generalizability problem. The findings are really not generalizable to the U.S. population because of the exclusions and also because up until fairly recently, ADNI participants have been largely well-educated white people. The second limitation is that the technology continues to improve. And ADNI, we decided at the beginning that we would try to keep up with technological improvements. So the MRI scanners, when we started, were 1.5 Tesla scanners. Now they're 3 Tesla scanners. And as I'm sure you all know, the scanners continue to improve. The instrumentation improves, the software improves, the images are getting better and better. And we've chosen to keep up with that. So what that means is that as patients are followed longitudinally from one wave of ADNI to the next, ADNI 1, ADNI 2, ADNI 3, ADNI 4, the scanners change, even though the patients sometimes continue longitudinally through that. And that makes the data a little more difficult to harmonize. There's a patient burden. ADNI collects a great deal of data, which is good, but people are always asking us, hey, can you collect more information about diet? Can you collect information about exercise? Can you collect information about air pollution? I mean, everybody's got their thing that they'd like us to measure, and we can't do it all. So that's been a limitation. And finally, the ADNI data set is massive. It's huge. And because we've had all these different ways of ADNI with different collections, it's getting more and more difficult for people to figure out. We're working on that, trying to create improvements with our website, but it's a limitation. So what will be the Alzheimer's clinical trials of the future, and how can ADNI help address the issues of what's coming, okay? Well, in my opinion, there's going to be more and more emphasis on prevention, especially if the Lilly donanemab Trailblazer 3 demonstrates that removal of amyloid plaques in asymptomatic people will postpone the development of mild cognitive impairment. That's going to be huge. It's going to mean that many thousands, tens of thousands, potentially even millions of seniors who are amyloid positive but asymptomatic would benefit from essentially some kind of prevention treatment. And I think that infusion of monoclonal antibodies is a good start, but we've got to make it easier for people. And already they're working on subcutaneous injections of monoclonal antibodies, and there's work going on with small molecules. Secondly, we know that Alzheimer's is more than just, we know that dementia is caused by more than just amyloid and tau. There's alpha-synuclein that's associated with Lewy body disease and Parkinson's disease and multiple system atrophy. There's TDP-43, which is associated with ALS in younger people and older people, but also associated with what's so-called late, that is hippocampal atrophy, and a mnemonic syndrome that resembles Alzheimer's disease. We currently don't have good biomarkers in humans, although with alpha-synuclein there is now the so-called seeding assay, which seems to be effective with cerebrospinal fluid, but we don't have any blood tests yet for synuclein. We don't have any blood tests yet for TDP-43. I think we're going to need a more of a real-world, community-engaged research approach, and a reduced need for the scans, more at-home assessments using the electronic health record, and more use of AI. And in ADNI, we are launching the ADNI for All project. The ADNI for All project aims to increase generalizability by recruiting 100 to 200 low socioeconomic status participants through a partnership with the Clinical Director Network, which is a network of primary care federally qualified health clinics serving those who don't have health insurance. It's basically clinics that take care of poor people in the United States. And we're going to have a truncated ID assessment battery. We're going to get blood for biomarkers, and we're going to do MRI, amyloid, and tau PET scans. And this ID for All pilot is going to take place over the next few years, and we think this will increase the generalizability, and maybe will for the ADNI 5, we will take advantage of this and do this on a much bigger national scale. Finally, I believe that in the future, we're going to be using a lot of artificial intelligence assisted conversational voice robots for assessment. Currently, clinical trials, currently all clinical work and neuropsychological testings are really done by trained clinicians and staff, and that's costly. You have to pay people to do this. There's the need to train people, and there's a lot of between rater variability. There's been an effort to create online assessments, but they've really had limited acceptance. The chatbot GPT voice robot has demonstrated the power of AI, and our team at UCSF is now developing and actually has working a platform for AI-assisted conversational voice robots for a variety of assessments. For example, to obtain informed consent and assess the competence of whether somebody understands the informed consent form. And specifically, we're working on a voice clinical dementia rating scale in collaboration with our colleagues at WashU, John Morris. And then there will be voice measurements of activities of daily living, voice memory testing, voice testing of executive function. I believe that AI-assisted voice bots are going to start to dominate in clinical research, and then they're going to get into the clinic, and they're going to help physicians make diagnoses and provide a lot more information, including electronic health record data. So I think that's where the future is going. So in summary, ADNI has had a big impact. We've created a new model of partnerships, more than 7,000 publications, leading to the approval of the PET tracers, the CSF assays, and we facilitated the design of trials of lecanemab and donanemab, leading to their approval. And we've demonstrated that we can improve our generalizability by recruiting underrepresented people, and our ADNI for All pilot will increase generalizability. I think I've run out of time. The remainder of this is just demonstrating a listing of all of the people who are involved in this project. And I just thank everybody in the audience who's been involved in that. If anybody has any questions, You could always email me at michael.miner@ucsf.edu. Thank you very much for inviting me to speak at your conference, and I wish you all well.
Thank you so much, Dr. Weiner. We're so honored to have you here on board. And our next speaker is Dr. Mohammed Suhair. It is my honor to present Dr. Mohammed, whom I know virtually, and we're trying to collaborate and looking for a great opportunity. Professor Mohammed Suhair has over 20 years of experience in brain mapping and cognitive neuroscience. His work revolves around the use of neuroimaging techniques to study brain function in individuals with neurological and mental deficits. He holds a PhD in brain mapping with functional MRI from Joseph Fourier University in France, and has worked at Geneva University Hospital, Switzerland, and the Wellcome Center for Human Neuroimaging at UCL. UK since 2021. He has been at the Biomedical Engineering Department at Khalifa University, UAE. He serves as an editor-in-chief of the International Journal of Imaging System and Technology, published by Wiley, and had handling editor at Imaging Neuroscience, published by MIT. Please help me welcome Dr. Suhair.
Thank you very much, Dr. Hanan, for this kind introduction. Good morning, everyone. So my talk is about, the process of aging from a different perspective. So it's from the brain mapping perspective. That's the tool that the community of cognitive neuroscience and cognitive neuroimaging are using, particularly to study this, how the brain function changes with aging. So if I can make this one work, okay, yes, it's working. So as we know, we are trying to study a natural process. This process tries to characterize the evolution not only of the human brain but every system in our body through time. And this process is extremely variable across individuals, very complex, but during the late stage of this process, it's usually associated with poor outcome, a kind of a decline in one ability or multiple abilities. And here I make distinction between a healthy aging process or pathological. I couldn't find like a better definition than the one that is in the website of the WHO. So it's mainly about the individuals, the ability to maintain their function when they age, and anything that deviates from this ability could be a sign of pathological aging. So in that sense, so if there's a deviation from the healthy aging trajectory, one can infer that there's maybe a sign of a disease, and vice versa. So if we see a deviation that we can measure, including with MRI, that could be like a sign or a marker of this type of diseases. Basically, this evolution over time is extremely complex. So here I'm showing an example of someone who has like 42 years old, and someone has 82, and there's clearly some very clear differences even with the naked eye in the structure of both subjects. The question is always, how this happens, and when these changes will have an impact on the behavior of subjects. I think this is a very important question. Excuse me. And also where, so why the different brain parts age in a different way according to different profiles of aging in these regions. And in fact, this spatial heterogeneity will help us differentiate between different types of disease-related aging. This association is complex, and what we are try to do in brain mapping is to express this association as an aging-related brain behavior relationship. And this relationship is, of course, extremely complex, it's dynamic, it's nonlinear, and above all, it's highly variable across subjects. And we'd like to try to make a sense of these associations between change in the brain, excuse me, and change in the behavior. In fact, not only that, we know also that although we can associate a change in the brain with a change in the behavior, but also we know that a change in the behavior, whether it's a spontaneous change or therapy-induced, will also cause a change in the brain structure. And we have this complex association that we have to map with, for example, MRI. So here with my colleague, Kathy Price, we try to take a more pragmatic approach to this issue. Because if we try to identify a clearly deterministic causal associations between change in the brain and change in the behavior, it's extremely complex. So what we do here is try to express it as a probabilistic causality. And we can simplify it in a very simple rule that if we identify, let's say, a biomarker, it could be an MRI-based marker, and this marker has to raise the probability of seeing a deficit Y. So this association between X, a biomarker, and Y, a change in behavior, can be expressed as a probabilistic association. And we try to map this association with different types of MRI acquisitions. So basically, we try to associate the left side, the imaging part, and here I'll focus mainly on the brain structure and brain function. But of course, MRI can offer a wide range of modalities that can provide us with a kind of multifaceted understanding of these associations. And on the right side, we have the okay, no, let's do this one like this. No, sorry. Anyway, so the right side we have the different behavioral measures that we can do. They can be measures during a scanner, for example, during fMRI. It could be outside scanner, and also, like I think there's also an increase now to try to associate these brain markers with measurements that are collected in the natural environment, like with during this remote health monitoring device that we have in subjects. With smart wearables, and this will provide a much richer characterization of the behavior of subject in a more naturalistic ecological framework. So let me start very briefly with structural MRI. So this is a very brief overview. I think my previous talks have already touched upon this different changes, in particular for the atrophy in different parts of the brain. And in fact, this spatial heterogeneity again help us differentiate between different types of pathological aging. So whether in terms of atrophy or like enlargement of the ventricles, or the high occurrence of some of brain abnormalities, whether they are hyperplasticity white matter or like macrobleeds that we see also increasingly with age. And idea is to try to associate these changes with behavior. We did with my colleagues using the PLORAS database from UCL. We tried to estimate what happens if this aging process in this population also are, let's say, suffering from stroke. Because we know that stroke may accelerate the rate of atrophy in the subject. So if we take from a baseline of around 0.3%, of course, the estimation varies across studies. So around 0.3% per year in terms of atrophy rate, global atrophy rate. And if you do it in stroke survivors, you can see that the rate almost is 3 times the natural or the normal rate in the subject. Of course, it's a little bit lower than for some patient with AD. But this again shows that if you have an additional suffering from an additional disease, this have like a major impact on the rate of atrophy in your brain. This is just an example of another study from Pagel and Olds. You can see that within 1 year period, you can see the significant quantifiable measures in terms of change in cortical thickness and healthy compared to Alzheimer disease. For functional MRI, I think there's a lot of studies that show some differences in how the brain, process information when we age. So whether using like a task-based fMRI, so this like the patient or the subject is laying inside the scanner and they are asked to do a task, okay? Or they're like doing a resting state, which is like a new protocol where the subject is just lying down in the scanner, and we can look for statistical association between the regions during the whole acquisition. And if you look at these changes, we have very significant or major changes in the brain, in particular what we call the default mode network, in elderly subjects. We also have seen different types of measures that these are based on graph theory measures that we can try to summarize the complex fMRI information to one score. And one of these measures are related to segregation. So we observe that when we age, the segregation of different networks is reduced. So there could be like a sign of less maybe efficiency in terms of processing, or the reliance on more compensatory activations in the brain. These are some typical effects that we also observe, in particular the reduced hemispheric dominance in some tasks in subject when we age, the question of the shift from posterior to more anterior activations in some tasks, and also the over-activations in many regions, in particular from domain general regions, that maybe the patient, when they age, they try to rely more so they can deliver the same performance. This is an example that we did with my colleague, Claudine Habak. And it's an example we just like provided, a very simple task. We show the subject a Gabor patch with different spatial frequencies, and they have like to do a very simple orientation judgment between the different stimuli. And the stimuli are presented either like horizontally or vertically. And if you look at activation, this very simple task, we see like a very significant interaction with age in the ventral part of the ACC. And there are many studies that show this type of effects. Also recently we showed a difference in the ventral part of the precuneus in subjects that are old compared to young. And not only with task-based fMRI, but also with resting state fMRI. There's like a paper that published like, I think a few days ago, and they showed like a reduction in segregation, infection rate segregation. That could be like a biomarker for any task that relies on memory phase and performance. I think if you look at this field of brain mapping with functional MRI, there's a lot of studies that show like significant difference, in fact, everywhere in the brain. And the question is how to make this significant differences as a biomarker that could be clinically relevant. Because if you look at the clinical practice, the majority of indices are based on structural MRI. I'm not aware of any functional MRI-based index that has been now being used to characterize, for example, AD or other types of dementia. I think this is the reason is that, of course, we are dealing with very complex associations when it comes to the brain function when we age. Also, the majority of studies are relying on cross-sectional designs, and this may limit our ability to provide causal associations between these effects. Also, the one aspect is that many of the studies rely on group comparisons. So I try to compare an average in one group compared to another group. And thus, it's very hard then to go back to the individual subjects so we can make like personalized predictions. And last but not least is also the lack of normative imaging, in particular for functional MRI, so that we can differentiate between a healthy aging process and a pathological aging process. And the whole, of course, purpose is try to derive this type of MRI based on biomarkers for either diagnostic or prognostic purposes. Let me now show you some examples of some emerging, let's say, questions that we see in brain mapping currently. Let me start with this one about the possibility to derive or create a kind of brain charts. The same thing as we have, if you have a newborn, where I can take their weights, I can measure the size of their head, I can compare it to some graphs that I have derived from many studies before as normative charts. And I just could create something similar using MRI. So here we're taking like the MRI brain, and we're measuring, like, for example, the volume of the gray matter, the white matter, the whole brain as well, the ventricle size. And we can plot this across age. For example, in the study, they have this evidence accumulated across more than 100,000 MRI scans. And basically, it's provide this brain charts for clinicians, so they can use them to differentiate between a healthy and pathological aging. Not only with MRI scanners like structural MRI, and also recently it has been shown that we can do also this one with resting state functional MRI. And this is like a paper that published like a few days ago on 33,000 individuals with wide range of age, where we can measure all these different metrics based on functional MRI. Another emerging, or I think, interest in the community of brain mapping is try to derive new types of indices. One example is the body index, trying to combine multiple measurements in one single value, and try to use this one as a biomarker for aging, for example. But I believe the most popular one is the brain age or the brain age gap. So this is like the possibility to estimate biological age, which could be different from the chronological age. And we can take the difference between the biological age and the chronological age as a kind of a metric to differentiate between healthy and pathological aging. So, for example, if this difference is very small or negative, we can say that this is a healthy aging process. If it's very positive, that could be a sign of a disease-related, in these patients or these subjects. And it's very simple to do because you can just, with one MRI scanner, and you can use it with the machine learning techniques that we can build, and we can generate this biological age. And it's now being widely used in the field as a global marker or global measure of the aging process and its impacts on brain structure. In fact, now we can even do this assessment of brain age not only with structural MRI but also with functional MRI. Here's like an example from this study. What they try to do is in particular to show the usefulness of characterizing or estimating this brain age gap, and try to relate this to some genomic formations and even for drug repurposing. I think this is like a really fascinating study that showed the potential of this type of measurement and what could be the application for how we design for some clinical trials. In the right side, what I would like to highlight here is that this brain age gap, if you look at the distribution across many subjects, you can see that it's very sensitive to brain diseases. However, it's not specific to a particular disease, because I can see, say, the same distribution for AD subject compared to someone who has like an OCD or major depression or anxiety and other types of diseases. But the point here is to make is that this is a very sensitive, measure for characterizing the impact of brain on brain structure and function. Let me show very quickly some trends in the field. One of them is, of course, to move to very high or ultra high magnetic fields. So what I showed you before are typically created at 3 Tesla, like the clinical scanner, the default one, the traditional one. This is an image of at 7 Tesla. There's even now a first prototype that can scan human brains at 11.7 Tesla. I'm not sure if everyone would be happy to put their brains inside 11.7 Tesla. But what we gain here is high resolution. So this image here is around 100 micrometer isotopic site. So this is really interesting. And in particular for applications in MR spectroscopy. In fact, we gain a lot when we move to ultra high magnetic fields. On the other side of the spectrum is the emergence of imaging or MRI at ultra low fields. So these are scanners that could be mobile, portable, and that operate at very low field, like 100 millitesla. And the idea is like to bring these scanners to the patient where they are. Because if you passing from the RD data set, but also the example I showed you with the brain chart for 100 subjects, the majority of subjects are from coming from one particular demographics or socioeconomics. And the idea, like if we can deploy this type of portable imaging to rural areas or places that have limited resources, we can collect data from diverse demographics or diverse socioeconomics. This could be like a very interesting way to, have a more representative data sets that we are creating. The next trend, of course, we cannot talk about imaging now without AI. It's now like being used in many aspects of the imaging process, from reconstruction to processing to even trying to identify a kind of data-driven features that could be relevant for the aging process. Of course, this will put put a lot of a burden on our infrastructure in terms of data storage and data processes. Just to give you an idea, based on the image that I'm showing in the left at 100 micrometer isotopic resolution, the case space of that image is around 2 terabytes. So you can imagine the size that you have to need to handle this type of acquisitions. And last but not least is that we need also new cohorts and data sets more representative for the diverse populations. In particular, if we can collect longitudinal data. I think I have 30 seconds, so let me finish with the conclusion. So this is, I think, one of the aspects that we are doing using MRI, in particular for brain mapping, is in particular to understand the exact associations between a pathological aspect of aging on brain function. I showed some earlier in the previous slide, some of the trends. And I think that really the major, I would say, challenge is to translate some of this, in particular function MRI metrics, into something that could be useful for clinicians. I think that's really the biggest challenge that we are facing now in the brain mapping community. And of course, how to explain the wide range of variability between individuals in the aging process. I would like to thank my team and my collaborators, and thank you very much for your attention.
So I think that concludes our session today. Thank you so much for listening. I think it was great. We're blown through our coffee break, but I think that we'll have a 10-minute coffee break. Please try to be prompt, and we'll start again, I guess, at about 10 past 11. So thank you so much.
natural setting. Actually, you are gonna march.
Okay, I'm going to march the slide. Okay.
That's the baseline thing that.
Is the other one supposed to be working?
I'll give you mine.
Then yes.
Topic we cannot discuss.
This is one. Even within the.
It's one, it's previous one,
Yeah.
and this is the recent one.
Yeah.
right?
Yeah.
It's working.
Yes.
The microphone.
Yes. Yeah. No, I can do it. Okay, let's get started for our next session. This will be interesting, unusual format. I want to welcome our guest, Professor Ziad Nasruddin. Do you have a microphone, Professor Ziad? Yeah. So, as you all know, I think probably the most famous of all of us is Professor Ziad Nasruddin. He created the MoCA, the Montreal Cognitive Assessment. And today we're going to have a roundtable discussion to discuss the MoCA, how it's used, how it's relevant, and discuss the new developments around the MoCA with the new validated Espresso MoCA. But Dr. Hanan, you have the Arabic MoCA. Tell us about that in practice and tell us.
Thank you very much and welcome on board. This is a nice topic. Actually, MoCA has Arabic version, but it's not still transcultural. I think it's a very nice, platform to discuss. We have people from the MENA region. I've applied it, but it doesn't work. There's cultural and accent and vocal skill variation in the geography of this region that makes it challenging, and maybe our talk today might.
And then, of course, with that, the education adjusted mean scores for different ages.
So that's it. In addition, so we usually look at the score, but there's something far beyond the score, the vocal skills and the cultural vocal skills, which is cultural specific, in addition to ethnicity. So all of those are hidden covariables that maybe you would like to have help from experts.
And Dr. Ziad, you said it's been translated in over 100
languages.
Yes.
Is it now working? Yeah,
Yes.
yeah, I can hear me. Okay. Yes, it is 100 languages and dialects, and we usually accept to have adaptation for each culture, because some words like are religious, some words are non-religious, some animals are like too frequent in certain cultures.
Absolutely.
Yeah.
Absolutely. Like the rhinoceros one is like in New York. I practice in New York and practice here. They're not comfortable. Some of the old folks, they don't know rhinoceros. So we have, and I know there are versions of animals based on the region. So I put the camel.
In Chinese, for example, they don't have the alphabet, so we don't have letter fluency. So we have to do animal fluent. For example, we had the also the trail, like its letter and number. We have to change that. There's also for the Inuit Aboriginal populations that have different types of animals. Also, it's not like the lion is maybe too frequent in certain countries. So it's
bodies, screening patients in clinical practice for severity. How are you using the MoCA?
Actually, I use MoCA and I convert it. It's not enough because sometimes it overestimate or underestimate the deficiency. So it depends. Overestimate people with low education level, low vocal skills, cultural, and can also underestimate people who are super smart, PhD holder, high cognitive reserves. So I still use different, especially actually to include people in the medication. So we have different way of doing that. We have IADL, the instrumental activity of daily living that we do in geriatric. That helps a lot. So if he's really not that much, is still, for instance, MCI dependent, that has some challenges. So we will go into very personalized. So in order not to have people missing treatment or, I still think there are some gaps here.
So, Dr. Ziad, I know you've had a lot of development, evolution with the MOCA, which became a company and became many things. So, do you want to kind of share us what do we want to look at next? Do you have this one, MOCA, as a cognitive scan? What do you want to look at next?
I just wanted to also share how the MOCA was developed in the beginning. I think it came from the idea where I was practicing as a neurologist in a community center where there was no neuropsychologist, no nurses. I was the first one seeing the patient. After my fellowship, it would take 3-4 hours to do the testing, but in the clinic, in real world, we only had like 15-20 minutes. And I said, okay, I'm going to try be more comprehensive. I take 1 hour and a half instead of 3 hours, but you could see only 3-4 patients a day. So I couldn't, the waiting list was getting too long. So I thought, let me do something that was 10-15 minutes only. And from what I've learned in my fellowship and my colleagues, I think there's a few elements from the neuropsychological test that are important. And I thought, let's do it like a cognitive scan, where you start with the frontal lobes and parietal and temporal, and this is how I built the test as a cognitive scan. We can show you maybe the next slide, where the part of the test is mapping to a different brain area. So it's a good educational tool when we see it with the residents. I think it's fun to see that this is the executive visuospatial, what part of the brain are we looking at, and the same thing for memory and language scales. So maybe we can go to the next
The question, though, it's just not excited to actually talk to you about it. How did you pick these specific domains and these specific tests?
Obviously, in neuropsychology, we want to assess the most domains possible. But the early domains in the test was developed so that we can detect the earliest possible changes in cognition with Alzheimer's. It was developed not necessarily for other conditions. Alzheimer's mostly is the memory that is the most important, and also executive functions becomes afterwards. So it was very strongly weighted, at least for memory. So 10 out of the 30 points are on memory, like orientation, right, plus the 5 words, and 18 points were executive functions. So if you look at abstraction, calculation, there's executive components in them. So it was weighted against for memory and executive functions, some language and visuospatial skills as well. But we didn't look at praxis, for example, because praxis is affected more later in stages in dementia, at least for Alzheimer's. So we thought, let's keep it for the earlier stage possible.
Okay. You wanted to, trails, we kind of already talked about this.
We can jump to the next one.
Okay, cube, memory, we talked about this.
Dysfunction.
Okay.
So this is the first validation study. So the test took 9 years to develop from the concept of the test and to the first validation study that was published in 2005. So it's been 20 years that the test has been validated in 2005. And so, and since then, it has been well accepted and taken up by a lot of countries. And we can, and the validation study, the main point for the MOCA is its sensitivity for early impairment. And we see in those numbers that compared to the MMSE, if we take the same cutoff of 26, the MOCA is able to detect 90% of the patients who have MCI according to Peterson's criteria at that time, compared to only 18% of the patients scored below 26 on the MMSE. So it was mostly for the MCI category or MCI stage that the MOCA has the most use. And so this is what makes it interesting. Is with 2 more minutes, because it takes 10 to 12 minutes, and the MMSE 8 minutes, you're able to detect much more because of the more difficult tasks on the MOCA.
So I'm going to ask you that, is that I've noticed when I do the MOCA, they always do worse on the MOCA than the mini mental. And what's your experience?
Actually, yes. They do, and I do in between of them at the slums because a little bit transcultural than MMSE, and we know that MMSE missed mostly the frontal lobe a little bit, except for the attention test. And 100-7 has been difficult even for some, like even not PhD, I would say like bachelor degrees. They're not good. They say I'm always bad in math, so I found it, the best among all of them, but still use slums to back up the episodic memory. If you have more, if somebody has more episodic memory by subjective, I usually use the slums. If you have so many items on verbal memory, so I kind of do 3 of them when I'm in doubt. But if it's very no-brainer, if some people are so too much demented, I use 1 tool. People who are in arbitrary, yes or no, MCI versus Alzheimer, I do 3 of them, and I send them to OT here in UAE because still these are not validated in UAE. Honestly, they're not. It's just having the Arabic language doesn't mean it is valid. And our colleague in Saudi Arabia also have some challenges. It's not the language alone that make them, there are so many things. I know there's an Omani also version of MSE that have removed the 100-7 on MSE and used the days of the week backward. We're discussing that. But it's very easy too. So everyone, even delirium patient, when the first thing I know the delirium is gone, I have them do the days backward and then the January.
There you go.
So that's a delirium. So this is here. What do you think of a better attention test other than 100-7, which is hard maybe for me as well?
Yeah, I think there's certain parts of the test we can adapt, and I think we have to tailor it to your own clinical practice. Yesterday I was talking to Dr. Suhail, who was telling me that the sentence to repeat أبو نسيب زار جاره واطمأن عن صحته. And this sentence is Abu Nasib is something it was my father-in-law in Lebanon. I was telling him, I didn't know that Abu Nasib is not very frequent here, at least in Saudi Arabia, so you have to adapt certain sentences.
As well. So I have a Syrian accent, so when I speak to Emirati, I say I'm going to speak it in Fusha, which is the official language, because it's common. Because if I speak it in my accent, they cannot repeat it, even in Arabic, different dialects. The same applies to Saudi. So, the other thing is the abstract. So some of the abstract part is also transcultural. How do you make it for the Arabic population?
So
have a different abstract, 2 questions, right? 3 points.
The abstraction, 2 points. The animals, the 5 words, the abstraction, the sentence repetition, these are all changeable. I mean, these are the ones that we adapt because they can vary a lot. The letter fluency also in certain countries, the letter F is not necessarily the most frequent or less frequent, so we have to find equivalent ones. But what's the new development I wanted to mention.
So we go on.
We don't have a lot of time left.
Okay, so where do you want to go? This one?
We can go to this is just to summarize that the MOCA was compared to 53 other content screening tools in the Delphi consensus, and they ranked it number 1 for early detection of Alzheimer's, because it has now 7,000 studies on the MOCA since 2020, and so it has developed a lot of credibility over the years. But I thought we should, the shortcomings of the MOCA was developed for the Espresso. The Espresso is like a pre-screen, and since we have just a couple of minutes left,
do you want to go to this one?
This is the training program that we have, but we can go to the next one again. And this is actually, before we go to the next one, maybe play this video. It's the Mocha self-administered with an avatar. So this could be a way to save time in the clinics. I don't know if the sound will come up soon.
Let's
Go back one more. It will start on its own usually. One more back. One more back. And then forward. Forward again. And here we can go one more forward. It will start on its own then. Yeah, it's starting now. Is it
playing?
Now it's playing. Okay. So these are like AI generated
Jana.
AI avatars.
Today.
And we can pick the AI if you want. Obviously, you can adapt those AI to any country, and we can have them speak any language.
Today.
And with ChatGPT, voice recognition is improving around the world. I think we can have different ways of administering the test and scoring it. So we will welcome any one who's interested to validate it in their country, and so we can compare it to human administration.
To move from one screen to the next, please slide the arrow below with your finger.
So we can go to the next because this will be, I think, too long to show the whole video. One more. This is the one that if we have a couple of minutes to mention, is that we wanted to develop something that the families can do at home so that they can self-assess and also monitor their cognition between doctors' visits. Something that I didn't want the patient to start overlearn the MOCA at home.
They study it. My patients do they study it? They actually study it before they come in.
It's like an assignment.
Yeah. Did they do that for you guys? Same?
5 more.
Yeah.
So they do study it.
Luckily, we have the other versions that we can try. But so the espresso is meant to be able to be a different test. We're testing visual memory, so there's no speech recognition. It's less culturally and education dependent because the MOCA is more education dependent, obviously, also culturally to adapt. So we chose some items, so the patient have to place some items in a specific order on the screen, and then they have to remember those items for later, and in between they have like an executive function task to classify in the right order those items, and at the end it gives them a score from 0 to 100, and if they get above 72 they get green, if between they get 42 and 70 it's yellow, or it's red, it's below 42. And those scores correspond to your MOCA score. So if you have green, you're high likely, 95% chance that you have a normal MOCA, so you will have above 72. And if you're yellow, you will be between 23 and 25 on the MOCA. If you're red, you'll have below 23 on the MOCA. So it's a quick test, 5 minutes, that they can be self-administered. Obviously, the families, if they have to administer to their older patients, if their parents are older for technology purposes, but it did show a very strong correlation with the MOCA, with 0.85. This is a validation study. It was published last year. And I think we can go to the next screen. These are the cutoff scores showing the area under the curve, 0.84.
So self-administered shows good validity then.
Yes, it is.
Because there has always been the skepticism that a self-administered test will have a bias and will not have validity. But you're showing the opposite.
Yeah, it's showing that it's very significantly reliable to do it on their own. And this study is from 50,000 people who did the espresso in the last 6 months. And you see in the green where you will have the age 40. You're all functioning well at 40, it's green, and then it starts going down after 50.
I'm in trouble.
So do you do it with baby boomers or centenarian? You know, we in practice New York at between 80 and 90 patients. They are very non-computer savvy.
Yeah.
Yes,
So
it's not going to be possible, I think, to do it.
This is the
It
thing.
would need the family probably to help them.
selected certain age group
Yeah.
with certain education level and
Mhm.
computers.
So you're saying that could influence the interpretation in the elderly.
geriatrician, so neurocognitive geriatrician. So most of my patients are centenarian or below a little bit. Like,
Yes.
I do see young people,
Mhm.
but you know.
So does that mean the age affects the ability, not the age of the, I'm talking now the
Technology.
technologies, is that affected?
We studied that in a separate study, and it was showing that even non-technology savvy they don't even have a cell phone, were able to do it on their own.
Oh,
Not
good.
all of them, 80%. So we still have 20% of the people at age 80 that were not able to do it. The nice thing about it, this is a population study, not in the clinic. And the population is behaving exactly like in the clinic, and we can see in the graph on the right that the MCI prevalence in that population groups is increasing parallel to the expressal scores. So it's giving us an external validation from the public. Yeah.
No, we're running out of time.
So maybe
So this is the report. You want to?
report that they get, like if they are green, then they can be assured they can monitor themselves over time. Maybe one more slide. And this is the take-home message. So we're right on time. Just that we can increase early detection with a simple tool, and that people can do it at home, or they can monitor themselves with time. And I think eventually the solo would be the one that self-administered avatar would also save time for the busy clinics to help increase screening and increase cognitive assessments.
Thank you very much.
Thank you.
It's amazing.
Merci. Thank you. Thank you. Thank you.
Or I will.
Distinguished speaker, ladies and gentlemen, good morning. My name is Layla Abdelwarith, and I'm co-chairing the session with Dr. Hanan. I am a clinical pathologist and a medical biochemist, and I have to say I'm fascinated, completely, really thrilled to be with you today. Let me introduce Dr. Hanan, and I will be sharing also the talk with her. Dr. Hanan is a clinical assistant professor and American-trained, board-certified consultant neurocognitive geriatrician at Neurological Institute at the Cleveland Clinic, Abu Dhabi. Prior to joining Cleveland Clinic Abu Dhabi, Dr. Hanan was working in the U.S. as a consultant, neurocognitive geriatrician, and clinical professor at Rochester Regional Health Clinic, and also as a geriatric consultant with a very busy dementia and delirium practice in the States. She dealt with diverse aging, brain-related memory disorders, delirium, dementia, and geriatric polypharmacy. Being an academic lead physician at the Geriatric Fellowship Steering Committees in New York, in the UAE, producing conferences such as this. She's incredibly passionate and very well driven, and I'm really honored to be with her. And Dr. Hanan is going to be talking about the female brain code, sex-specific diagnostics, AI biomarkers, and personalized strategies for dementia prevention and management. So please join me in welcoming Dr. Hanan.
Thank you so much, and thank you for a great audience. So that means women's brain matter. That's wonderful. So before I start the talk, I would like to know whoever is practicing dementia, would they have special approach or impression about how to approach women that are coming with cognitive concern. So anybody has a thought, or just to to kick off the conversation? So I'm not able to see it here. I'm sorry. All right. Sorry. So, as I said before, that women constitute 2/3 of Alzheimer. So, every 3 people who have Alzheimer, 2 are women. And if we miss women with MCI, so let's say we have 100 million, we might be missing maybe, I would say, 10 million. So, it's not a joke. So, we need really to make sure that those population that constitute women constitute those type of the dementia are really well managed. Our role or talk in this objective is to reveal sex-specific diagnostic blind spot in women to make sure we're not missing anything, and explore hormone and ApoE4 and tau interaction in female brain, because we, over those 10 or 20 years or 30 years, all our trials were done on male, designed on male model. They're also, even whether it's animal model or a male model, including the neurocognitive scores and how to assess women. So I want to present some AI and imaging tool that improve early detection in women, the role, not the imaging tools, and examine how verbal masking delays diagnosis, and propose a precision model for female brain health. You know that cardiology, women's health have been ahead of us. Now they realize their coronary distribution, their stenting criteria is different. Is there any stenting criteria for the brain health? We don't know yet, so we're still not there. Diagnostic blind spot and why women are missed. When the model is male, the data misdiagnosed for sure. Women, as I said, they compromise this portion, but guess how many trials? Only 7, and some studies 10%. Clinical trials stratify outcome by sex or hormonal status. They are only subgroup. After they finish, they say, let's move to this tiny subgroup, which is not the tiny, they're the majority. So, and there's something also about ApoE4, and somebody was asking me, why do we check it on women with brain fog? I do also perimenopausal, collaboration clinic. I check it because ApoE4 hits women 4 times than men. So if you are if having 2 alleles of ApoE4, you are a male versus female, you're having 4 times the risk of what you have in cognitive for a male to develop dementia. This is something is always missed. And the result is missing the MCI window if you miss the diagnosis and delay treatment for millions of women. So that's all about the objective. Okay, and now, as I said, the pitfalls mostly falls into verbal masking. Verbal masking, anybody's familiar with verbal masking who does dementia workup. Fortunately, women outperform men in all cognitive score at the beginning, and they do better, except for 1 or 2. Anybody's familiar which one they are not good at, as opposed, but all cognitive domain that Dr. Nasruddin mentioned, they outperform if you have age matching group. So especially the verbal. The only thing is the visual spatial. So even the executive is, so how do we compare them? Why are we giving them the same score? So when that's a strength, which is something, okay, why are you worried? They're stronger, they have better cognitive reserve, and they have actually, it's proven by study, I think Dr. Dubois, one of the women who were, I think, studying in aging, they have better resilient brain till the estrogen falls. So when strength become a diagnostic barrier, so this is the issue here. So women outperform men and verbal memory, even with equal neuropathology now. They found out now with this biomarker that we introduced, for the same cognitive score, the women have higher tau in their brain. That means we're staging them differently. So we are not staging them only by cognitive score, and that has a lot of therapeutic implication. Are you targeting the MoCA, or are we targeting the image here, the load? So we're giving now anti-tau in the future and anti-amyloid. So that's important for our future tailoring medication for sex-specific. Women brain are not like male brain. And I think at the end of the lecture, if I convince you as such, you will change the way we practice. This is my goal, just from the beginning. So sex agnostic, I call it sex agnostic. When you have sex neutral or the threshold, it misses out 15% of those women, mean that if there are 100 million, as I said, you're missing fair amount. Women with cognitive reserve can pass the test despite underlying disease, and that's well known. And there are now new studies, but still not in the guidelines, which we hope to introduce. Early EEG and tau signals and signature, tons of study replicated, showing the same thing I'm saying, that you can have a normal MoCA, for instance. I'm not saying MoCA, any cognitive score, but you have abnormal EEG and abnormal tau on study. So, and she is diagnosed as normal, but when you do the tau, so, and that confirmed that we have to revamp the cognitive score for women. Okay, why standard cognitive tests fail women? The bias is beneath the surface of MOCA and MMSE. So MOCA, MMSE, and SLUMS emphasize mostly verbal and orientation. There's some what we talked about, the executive function, the clock draw, but also they can pass it. You have to go into deeper executive function and visual spatial. And also that trail we do in the clinic, I used to do in New York, that trail that has time, speed, but takes time. The trail alone, the speed also important. We don't measure the speed of the trail AB, right? Unless if somebody's coming for driving, I did it in New York to pass her for the driving test. So the other thing is EEG, there are new things that still taking time because there's not too much money or support or grants for it. There are things that can do it now and screen till we figure out those cognitive scores. We need to do something about it. So there's tons of studies showing radar plot revealing domain deficit missed by global screening score, and sex-adapted battery improved detection by 10 to 15% if you use different tools, different methodology in prodromal women. Okay, so sorry. So this was the radar. I don't know how much time we have. Sorry, I'm stepping. So this radar, I'm gonna pass it through, multiple study done, and it shows that where the verbal memory, they do well, but you compare it, if you have EEG with cognition score, you can tell that the executive fall beyond abnormal and the processing speed. And actually the signature for each domain in EEG, not the one that we do for seizure, there's a special one that traces ERP and theta wave. So if you do an EEG for seizure, you're not going to find that. And as I said, the verbal masking is a study by Sunderman. Sunderman did a lot of research on that. It shows that for a given verbal memory score, you can see big difference where yellow are females and male, and this is adapted. It's not copied and pasted, just adapted based on Excel sheets. So amyloid tau and amyloid tau, there's big difference between women for the same cognitive and masking, verbal masking score. So female cognitive trajectory is also different. It's not only the score, the way we monitor disease. It's linear in male, but it's curvy in women. That's the same. So the same thing is the cognitive score. So two phases of the decline, they're heading curve in women. So here we have to look at that. And women show delayed symptoms, so they become like plateauing and then or a little bit decline, and suddenly the estrogen drops. And you miss them. You see them next year, and they are different. So once symptoms appear, decline accelerate faster in women, and it's not only the cognitive score; it's the functional imaging now helped us look at it differently. Shows early compensation, then rapid decompensation. As I said, linear model is no longer working. This is nonlinear. Okay, and this kind of represent a trajectory where you see male versus female. So, and it's all because the estrogen supports synaptic plasticity, cerebral blood flow. It interact even with the plaque formation. So the pathway for putting plaque in the brain amyloid is totally different. And even the neuroinflammation has a higher role after estrogen is withdrawn. You can have more, for instance, they found that GFAP is higher, a lot of inflammatory markers. So there's different pathway, and that will let us think of different disease modifying and a lot of suggestion about using anti-inflammatory more in women. And that also tells us about the verbal memory and the PET score. So for a given score on the verbal memory, you can see red versus blue, the men. You can see how much different is the score if you drag a line. So not only for the tau in the image, it's also the CSF. Lots of study done on CSF as well. So women with ApoE4, they show different higher CSF tau and total tau despite equal cognition. And also, you're not going to do CSF on each woman to tell, you have the same of that guy, but no, your CSF tau is higher. And we know that can represent the tau burden, then are we treating with the same medicine of like lecanemab, donanemab, and for which threshold we are titrating? So A beta 42 is lower also in women, especially peri and postmenopausal. As we know, also not only inflammation is affected by neuroinflammation by estrogen. Estrogen also has a role in phosphorylation. We know that there's phosphorylation in the tau, and also in clearance. It helps clears the dirt. But when the estrogen fall in some women, I'm not saying all women, luckily, so it have to have a different propagation and different speed in their brain. So the plasma, GFAP, and NFL as well shows not only, we said A beta 42, and also these are affected. They have a predictive value in women, and I'm very blessed that Dr. Layla, after one day, she's working, like we're working tandemly, we're gonna get it fast. So current diagnosis thresholds currently, unfortunately, in all labs are not sex adjusted. So we'll have to ask Dr. Hans. So the next episode is about that. And I know Sweden is on the top of the world for what we call it SBAF policy, and women and age stratified data for when they put the data from the beginning, they enter into the computer, this is female and this is male, hey, pay attention. And we put threshold cutoff. The same as anemia. I have a man with anemia. Anemia for males is different than female. There's a threshold and there's a ferritin. And I wrote them differently when I was practicing. And also for polycythemia. So when you know, it's a huge. Okay, and these like represent adapted as well. From Dr. Mosconi, he's done a wonderful job, and she got, I think, $40 million grant recently to do neuroendocrine woman brain, because you cannot take the brain of the woman, separate it from the estrogen and hormone and FSH. There's a great deal of also FSH relationship with the hippocampus. So my new dashboard now on EMR, I have FSH, early menopause, all those things, part of my HMP now for a woman with the brain fog. For MCI versus brain fog, we'll talk. This needs a different lecture, by the way. So the current unisex diagnostic threshold may lead to false negative in women. And adjusted threshold, you also have the adjusted threshold, a light shade in like the red for women and also for the blue for male. It's also different. And NFL as well is different. So the imaging the female Alzheimer brain, atrophy, tau spread, and estradiol decline also are different. So the trajectory of atrophy is different as well. Tau PET show earlier and more aggressive spread, as I said, and it's also the regions are different. So the temporal and parietal amyloid PET update begins earlier. And if you are an ApoE4 and perimenopausal, you have a different PET, and that's actually published by Mosconi in one of, and they have beautiful images showing that. MRI reveals faster also cortical thickening, even though they start with a higher good hippocampus and good verbal memory, and they have cortical thickening post-menopause. Estrogen as well, loss accelerate, as I said, the tau propagation. So imaging thresholds are still based on male-derived templates. If somebody can argue no or except for ADNI did adjust, and he didn't mention that today. The ADNI today, so I think few platforms taking that into consideration. So also the MRI volumetric for a same given score on all those women. So they have a different tau, as you said, orange and yellow. The uptake is different for female. The cortical thickening is different, and the hippocampus volume loss is also the same. It's different. And also there's a study in Switzerland by Boccolini, it's published recently, I think this year, showing the same thing. They have those group equal number of women and men, and they studied those biomarker, trying to find out this threshold. And guess what? We use Barak stage, right, in tau. Yeah, so the Barak stage is different. You can see the tau aggregation, its area in the tau. Usually it's in an image for tau. You can see the red versus blue in tau, and also in amyloid. The same applied to GFAP and cortical thickness and early detection. And this one published a long time ago in June. Also, I think Dr. Mosconi has done. And you can see here the difference. You can see the difference between the women with ApoE4 and have MCI. You can see the upper one had more metabolism. Sorry, as opposed to the lower one. So this is ApoE4 male for female, and you can see the ApoE4 men are not that much affected like the male with the ApoE4. Okay. Also, as I said, the EEG, I can pass that fast because we might have, I think we have few time now. Mostly just there's a signature for female brain in the EEG, and it can be, and if you combine it with the Octa marker, you can screen MCA, including the theta alpha wave, and as well as the retina of the women has proven in multiple trials, still not included. So, and this is not invasive tool before the CSF to prove you have a different threshold. If they are normal on MOCA and you don't want to do CSF, this is something we can do cheaper and less invasive. There's tons of studies showing the EEG alpha power decrease in women, as well as ERP and P300. ERP stands for event-related purpose, and the retina vessel, and I'm comparing. So if you do also the retina in the women who start the MCI, they have faster thinning. So you can, and I'm now collaborating with our ophthalmologist to see whether this is validated in UAE. EEG and Octa, as I said, this summarizes. I might pass it fast if you don't mind. Women has more microvascular changes compared to men, more pronounced, and that helps to use her eye as a window to detect the MCI. So if you combine both markers like Octa and EEG, you can see that you can detect even women faster than men. And you can see this, the right side is the thinner in the Octa of the retina, and this is the left side. So why sex-specific threshold matter, which we don't have now? It's rethinking normal in women's biomarkers profile. We should start from the beginning to tell the story from the beginning. Women may appear normal also on CSF PET if you use the male threshold on imaging. Unfortunately, the imaging, we have someone from imaging here, so the sex stratified cutoff is needed for this is PET threshold for women versus men, increase early detection and reduce false negative. So if you have verbal masking plus unisex, it's equal to missing diagnosis. ApoE4 will also show a decline before reaching the traditional biomarker threshold. You can imagine. So in summary, this is like a sex-adjusted diagnostic model is more predictive and equitable. And I have already talked about the ApoE4 and the high risk before the lecture, which I broke the ice. And I talk about also the estrogen. Actually, when you have estrogen loss, you can also test glucose metabolism. They do hypometabolism affected by the estrogen loss. So the PET really shows and it proved that estrogen played an enormous role in that. Also, the cognitive drop often follows estrogen withdrawal in midlife. So the synergy is unique to women and absent in male profile, and we should include estrogen and phases in that. And you see that in in clinic, women postmenopausal have so much cognitive and mood complaints. So women shows also different genetic interaction between what she carries. We said about ApoE4. Not only that, there are more genomic and metabolomic interaction that makes a different outcome in female than male. So women show more distinct gene expression patterns in microglia and synapses, and the X chromosome inactivation skewing effect of immune risk genes. So the epigenetic marks, the DNA methylation, differ by sex and aging stage. A sex stratified transcriptomic model enhances biomarker precision. Why I'm asking about that? Because UAE has been now a beacon for precision medicine, and we are lucky to have our NRLM42 with the genome project merging. So that's why we actually pioneer using the genomic data since we started the brain health. So we might need to understand the population first. Maybe we will have a different treatment for our patient. And now so we talk about diagnostic, we move to therapeutic. So when we give the drug to women, we think it's the same dose. We never think, oh, she's a woman. We think it's elderly. We think renal failure. We don't say she's a woman. Let's think about it. So women have slower hepatic clearance and higher CNS exposure. Their BBB is different. The blood-brain barrier permeability is different postmenopausal, and it's more leakier. So that might be positive or negative about bioavailability of the drug, right? So postmenopausal brain show altered brain BBB permeability, and that also affect even we're not talking lecanemab, donanemab, we're talking Aricept, and it's been proven antidepressant and zolpidem. I've seen women behave differently, and it might persist and linger those drugs in the female plasma. So FDA now alert to like high adverse event rates in women when you give any of those drugs, whether it's bradycardia, heart block from rivastigmine or zolpidem, side effects. Yet most dosing is based on male-derived trials. So this graph I just summarized from different study the difference in pharmacologic vulnerability in CNS drug, including the BBB, the drug midlife, the inflammation, and the amyloid clearance, as I said, influenced by estrogen, and the area E, where we have to talk about women have area E. So when we discuss and we see a women want to take any of those anti-amyloid, we have take it as an extra point that they might bleed more. And there's a recent publication actually about lecanemab efficacy and area E, I think published recently in January 2025, and talking about that from Clarity D study. Why it's also important not to miss MCI is the estrogen. Anyone is familiar with HRT? Does it help or does it help or it does not help? Anybody says yes, raise your hand. There's one, okay, gentleman. Anybody? Oh, thank you. It does help, and thank you. And anybody says it doesn't? And actually, both are correct. Why? Again, there are so many reasons why we didn't get conclusion from that. It's based on the stratification of those patients. We picked the wrong patients. We picked the wrong window. So it should be at the earlier, like post-menopausal. You shouldn't have it after like age 60. And also you have to look into metabolic risk. So some patient can get a stroke. So you have to do as if when you were doing estrogen for breast cancer and stuff. So that's why, so it is still now not in the standard. I have to do risk stratification. So an ApoE4 factor into making that decision because we know they're damn at risk 4 times the men when they get ApoE4. I'll think about it, yes, benefit versus risk. So PET imaging shows better tau and glucose profile in early HRT. So that's a supportive one to Dr. Manal, and who said also, yeah, somebody also supported that, and Dr. Mosconi proved that in the PET. And the WIMS trial failed. There's another trial that failed due to delayed HRT start. Now, the lecanemab, I already talked about it. There are 2 outcomes, and they have no new now reading for it. They reread it. Clarity AD showed less cognitive benefit in women versus men. ApoE4 women had higher rates of area E, vasogenic edema, and estrogen loss impairs amyloid clearance via lymphatic pathways. So that means so your outcome is what? So you give lecanemab, I want to see the clearance. Are you giving the male and female the same and waiting the clearance, but his clearance is different than her clearance. So are we supposed to give the same dose? Nobody answers this question. So sex stratified dosing and anti-inflammatory adjustment or adjunct are emerging now. But till now we have no answers, no solutions. So lecanemab response in Alzheimer's 635 metric, the cognitive benefits is different, the ARIA-E, the amyloid reduction, the tau spread speed is different. So now also why it's important, I do, some of my patients are more into lifestyle, they opt lifestyle modification, and lots of study actually, including finger, show a better outcome in women. So they tend to respond more. I have also cognitive trainer, she's gonna talk about it tomorrow, the sign up, we call it the plasticity clinic, where we do occupational therapy for those patients. They show improvement in their executive function in MCI, in addition to treating diabetes, sleep apnea, all those risk factors. So it's important. So they have to have a different precision and approach. Women benefit more, as I said, from social engagement as well. And we've talked about neuroplasticity boost. So lifestyle and with HRT and lifestyle, you can see a lot of difference, not also on their phenotype. It's proven by PET. So we should consider it and make it a standard of care. Now, the other thing is vascular brain risk. As I said, they have more silent strokes, leaky vessels, and vascular dementia in women. That's what the trial summary shows. So, because estrogen plays a role in endothelial function and blood-brain barrier, women with postmenopausal, status, they have more small cell disease, white matter, and microinfarct. And women showed greater white matter hyperintensity burden post 65. And also SVD interacts with tau, we know that, and functional decline rates. So yet stroke and CVD risk model are rarely sex adjusted, they're still male model. And here's one of a few, actually multiple studies showed that, Rizal and Mosconi, that the white matter disease, you can see yellow versus orange, microinfarct is different. So that's why we have to take care of the vascularities. What we suggest, and I have created a theoretical dashboard to integrate dosing in women, especially the early MCI. Prevention must begin before menopause, not after decline, combining HRT in a timely manner and address vascular risk, and also ApoE4 status. I know it's not in the guideline only for lecanemab, but we have the luxury of being a new AE, so we have more flexibility in knowing and stratifying patient. We might come up with a different risk calculator, and they do need the risk, like we do in stroke, right? We should do that. So this is my suggested roadmap. Is to do decode the women is by understanding their verbal masking, explore estrogen's protection, and use a dashboard precision strategy. Because if you don't put the data all in one dashboard, you don't take estrogen into perspective and cut off thresholds. In addition, if we use the MoCA, for instance, the Espresso, which is more digital and use AI, we can bypass that part. That we can actually know we don't miss the part of the handwritten MoCA where women can pass because it has more executive. There's also something if you go to NIH SBAV, they have more tools that are friendly for women. And we're gonna advocate. Are we still there, or am I passing the time, right? No? How many? 1 minute? Yeah, okay, that's it. 1 minute. All right. So just actually the latest one, the latest 3 slides talking about policy. I'm going to introduce it to SABV. It's more policy and procedures in the world. I'm just going to make you aware of something called sex as a biological variable. Only one that applies its high center in the U.S. ADMI started that, and Sweden is on the top of the world of that. And UAE has included sex as a variable to build the data. So you need to build the data from the beginning. So AI can be misleading. If you teach the AI, they are the same. He's going to give you They are the same at the end. So we have to rebuild data. So we need AI, intelligent people. And that's what the Californian did, something we call, the German one called digital twins. They have the digital twin concept where they created a more female model with Atlas, with hormone, and the replicate brain and connected to the dashboard to think about women, what's going on in her hormones. And it's proven, but it's still not widely used. And we something also called neuro AI. So this way, it's a call for precision medicine for women, and one size doesn't fit all. We have to think about it outside the box. And thank you. Yes, it's okay.
Thank you very much, Dr. Hanan, and thank you for reminding us. This is something in the lab we are very fond of, sex-adjusted, age-adjusted reference ranges. Every day we talk about that, and we have lots of argument also within the lab community. I will be very quick. I'm going to take you now to the laboratory world. My presentation, actually, I'd like to condense it just to make up for the time because we're practically in the lunch break right now. So I will be quick in talking about the biomarkers, and I'd really like to keep some time for my colleague, Dr. Hans, to talk about phosphorylated tau 2 and 7, which is one of the blood-based biomarkers that is gaining a lot of traction. My talk today is about the novel biomarkers for the early detection and diagnosis of Alzheimer's disease. And yeah, there we go. Yes. So we'll just quickly discuss them, list the core 1 and core 2 biomarkers, and then evaluate diagnostics performance. Yes. The hallmark of Alzheimer's disease really is the amyloid deposition. And now we talk a little bit about pathogenesis and pathophysiology. So the amyloid metabolism in the brain takes one of two pathways. So we have the amyloid precursor protein, and we have what we call the alpha secretase pathway or the beta and gamma secretase pathway. Those of us who have the alpha secretase pathway, the amyloid gets halved or cleaved perfectly nicely, and you don't have any sticky molecules. It is easy to clear the amyloid products in the alpha secretase pathway. The unfortunate thing is people with the beta and gamma secretase pathway, the cleavage is not really equal. And then you produce this amyloid beta 42 molecules, which are really sticky molecules. And these ones, if they are not cleared quickly, they tend to stick together, they polymerize, and then they form the amyloid plaques. And this is the problem. Now, once the amyloid plaques forms outside the neurons, it creates a kind of an inflammatory effect. It activates the glial cells. There are some inflammatory markers are produced. That leads to hyperphosphorylation of the tau protein, which is a structured protein in the neuron cell itself. And when the tau protein becomes hyperphosphorylated again, they tend to stick to each other, and then they form these tau tangles. Now, the combination of the tau tangles and the amyloid deposits out of the neuron basically kills the neuron. And you have this process happening slightly and slowly, by slowly, you lose brain matter. And these were the pictures that our colleagues showed us earlier in the morning when you just have the emptiness. Basically, the brain disappears as this process happens and continues. Now, the exciting times here for the lab world is now finally we are able to actually measure those markers in both the CSF and the blood samples. And that's what I will talk to you about. So that led also the Alzheimer Association, the National Institute for Aging and Alzheimer Association, to advocate for the use of what we call the ATN biomarker profile, where A stands for amyloid, and then T stands for tau pathology, and then N is neuro degradation, basically. In the revised criteria, they characterize what they call core 1 and core 2 biomarkers. And these could be blood-based, CSF-based, or imaging-based. We'll talk about that in a minute. The core 1 biomarkers tend to appear early, while the core 2 biomarkers will appear later in the disease and also correlates with the severity and the rapid decline in these conditions. So this is the core 1 and core 2 biomarkers, as you can see. And then we have other biomarkers as well that could indicate neurodegeneration, and there are other biomarkers as well that indicates non-Alzheimer disease pathology in the brain. So you have a lot of choices now if you want to apply the ATN system. So if you want to detect amyloid pathology, you can do a blood-based test looking at the amyloid beta 42. And because it deposits as an amyloid plaque, actually it's counterintuitive. The level in the blood and CSF decreases because the 42 molecule actually deposits in the brain. You can measure them in the blood or the CSF, as I mentioned, or you can do the imaging based, as Dr. Hidayat told us in the morning, using the PET amyloid tracer. For the tau pathology, tau gets phosphorylated at multiple sites, but the important ones associated with Alzheimer's disease are the 181, the 217, and the 223. So you can measure any of those in, again, CSF and blood, and again, Dr. Hans will talk more about that. And for neurodegeneration, you can measure the neurofilament light chains, which is basically the product of the disintegration of the neuron cells, and you can also measure total tau, again, in the CSF or in the blood, or you can do the FDG PET, as Dr. Hidayat told us in the morning. So quickly on the plasma biomarkers, basically what happened in the laboratory environment is, I guess, two things. One is the rapid advancements in technology. So these biomarkers, the concentration of these biomarkers in the brain and in the CSF is actually very high. I mean, you can detect them in the CSF because they are surrounding the brain. So the problem is because of the blood-brain barrier, the concentration in the blood is significantly less. So in order for you to detect them with the same accuracy as in the CSF sample, you need very sensitive analytical techniques. Luckily now, we have the single molecule array methodology, what we call the SIMOA assay. We have the chemiluminescence immunoassays. We also have the liquid chromatography mass specs assays. And these are all very sensitive assays that enabled us in the laboratory to be able to measure these markers readily in blood samples. So if we talk about the amyloid, for example, if we look at the amyloid 42 to 40 ratio in the CSF and in the plasma, you can see, for example, here in the CSF, you have the PET negative and PET positive patients, clear delineation between the two. Again, remember, the levels will go down for the amyloid beta 42, not up. Yeah. With the plasma, you also have some separation, but perhaps not as impressive, but it is present nonetheless. The picture is slightly different with the tau protein, particularly the 217, where actually you have very clear demarcation between normal controls, PET negative patients, patients with non-Alzheimer's disease pathology, and patients with Alzheimer's disease pathology. So that led to huge excitement about the phosphorylated taus. And again, we'll talk more about the 217, but it has a very powerful discriminatory function in the blood by measuring it in the blood. There is a perfect correlation between the CSF and the plasma 217 levels. And also, the more exciting thing is that we're able to measure the phosphorylated tau 217 in cognitively unimpaired participants who are PET scan positive. So again, it can be used to predict who is going to do worse than others. This phenomenon was replicated in multiple cohorts, huge cohorts, the RAP cohort, the Triad cohort, the SPIN cohort in Sweden, in the US, and in Australia as well. And basically, that led to a huge excitement in the field and people thinking, okay, now the plasma 217 and tau PET can actually predict future cognitive decline amongst cognitively unimpaired individuals, and it can be used as a way to stratify patients. And the interesting thing also is that you can detect this way early, 18 to 20 years early in the blood before in completely cognitively unimpaired individual before they get into the neural dysfunction and the actual amyloid pathology. So now the conceptual and the huge hype in the lab is that we're thinking, oh my God, now we've got a marker that can help us with diagnostic accuracy. It may have a prognostic value, differential diagnosis from Alzheimer to non-Alzheimer pathology. Perhaps it can help for pre-screening, for clinical trials enrollment, and also monitor response to treatment. And now the advocacy is to use a kind of a tri-level cutoff for the 217, one which indicates it's a very high probability, it's an abnormal level, one which is very, very normal, so there's a very low probability that this individual is at risk. And then you've got the medium or the in-between kind of value, which necessitates that this individual may have to be assessed in another way and maybe do the cognitive test, do more imaging studies, etc. Neurofilament light chains, as I mentioned, is a marker of neurodegeneration. They are not specific for Alzheimer's disease. However, if you use them with the core one, they indicate the severity of the disease. The glial fibrillary protein, the GFAP, is another very interesting molecule, and it's a marker of amyloid deposits because the astrocytes get aggravated when amyloid gets deposited, and then they produce this protein as a marker of inflammation. So the interesting thing about this marker is it can actually be used to monitor the decrease of the amyloid with immunotherapy. Genetic markers, very quickly, as Dr. Hanan mentioned, the ApoE genotyping. It's a very important risk factor. It also important for the complications when you get those immunotherapy. There are also other genetic panels, but this is for maybe the 5% or less familial causes of Alzheimer disease. I am very excited to announce that at the National Reference Lab, we are collaborating with the University of British Columbia, the University of Gothenburg at Sweden, the University of Oxford, through the Neurocode International, to actually bring all these markers in-house here in the UAE in both plasma and CSF. So in summary and conclusion, I hope I managed to convey to you that the recent development of analytical techniques improved our understanding of Alzheimer's disease. And I think it's going to be very exciting times because it's a very simple blood test, and you can ask any research question, and we should be able to entertain this question and learn more about this disease and other diseases as well. They can use for diagnostic, prognostic workup of patients with Alzheimer's disease. They really are beneficial to detect patients early, so you can detect patients in the preclinical stages. They can guide therapeutic intervention, and I think very soon they will replace CSF. I'll close with that. Thank you very much for your attention, and And I'll just introduce Dr. Hans quickly. So it is my pleasure to introduce Dr. Hans Freckmann. Dr. Freckmann is an MD, and he's the founder, CSO, and a medical director of the British Columbia Neurochemistry Laboratory located at the University of British Columbia Hospital in the university campus in Vancouver, British Columbia. He's a medical director for Lick Lab at the Genetic Laboratory, also at the University of BC, and also he is the CSO for Neurocode Lab in Bellingham. He is also the CEO of Neurocode International, and we are collaborating with him. He's bringing all the expertise required to do these tests. Since 2020, Dr. Freckmann has led clinical laboratory field in neurochemistry across North America by first launching blood-based clinical trial tests in 2021 and the ALSPath Tau 217 that he will talk to us about in early 2024. His lab now one of the most experienced laboratories in clinical practice, and they've done more than 10,000 tests in various studies. So please join me in welcoming Dr. Hans.
Thanks, Dr. Lila, and thanks for the organizers for inviting me. Yep. Oh, okay. All right. Yes, okay. Yeah. All right. So thanks to Dr. Lila, and thanks for the organizers to invite me. So we didn't coordinate our slides very well, so I'm going to flip through some of the slides quite quickly, and you can stop me if you want to know more. But I think the importance is to not to bore you too much. We as laboratorians, we're always a little bit more interested in all these different technical details, which I'll try to spare you. Yeah, so as Dr. Lila mentioned, I work in different labs around the world. In the Neurocode lab in USA, we were the first to set up the p-Tau 217 clinically already in 2023 in the world on an immunoanalyzer. C2N was I think 3 months before us, but they do a mass spec technique. And now I'm here. Different dementia types, we don't have really good biomarkers for all of them. Alzheimer's, we mostly have a good biomarker for amyloid. But the new development that I may talk about at the next conference in Riyadh would talk about the tau biomarker that just arrived in both in CSF and perhaps also in blood. Vascular biomarkers, we think that there is a biomarker that is actually measuring vascular pathology. Lewy body, I'll talk about tomorrow when we talk about synuclein. And then FTD, we really looking at neurofilament light chain or perhaps PD-tau. TDP-43, there is nothing yet. And then, of course, to make it more complicated, even though this is not a complete list, we also have all the mixed pathologies. And as you know, the Alzheimer's is 62% of the dementia. About half of those are mixed pathologies, which makes it difficult when it comes to biomarkers. It's just to keep in mind. However, the right type of dementia is hard to diagnose, and really good neurologists only right about 70 to 72% of the time. So the biomarkers do play an important role. There are many biomarkers that are possible, and I think you heard about this quite a bit now, and Dr. Lila was mentioning this as well, so I will just skip this slide. This was a publication that came last year from Beijing, where they looked at biomarkers over 20 years. This was in CSF. The 648 Alzheimer's patients were matched with 648 cognitively normal. They looked over 20 years, and they found then that the difference or the decrease starts 18 years prior. So this is A beta 42 being the most sensitive. This is in CSF now. Is quite remarkable, and other studies have supported this through the years, but the study was kind of comprehensive and in finalizing that idea and knowledge. When you do the ratio between 42-40, which is more stable way to measure it, then you also have the difference starting at 14 years before symptoms or diagnosis, actually before diagnosis. And p-tau 181 is a little bit less sensitive, but still many, many years before, and the hippocampal volume and so forth. So the diagnosis of Alzheimer's was defined is being defined more and more as biological diagnosis. This was the first framework in 2018 when that was brought up. And then this table you seem to know quite well, I think. So the evidence is very strong for A beta 42 versus control in CSF. There's more than 100 publications showing that, and this is also so-called FDA approved, which makes everybody trust it. And it is true. It's also something that measures the plaque directly, so it measures the amyloid pathology directly, which is very, very good for a biomarker, but it is in CSF. The CSF p-tau increases. This is also confirmed in 100+ studies. And the total tau reflects disease intensity, also many, many studies. However, total tau, even though the name is such, does not correlate with autopsy. And this is something to think about, because when you order all these different tests, some can be misleading in what you think you order. So that's where the new MTBR biomarker that we'll bring here during the summer will come into play. So the MTBR biomarker does seem to correlate with tau pathology. And that's important because you would like to have select patients that have a strong positive p-tau 217 and a kind of negative MTBR for the treatments. So if we look at this, we really only have a really good biomarker for CSF, A beta 42 or A beta 42 over 40. We don't really have a good biomarker for tau, but now we may have that in MTBR, and for neurodegeneration, total tau. So the year of plasma p-tau 217 is here. I think it's really was more last year than this year, but still continues. People don't really want to hear about it anymore when you go to the Alzheimer's meetings. And it's hard to publish on 217 unless you have something strikingly different. It's not. There. All right. So I will skip through the slides. It's just suffice to say that the work started quite a bit ago in 2011 already, University of Gothenburg, and in A beta 42/40, and went towards mass spectrometry, and in 2017, the first methods. Let's see here. Yeah. So this was the method that came from Japan that was measuring another biomarker as well. And then this year, I think in 2017, 2018, we started to really get confidence that we could probably do this in blood. And because the reduction in plasma is really not that sufficient, it works in big clinical trials for A-beta 42/40. So as beautiful as it is in CSF, it is not as beautiful in plasma and only works really in clinical trials. There were many different trials. We started with plasma p-tau181 in 2020, right after the Kari paper, which is this paper, I think, yeah. We got FDA approval to use it in clinical trials in 2021 already for selection criteria. However, plasma p-tau217 is even better separation than 181, which is shown here. And now there's been more than 100 studies on plasma p-tau217. So I think it's beyond doubt that this is a good biomarker. This was one of the hallmark publications from 2023 where it looked at diagnostic accuracy, and I think Dr. Lila showed this information as well. What we could see here is that when you have amyloid and tau PET positivity, then the signal of p-tau217 is much stronger, as you can see the blue line, and then the yellow line where the amyloid only is positive is a bit lower measurements, but still very distinctly different than amyloid negative and tau negative patients. So when we talk about different methods, because now we're measuring in picogram per milliliter, it's very, very small amounts, and this is kind of the first time we can measure these small amounts in a lab, at least in a repeatable way. And when it comes to the Simoa instrument that we are now installing in the lab here at NRL, this instrument was first came to the market in 2011, but still has a kind of a leading technology in that it's a digital analyzer. So the range is very, very big between the highest value and the lowest value. So it can measure also all healthy controls, and it's actually the only instrument in the market today that is that sensitive. So we're building a second generation p-tau217, and that is far more sensitive than any other p-tau217 on the market, and we're using the Simoa technology for that. Also, we're running the ALZpath 217 in our lab since 2023, and the Lumni Pulse came shortly after with also a p-tau217. And now we're going to investigate a little bit the difference between them. The Lumipulse is kind of the standard of care when it comes to the CSF testing, together with Roche to some degree, but the Lumipulse has more analytes on this instrument for CSF testing. And in our case, we are now going to approach 8 biomarkers for CSF and 4 biomarkers for blood. So when you do set up a new analyte, you want to do the reference range first thing with healthy aging samples. There is really only one such cohort that has PET data, and that's the ABLE cohort. It's obviously the drawback is that it's only white people in Australia. but nevertheless, it has both tau and amyloid PET data, as well as very well characterized patients, people. They're healthy, so they're not patients, and they've run the memory scoring with different memory scores over time longitudinally. So when we looked at the CSF that we had, we couldn't see much difference between the two instruments, and this is what's been published quite a bit by other groups as well, that the Fuji-Rebio and the ALZpath would be very similar. However, we had another set, access to another set that had very full pathology characterization. So these were patients post-mortem that had characterized brain pathology that also had collections of plasma prior to passing. And in this data set, we see that the ALZpath on the Simoa is a bit better. As we discussed before, the range is much better, but also the becomes even more important to have a strong differentiation, because you may have less signal since only amyloid is going to give you the signal. And if you have without mixed pathologies, perhaps it's less important which instrument you use. So in our lab here at the NRL, we used both instruments. In our labs in the US, we also use both instruments, and the machine park is kind of expanding. We're not proposing one instrument over the other necessarily, but we think that this Simoa technology really has a lot of advantages in terms of detecting earlier, detecting MCI more surely. Here, when we look at Braak pathology, which is, Braak staging, which is a way to characterize the pathology, we see this again as that the Fuji-Rebio is probably fine when you go into mild, moderate, to severe dementia for diagnosis, but the ALZpath picks up and has separation earlier in the Braak stage. And CRAD, which is a more modern staging technology, is the same results. I think we are using the 3-point cutoff, and when you look at this, you can see that it works wonderful for the mixed pathologies as well as for the pure pathology of amyloid. However, with the mixed pathologies, you are going to have some that are in the intermediate range. And what does that mean? That means likely that you need to retest those or send them to CSF testing or PET scan. And I'm going to go through this here a little bit quicker. The brain-derived tau is a biomarker that can also be useful, but it is a biomarker of disease progression rather than a tau biomarker. So that is distinction here. And you can combine this using the p-tau 217 together with this brain-derived tau. Then you can increase your specificity and also get the prognostic measurement. And again, the revised criteria. And as I said, we have the MTBR. I will talk about that next time you hear me talk. And then also the second iteration of the p-tau 217 that is perhaps has the advantage of partly being able to detect even earlier, but also has the advantage of being able to look at the treatment efficacy in a better way. So treatment efficacy as well as earlier detection for the second generation P217 is coming to market later this year, and then the MTBR for distinguishing those that are suitable for treatment, then the MTBR should be low, and the P217 should be distinctly positive. And I will skip this. We're doing several prospective trials in primary care right now in the United States. Those are NIH-funded trials with UPMC, which is Pittsburgh, as well as Wake Forest, as well as University of Texas in Austin. And the diagnostic accuracy increases tremendously, actually, with using these biomarkers, as been shown in this publication. So when you combine P217 with clinical care, both in primary care as well as neurologist, this in the primary care it increased from 61% to 91%, and for a neurologist from 73 to 91%. Yeah, it's done. Yeah. So we're standardizing all this, and this was the acknowledgement. Thank you for listening.
So much. It was a fantastic talk. I think we can go for tomorrow. It's very, very wonderful, and I love the slides. So now we're late for lunch. We should head for lunch. We should be back at 1:30. And the speaker here we can give the plaques now for the speakers. Speaker together, we will have a photo for all the speakers. And speakers from
What about your words? Before you go.
Recording stopped.
Assalamu alaikum. Welcome back. Hope your blood sugar levels have nicely risen and so on. It's good to be here, and it's a pleasure to start our next session with the title of Therapeutics, and with the first speaker being Professor Marwan Sabah, who really needs no introduction at this point, but just for formality, well-known behavior neurologist and Alzheimer's memory disorder program specialist, professor at the Department of Neurology at the Bayer Neurological Institute, best board certification, best credentials that you can think of, leading investigator, expertise, publications, et cetera, and also sharp, and it's smart looking today. So looking forward to hearing you speak. The title of your talk is Emerging Treatments in Alzheimer's Disease.
Thank you, Dr. Haytham. I am going to, you're going to hear a lot about therapeutics this afternoon. We'll talk a lot about monoclonal antibodies. In fact, there's two symposia this afternoon, one sponsored by Lilly, one sponsored by Biogen. We'll spend a deep dive on the monoclonals in those sessions. So today I will kind of talk to you about where we're at in the state of science, looking in the present and into the future. These are my disclosures. So you need to understand that lecanemab and donanemab, approved now under the brands Leqembi and Kisunla, are second-generation monoclonal antibodies. If you know that the first-generation monoclonal antibodies, which were bapineuzumab, crenezumab, solanezumab, you understand that we learned a lot of things along the way to get to the second generation of the monoclonal antibodies. And now we're also going to talk about third-generation monoclonal antibodies. And the reason we understand this is that biologically, we understand that the toxic species of amyloid is not the monomer, that when you cleave it with the amyloid precursor protein, you cleave with the beta secretase and gamma secretase, that the first protein that's created is the monomer, which is a nascent protein, and the toxic species, the oligomeric species, the protofibrils, fibrils, and then the plaques. So targeting monomeric A beta has not turned out to be productive or useful. Then people have said, well, why don't we just do the cleavage or the production-based approaches? Specifically, why don't we give secretase inhibitors? And it turns out that they did, and they didn't work. So the production-based approaches of treating Alzheimer's has not been productive. So that's how we got to the second generation lecanemab, aducanumab, and donanemab. Well, let me go back one. I was very lucky to be part of this program. You'll have a whole session on this. I just want to make one comment here about lecanemab. Again, we're going to have a whole session on it later today. The thing I want to point out to you is that this is the actual randomized blinded study, and this is there's a placebo lying underneath here. It's a purple line, you can't see it. But what happened is that then they modeled a ADNI cohort, and I'll spend some time in the Biogen Symposium talking about the fact that the modeled ADNI cohort patient is matched patient for patient, characteristics, amyloid status, age, gender, etc., and it shows that there's a divergence of the clinical efficacy signal and is showing a sustained efficacy signal. So lecanemab removes amyloid about 85%.
Recording in
and
progress.
Meets its pre-specified biomarker endpoint of amyloid removal. But the important thing is people ask me, why isn't it that you're seeing a bigger effect? And I'm just really talking to my colleague who's sitting in this audience, who he and I disagree animatedly on this particular topic. And the answer is twofold. Number one is that clinical set instruments are very hard to move. Okay, you're not talking about symptomatic improvement, you're talking about change over time. And the second thing you're going to understand is that it's not one-to-one. You remove amyloid, but you're not taking care of tau, so the effect is only countering the amyloid and not the tau, and that's why you're not seeing a full effect that would correlate with the amyloid removal. So it's not one-to-one. You remove amyloid and you get that kind of level of reduction. Now, I'm going to spend a lot of time talking about this in the Biogen Symposium, so I'm going to skip this slide. I want to get to Trailblazer AL2. Again, this will be in the Lilly Symposium, basically talking about the fact that this placebo group, the amyloid PET is unchanged. The treated group of donanemab shows removal of amyloid, and you see, again, that they're slowing roughly the same, about 29% on the donanemab group. This is low tau was actually better, and then all tau status was they're roughly equal in donanemab and lecanemab. When you speculate why these work, what you have to understand is that they actually probably work because your tau levels in your plasma are falling. Remember, it doesn't target tau directly. It has a passive. You're removing amyloid. You do it very well. But what you're doing is when your amyloid is removed, you start to see the plasma p-tau levels start to fall as well, and that might be the driver of the clinical efficacy signal, not just the removal of the amyloid. So we understand that AD pathophysiology is complex. You have amyloid, you have the monomeric amyloid, it occurs early, and once you get it beyond a certain point, you start to see the pathophysiology start to cause the accumulation of tau, neuroinflammation, neurochemical breakdown, excitotoxicity, etc. So I also want to point out to you again that secretase inhibitors, production-based approaches have been tried, didn't work. We tried vaccines, anti-amyloid vaccines, caused a lot of toxicity, probably because we couldn't regulate the immunological response. Now we're looking at tau-based approaches, which I'll spend some time talking about, and then we have to talk about downstream effects as well. There are over 130 drugs in development for Alzheimer's disease. This is a very robust area. This is the 2023. The 2025 version of that should be coming out any day now. And so hundreds of clinical trials, but not all of them, only a few of them, a very small segment of them are targeting amyloid. There's bioenergetics, but targeting inflammation, targeting tau, targeting metabolism, and different symptomatic approaches. So, and if you look, here's the actual breakdown of what the drugs are trying to achieve, and they're including the gut microbiome. But you need to understand that there are a lot of different approaches because a lot of us believe that Alzheimer's therapeutically will be the chemotherapy approach. Not a one drug, but a 4, 5, 6 drug approach. It'll be stepped, it'll be slow, it'll be graduated. You'll try with probably a induction-based approach and then a maintenance therapy. And so there are a lot of different things we're going to see developed and moving forward. So people say, for the skeptics of this audience, people say, removing amyloid is not relevant. And I say to you, well, I can say that that's the second generation lecanemab, donanemab, aducanumab. We even are moving beyond second generation to third generation monoclonal antibodies. The first one you need to be aware of is trontinemab. And what trontinemab does is it's a facilitated transport using the transthyretin receptor. And basically, this is a facilitated access, so a facilitated transport. So this binds to it and then helps shuttle across a isoform of gantenerumab. This is trontinemab. And what they show is in 6 weeks, you have removed 95% of the amyloid out of your brain. So really startling removal of amyloid. So these are working better than second generation in terms of efficiency of clearance and total clearance, and you're seeing how much is removed in just 6 months. When you look at a competing one, so this is, by the way, this is the Roche drug trontinemab. This is the Eli Lilly drug. This is remternetug, and they show also same thing, removal of amyloid back to near zero within 6 months. So we know we can remove amyloid, and we can do it very, very well, faster, more significant, more complete with the third generation monoclonal antibodies compared to the second generation monoclonal antibodies. The next drug that is being developed around the anti-amyloid approach is PRX-012, and they're entering phase 2 trials, and they have shown already that they can have better affinity for amyloid than currently approved drugs. And then the last of the third generation monoclonals you need to be aware of is Acumen's ACU-193, and it actually targets multiple different species, as you see here, mostly oligomers, but it can, but it has a very high selectivity for oligomeric species of amyloid. So people ask the obvious question, which is, why are we spending all of our time talking about amyloid, and why are we not talking about tau? And the answer is, we did. It didn't work. Okay, so the short answer is that there's been a lot of trials on trying to affect tau. What you understand is that when you look at it, tau, we understand, is a microtubule stabilizing protein, and it becomes hyperphosphorylated. And once it becomes hyperphosphorylated, those microtubules are no longer bound by the phosphorylated tau, and then they kind of free up. So the question is should we use a kinase inhibitors to affect the stabilization? Should you be giving these monoclonal antibodies? This is what these new generations. So the concept here is that you have these free forms of phosphorylated tau. The cells die. They lyse. When the cells lyse, the free forms of phosphorylated tau are released into the milieu, and by so doing, they're taken up in adjacent neurons in a process called preonosis, and that's what they're showing here. And that would be how tau is spread. Okay? Maybe. But we do know that trying to create monoclonal antibodies to take care of these free forms of tau hasn't worked out. And the question is it a concentration? Is it a transport issue? Is it a gradient issue? But we haven't been able to demonstrate a clinical efficacy signal on the basis of this. Until recently, when actually it was Biogen who showed something called BIB080 or BIB80. They used an antisense oligonucleotide, injected into the CSF, and removed tau on tau PET, and it did it very, very well. So the first time we ever see ASOs used to treat tau. The next thing you need to know is autophagy. Again, you're going to have a whole session on it tomorrow morning at 8:30 on autophagy. And what is autophagy is, as Professor, I don't need to talk about it, Professor Per Nielsen gave you a whole lecture on autophagy and why it's relevant to Alzheimer's disease. That was the second lecture or the fourth lecture we had yesterday. But what it's showing you is that autophagy is our cellular reset button. If you can get your cells to reset and process things normally, that would be good. And that's really because you're seeing, of course, that once your lysosomes don't work, you get this accumulation of protein aggregates. And so by activating sigma-1, again, we're going to talk about this tomorrow, you're going to, you can make the lysosomes work better. I'm going to show that tomorrow. I'm going to show that tomorrow. I'm going to show that tomorrow. I want to next talk about GLP-1 receptor agonists. So I don't know how popular they are in the Middle East. Very popular? Super popular. So they're super popular in the US for obesity, diabetes, weight loss, congestive heart failure, renal disease, etc. So Novo Nordisk found a body of work that's relevant to semaglutide. What they showed is that in patients with real-world evidence of diabetes, that people who took GLP-1s had lower all-cause dementia compared to patients who did not take GLP-1s. In their animal models, they showed that they reduced neuroinflammation. And then there's now a few trials, both in Alzheimer's and then in other things. So when you're looking at other things like cardiovascular disease and type 2 diabetes and obesity, these are secondary outcome measures, not primary outcome measures. And they showed in randomized trials that they slowed cognitive decline. And this is the study that got everybody paying attention. They showed that patients on GLP-1s, both liraglutide and semaglutide, when they were followed for 4 years, that the patients had much fewer, 50% fewer AD events compared to placebo. Now, before you get super excited, I want to point out to you that these are tiny samples, 32 versus 15, so we don't know if we can make huge interpretations on the basis of that. But what it has done is they committed to doing a study called the EVOKE and EVOKE trials. This is two large studies, 2,000 patients each, so a total of 4,000 patients in 40 countries worldwide. And they will report their data on semaglutide, biomarker positive patients with mild cognitive impairment. They'll report their clinical outcome this year around November, December of this year. They're going to report their clinical trial outcome. Now, I have to say to you that they have plenty of statistical power. If you're doing 2,000 patient studies, it is very likely that a year from now, you're going to be prescribing semaglutide to treat Alzheimer's, mild cognitive impairment due to Alzheimer's disease. And I want to point out to you that this is not the injectable. This is the oral Rybelsus. So the oral Rybelsus, which is approved for diabetes, this is the oral version, not the injectable version, okay? So 3 milligrams, titrate up to 7 milligrams Q day, titrate up to 14 milligrams Q day. The biggest concern, as you obviously know, is that this drug suppresses appetite and causes nausea, and so does donepezil. And so the worry, of course, is that your dementia patients are losing weight and they're going to lose more weight. And the answer is yes, but not as much as you think. About 4% is what we've noticed on it. So it's not like they're just going to lose tons of weight on this. This has been studied, and we know that it can be done safely. Let's talk about other targets of neuroinflammation. So the people understand that neuroinflammation has been looked at a lot. So we have understand mechanistically that neuroinflammation has been going on for, understanding neuroinflammation has been going on for 30 years or more. We tried COX inhibitors. All the NSAIDs you can ever think of were tried and tried and tried again. Prevention, treatment, etc. Not a single one of the COX inhibitors worked. But we do know that inflammation is a pretty early event. In fact, there's now evidence to suggest as soon as amyloid is started to be deposited in your microglia turn on activation, you can see an inflammatory response that cannot be regulated. You're going from a physiologic change to a pathological change, and that's what's changing here. And so there's now a renewed focus on targeting inflammation in Alzheimer's disease. Oops. Okay. And why is that? Because we thought that you get the amyloid and then the tau and then the inflammation. Now we understand that the inflammation is probably occurring early in the amyloid deposition, which is then creating this negative feedback loop, which is caused by the presence of amyloid and tau and the damage to the neurons, and then the microglia activation, and then the pro-inflammatory response. And then once this cycle takes hold, it's hard to break the cycle. So that's why you're seeing now there are over 20 drugs now being developed for targeting inflammation in Alzheimer's disease, including asthma drugs like Montulacast. I am running the clinical trial on cancer drugs repurposed for Alzheimer's disease. And you're seeing several cancer drugs and JAK inhibitors, et cetera, being repurposed for Alzheimer's disease because all of these drugs actually have specific targets around inflammation to treat Alzheimer's disease. And you saw that there's the possibility that vaccines could be reducing Alzheimer's as well. We do want to finish up by talking about aggregation inhibitors, ALZ 801. This is valiltomipirosate, who just now, a week ago, 2 weeks ago, reported a negative study in their phase 3 study. But what they showed in the phase 2 trial is that in patients who were ApoE4-4 or homozygous, they had a very, very robust effect. But the interesting thing is, so how does valiltomipirosate works? It works by causing suppression or blocking the binding of a protein called a glycosaminoglycan. And it's a GAG inhibitor, and by so doing it, it can stop the accumulation of amyloid or aggregation of amyloid. And this, in their phase 3 trial that they just reported, they reported top-line results negative, but in the very mildest group, we're talking with mild MCI, it worked very, very well. So they're now discussing with your regulatory authorities whether they can do a sub-analysis or get an approval, a limited approval. So in conclusion, there's 120 drugs in development for Alzheimer's disease with multiple targets. and we will need to think about a different regimen and a multi-drug regimen in the future. Thank you very much. You're next. Yeah. So it is my pleasure to introduce my friend and colleague, Dr. Walid Fawzi, from the National Health Services and this old age psychiatrist in London, who's going to talk about walking the line of BPSD. He's a consultant psychiatrist and trust lead for mental health care of older people in East London under the National Health Services Foundation. He graduated from Cairo University in medicine in 1995 and studied geriatric and gerontology in Malta, and then trained psychiatry in London, and he's been in London ever since. He's joined the Royal College of Psychiatry in 2006. He received, and he's published many, many papers. I welcome my friend, Dr. Walid Fawzi.
Thank you very much, Marwan, for your kind words. It's very difficult to step in the podium after you. What an excellent presentation and the tour de force. So I will try not to disappoint. Can you hear me? Yeah. Okay. So I'm going to talk about the reason it's called walking the line. It's about basically trying to do no harm when treating behavioral symptoms in dementia. And I will explain later in my talk why there is a potential for doing lots of harm. So no talk can be complete. How do I go forward? Ah, there we go. Yeah. So no talk can be complete without her Alzheimer and his most famous patient, August Detter. As you will see, she was fairly young when she suffered from Alzheimer's disease. This is the seminal paper from 1907. And what is remarkable here is that she actually presented with a lot of behavioral symptoms in dementia. So what you will see here is persecutory delusions, auditory hallucinations. She had delusions of jealousy, morbid jealousy against her husband, and she was hiding things in the home. And for those of us who are non-German speakers, this is a translation of the paper. So behavioral symptoms in dementia started with dementia, basically. They were part and parcel of the disorder, and it's a part and parcel that we have since struggled to treat as well. The actual term, behavioral BPSD, came from a meeting in 1996, where the decision was made to move from the old term, which was less inclusive, and the behavioral symptoms are the ones that you can actually observe in the patient. So the aggression, the agitation, the wandering, the hoarding. These behaviors, especially the aggression, are not uncommon, more than 50%, and they're obviously overrepresented in people who are in care homes. The psychological symptoms are the ones that you elicit from the patient and from the carers when you're taking a history. Of importance to us today are the depression and also the psychotic symptoms. So where do they come from? Where do they stem from? The etiology is multifactorial. We don't have a clear understanding of it. The genetic studies have not yielded any consistent evidence. They do show some of the polymorphisms, but again, contradictory. The neurobiological findings are quite significant. We know that there are deficits in the neurotransmitters. Again, an interaction between these and the psychological factors like the premorbid personality, etc. If someone is aggressive throughout their lives, you would expect them when they become demented to become even more aggressive and out of control. Similarly, the social factors, like if the carers change or being moved to a care home, moving to a different environment, they can also precipitate behavioral symptoms, psychological symptoms. The findings that we find are consistent are about the functional neuroimaging. They have yielded consistent findings, and they can be linked. The hyperperfusion in different regions of the brain can be directly linked to the symptoms. This is really the Cache County study, a very helpful review of the point prevalence of behavioral and psychological symptoms, as you can see here, about 20–25%. More importantly, if you look at the 5-year prevalence, it is relatively, it is quite high actually. If you compare that to a population, a care home population, the previous study, the Cache County study, was in a community. If you compare that to a care home sample, you will find the aggression is about 77%, behavioral disturbances are 82%. So with that in mind, we can see that these are the symptoms that result in people ending up in care homes and going into care. How do I go back? Just to give you an idea of the, this is a spectrum of behavioral symptoms in different types of dementia. I know it's a very small slide. I appreciate that, but again, you can see here the aggression in different types of dementia, and you can see that it's much more pronounced in frontotemporal dementia. And I think this is the depression scale. Even I can't read it from here. So today I'm going to talk about the delusions, the hallucinations, the aggression and agitation in one lump, and then I'm going to talk about depression separately because it has different treatment and different approaches to management. So what types of delusion do we usually get in dementia? There are 5 big categories, and as you can see here, the most common is persecutory delusions. The least common is infidelity. So in that respect, our data was quite different from your average Alzheimer's patient, not just being young, but presenting with rather unusual symptoms. The caregiver being an imposter, the misrepresentation of people, that is very common, but again, we will talk about it a little bit more. Hallucinations, visual in about 30%. Obviously, visual hallucinations are much more common in dementia than they are in any functional illness. We find it even more pronounced, 80% in patients with DLB. That was McKeith's work. Auditory hallucinations are less common. Again, Augusto Detta had auditory hallucinations. The phantom border phenomena, that's finding seeing people who do not exist, basically. It's quite an interesting, almost specific presentation in Alzheimer's. And they're not always upsetting, which raises the question of when to treat and when to ignore. So the misidentifications, they're quite a common theme, and you can see different types of misidentifications, including the mirror sign and the seeing somebody else, the phantom border syndrome. Agitation, this is the Cohen-Mansfield agitation inventory, and you can see these symptoms, the physically aggressive behaviors, they are the ones most likely to lead to complications and people being in care homes eventually, but they have been nicely grouped by the scale. Now, there are significant differences between the psychosis that we see in Alzheimer's disease compared with what we see in schizophrenia. The delusions are less well formed. They are the Schneiderian first-rank symptoms are rare, and more importantly, when we're looking at treatment, again, the response to treatment is much better and requires a smaller dose of antipsychotics than we would in all people with psychotic symptoms, with schizophrenia, that is. And this is a great piece of work looking at the economic value, the cost effectiveness of. We're going to talk about non-pharmacological interventions first of all. I think as as an approach, non-pharmacological approaches to treatment of behavioral symptoms should be primary. They are the go-to approaches, even though they are not always as effective and they're much more difficult to implement. So this study looked at the cost effectiveness of a huge number of interventions. It was a meta-analysis looking at around 6,000 papers, looking at 6,000 patients, 150 papers. As you could see, the evidence base has been mostly for the interventions on the top half here. The most effective are the ones that are tailored to the patient. So working around creating care plans, person-centered care, and some of the sensory interventions. What is remarkable is the number of interventions that do not work. This is a population that is mainly care home based, so they are the most difficult patients to look after. So what they came up with at the end is that overall the activities in care homes would reduce the symptoms, and that individualizing activities does not help, particularly having activities in place, engaging people in activities in itself can distract them from the behaviors that challenge. More importantly, this is for people who are in care homes, so we should not generalize for people who are in their homes, because these interventions would be very difficult to implement. Another meta-analysis looking at the interventions that work and don't work. Again, focused behavioral interventions work, and music therapy is the only sensory intervention that they proved to work. So how do we approach it? How do formulated treatment work? I think this is really a key slide, and it's really about tailoring the treatment to the patient. So we can't just have a one-size-fits-all approach to behavioral symptoms. We have to assess the behavior, look at the tailored approach to non-pharmacological management, ensure that the family are involved in the understanding of what the behaviors, where they come from, what precipitates them. If we look at things like, for example, when patients are receiving personal care, whether the way it's applied, whether it's a man or a woman, these things need to be taken into account before we can formulate a plan that works. Using life history to understand the patient, to understand where they come from, and be able to tailor the approach. And then once it starts working, we need to revise it, see which elements do not work, which elements need to be implemented in the ongoing care plan, and repeat. Now I'll talk about the easier approaches. Well, the atypical antipsychotics, as we know, I mean, the only two drugs that are approved are risperidone and haloperidol, and I'm assuming that very few of us would still use haloperidol in this day and age. So the most important study was the KTAD in the 2006. 4 groups were randomized. As you could see, this slide is about the time to discontinuation, and you can see here the separation between olanzapine and risperidone, the top 2 drugs. And then the bottom is quetiapine at 50 to 100 milligrams was not effective. And at the bottom is the placebo group. So the drugs do work. However, there's a 1.7% increase in mortality, and they worked across a range of symptoms, as you can see. This slide is looking at a study that was done by Reeves and colleagues, looking at the therapeutic window and why we can use these small doses, and they are actually effective. The falipride D2 receptor imaging, it was an open study of 28 patients using amisulpride. It was effective, and the clinical response was a reduction in aggression scores. And you can see here the first image is for the D receptor occupancy before the small dose of amisulpride. And this is with a 25 to 75 milligram dose of amisulpride. You can see very effective receptor blockade. They hypothesized that this is probably due to the blood-brain barrier being very leaky. Now, another study looking at the impact of cholinesterase inhibitors. There has been a lot of work on whether cholinesterase inhibitors reduce psychotic symptoms, and the answer is they don't. Basically, as you can see here, all the double-blind placebo-controlled studies, this is a meta-analysis, and it has showed a negative effect. Even worse, if we look at mirtazapine, this is a very good study that was conducted by Subi Banerjee, and the mirtazapine did not work for people with agitation and dementia. It actually increased the mortality, even though this was not a significant statistically. It was just marginally statistically significant. But what it highlights is that many of the drugs that are used have no evidence base behind them and can actually be dangerous. Similarly, we know of a lot of groups that do not work, including the valproates. Their evidence for work in agitation is very slow, and most probably they're harmful. So I think this is a very good quote. I think when we're dealing with psychotic symptoms, we're really caught between the devil and the deep blue sea. We know the antipsychotics work, however, it comes at a price. Now we talk about depression quickly. Depression and dementia is again very difficult to capture because people are unable to express themselves. However, there are certain pointers, so behavior, observing the patient, looking at, listening to the family, and eliciting a good personal history. Also, rapid decline can be a pointer to depression and dementia. The hypothesis, a lot of it is about neurodegeneration. As you can see here, neurodegeneration of monoaminergic nuclei in different dementias. You can see that it's quite a range of receptors and changes across the different dementias, and we won't go there. But what it highlights is the fact that antidepressants, there is a reason that antidepressants do not work. And you can see this is a very, again, from Subi Banerjee's work, sertraline or mirtazapine, both of them did not show any efficacy in treating depression in people with dementia. Even more so, this is a Cochrane review from 2018. And again, all the antidepressants that were trialed, including TCAs, the final effect was non-statistically significant. So with that in mind, we are fully aware that antidepressants do not work for this group of patients, probably or possibly related to the significant neurodegeneration. The only good news that I have today is that the comparative efficacy, the interventions for depression and dementia, this is looking at a wide range of interventions here, and a lot of them actually do work. The authors of this meta-analysis, which is fairly recent, have highlighted all these treatment modalities for depression and dementia, which are quite effective, including cognitive stimulation, personalized care, psychotherapy, reminiscence therapy, so animal therapy. So all of these interventions do work in people who have depression and dementia, but antidepressants don't. Thank you very much. I think this is my last slide, and I hope this has given you sort of a brief overview of where we are.
Thank you very much. Good talk. And moving on, I will introduce my friend, Professor Taim Al-Maigil, who is a professor of neurology and behavioral neurology at King Saud University and he's the head of the academic committee of the Saudi chapter of behavioral neurology. Taim did his neurology residency and behavioral neurology fellowship in Edmonton, and has since been one of the leaders of the field of behavioral neurology in Saudi Arabia and the region. Taim will speak to us today about frontotemporal dementias and give us an update.
Thank you for the introduction, and thank you for the organizers for inviting me and allowing a talk that isn't Alzheimer's disease. All right, so what I'd like to, we're just going to discuss overall the clinical features, go over some changes in what happened in pathology and genetics with regard to frontal temporal dementia over the years. And we'll talk a little bit about ongoing research. So we'll start from the very beginning, when it was first described by Arnold Pick, a Czech pathologist, and he identified a patient who had atrophy, predominantly in the frontal and temporal regions. This was later on investigated further by Alzheimer, who had done pathological study and identified the finding of the PIC bodies, which are basically now tau positive neurocytoplasmic inclusions. Later on in the 1990s, the term PIC's disease was used for some time, but later on that was dropped. It's now one of the pathological forms of the disease, and we'll talk about that. All right. So frontotemporal dementia is a very heterogeneous term. It encompasses a lot of different clinical and genetic and pathological differences. It's very disabling when it happens, particularly since it happens in young individuals. And can manifest, of course, with different types of symptoms. Symptoms related to language, symptoms related to behavior, and other types of cognition, in addition to Parkinsonism, if you went with the further extension of the clinical spectrum. That would include conditions that are like progressive supranuclear palsy or cortical basal syndrome, or even apraxia of speech. So incidence has been variable across studies. It's not as common as the other dementia, so you don't get very accurate assessments, but generally it's around 2 in 100,000 person years, and it ranges, between 1.7 to 4. And still, even though it's common in a younger age, it's still more common in those above 65. One European study that looked at multiple cohorts showed the peak occurring in the late 60s, or around 71 years of age, with a little bit more predominance in men. And again, the incidence was also different according to the subtype of the type of frontotemporal dementia, with behavioral being the most prominent one. As I mentioned, it's the second most common cause of young onset dementia. And so Alzheimer's is still king in this area. And if you look at the prevalence studies for frontotemporal dementia, one is from a brain bank, one is from Medicare services. You can see that Alzheimer's is still the most common, with some variation between reports between the prevalence of Lewy body and vascular dementia. And then later on, frontotemporal dementia will come in between 1 to 5% of prevalence. And you can see in different studies across different centers the worldwide prevalence of frontotemporal dementia compared to Alzheimer's and vascular dementia. And with there is some change with age. The more you get older, the more likely you're going to have an amnestic type with regard to dementia in general, more likely to have amnestic type of Alzheimer's disease, but it does increase as age tends to go up. So want to discuss the main variants of frontotemporal dementia quickly. And so we've got the behavioral variant, and there's the two language variants. Genetic variations that cause frontotemporal dementia, maybe around 20 to 30% of the time, where the rest is sporadic. So behavioral variant is less common to have memory problems, and it's just important to tease out what the cognitive symptom is. Is it truly a memory problem or not? Because most patients or family members will say that there's a memory problem, that recalling how to do things, but once you go into more detail, you can identify the actual cognitive domain or behavioral domain that's involved. And behavioral problems is a major sign: disinhibition, apathy, compulsive behaviors, and all of these. There's some impairment in emotional recognition, as well as in the theory of mind and having empathy and understanding what people might be thinking or what kind of situation they're in. Characterized by atrophy in the frontal and temporal regions when you look at anatomical imaging studies. The non-fluent variant is kind of like an expressive aphasia that slowly progresses over time, but the key thing is agrammatism. So maybe simple sentences might sound okay, but once they're required to talk more, they might have like a telegraphic speech or drop a lot of function words when they're talking. And there's some hesitation and there's some effort. There might be an associated apraxia of speech, or sometimes apraxia of speech can happen as an entity by itself. And so this image highlights the localization, which is in the left inferior frontal region. And you can see changes on FDG PET that mirror the anatomical changes. Semantic variant is different, where the grammar seems to be intact. But there seems to be a problem with their content, and so they're going to have a lot of circumlocution, trying to circumvent the words they don't recall, or the lack of knowledge in a way, because it's truly loss of knowledge or identifying what things are, more than just inability to name things. So they might be able to repeat single words, whereas repetition might be impaired if you're looking at a logopenic variant of Alzheimer's disease. Surface dyslexia is something you can see in English language, because there are many words in English that aren't pronounced the way they're spelled. You don't have this in other languages that have a more superficial type of orthography, or the way they're written. For example, like in Arabic, and in some, I think, European languages as well, maybe Italian and Spanish or something. One method that might be helpful is kind of using Arabic homographs. So these are two words that are underlined that have the same spelling, but without diacritic markings. They're pronounced. Anybody with appropriate knowledge of the word would be able to pronounce it in the correct way. So this might be helpful. Does require some grammatical knowledge, so it's yet to be seen how this would differ in patients with non-fluent aphasia as well. This is the classical appearance of a semantic dementia, and this is the same thing, a patient with the same type of dementia, but it's happening on the right side. And this particular patient came with, still had some agnosia, some lack of knowledge, of words, and also had a bit of prosopagnosia to go with it. So also on the spectrum is ALS, and it happens concurrently with FTT. Cortical basal syndrome, progressive supranuclear palsy. The cortical basal, both of these are have Parkinsonian features. Cortical basal syndrome will have some cortical features, sometimes more apraxia, alien lymph phenomena, sometimes myoclonus. PSP will typically have the vertical gaze impairment, along with primary progressive apraxia of speech. An FTD phenocopy is a something that's becoming recognized over the past decade as well. These are patients who might meet behavioral variant criteria for frontotemporal dementia. They're typically people who might have had a history of being difficult to deal with or stubborn or some personality issues. But it's not, they usually don't have, these are people who don't have the underlying pathology. And even studies that looked at patients with this picture over time don't find changes, for example, in certain biomarkers of degeneration. Also recently, there's been some criteria to identify mild behavioral impairment. This can happen along with mild cognitive impairment, so it's not one or the other. This was actually, designed for Alzheimer's disease patients, but it's also applicable in frontotemporal behavioral dementia, and it's helpful for identifying patients with early symptoms. So going on to the pathology, there's three main proteins or proteinopathies that are important is the TDP43, the FUS, and the MAPT that's responsible for tau. Now, beneath it, I have the genes that are responsible for these, but they're not always responsible for the disease state. That's related to a different collection of genes, which kind of makes things a little bit complicated. I think we discussed earlier about the tau protein and its important role in Alzheimer's pathology, but also in healthy tau. It's important in stabilizing microtubules. But it does undergo alternative splicing, and you get 6 isoforms, usually a balanced level of 3R and 4R types. And so usually what happens in the FTD variants is an imbalance. You might have more 3R, which we call the Pick's disease, or you might have more 4R, which is cortical basal syndrome, or PSP. Now, if you want to compare that to what happens in Alzheimer's disease, and so usually Alzheimer's disease, you have all 6 isoforms of tau that are involved. And of course, there's amyloid beta in the pathology as well. The regions involved are different than that seen in the FTD types. And there's a prominent memory impairment that you see with Alzheimer's disease. The pathology is different, and their paired helical appearance in Alzheimer's disease, where they're straight or globular in FTD tau types. TDP43, the other protein, is usually located inside the nucleus, and there is a accumulation later on that happens into the cytoplasm, and it leads to dysfunction. With regard to the main pathology types, the most common one is the TDP43 abnormal protein, followed by MAPT. These make up the majority, and a small percentage, maybe 5%, in that vicinity, would be related to FUS. And of course, Alzheimer's disease can always sneak up and co-occur in any of these cases. So TDP43 mainly associated with ALS or FTD ALS. There might be a small component of those also related to FUS. And TDP43 is related to semantic variant, prime progressive aphasia, and behavioral variant is related to all 3 types, most of it being TDP43. Even Alzheimer's disease pathology can sometimes give you an executive or behavioral type of Alzheimer's disease. So that pathology is also important to know, just like in cortical basal syndrome, where you can get it due to Alzheimer's disease. Pure tau would be usually the PSP, and also the cortical basal syndrome, but that might also have TDP43 and kind of mixed in non-fluent variant of prime progressive aphasia. So the most common genetic mutations that are associated with disease is the C9orf72, the GRN, and the MAPT gene. And those that are highlighted in yellow represent the genes, but FUS really most of the time is not associated with any well-identified gene abnormality. It's very rare to find actually problems with the FUS gene. So as mentioned, most of the cases are usually sporadic rather than the genetic type. And sporadic, there's kind of an equal distribution of tau and TDP43, a little bit more TDP43 pathology with genetic types. Penetrance is high, whether it is due to the GRN or MAPT or with the C9RF. And this is just an example of age-related penetrance. As it increases with age, more likely to occur. MAPT also has a very high degree of penetrance. So looking at some clinical features, there are some unique features that might happen with different genes, like that with the C9orf might be associated with the behavioral variant. The MAPT and the GRN mutations are both on chromosome 17, and thus they used to be called FTD17 with Parkinsonism, and so you get that. The MAPT is also associated with semantic impairments, as we saw earlier. And more temporal atrophy is with the tau MAPT, and more frontal is with the C9orf. GRN might have a bit more asymmetry and patterns. Neurofilament light chain, I think it's been discussed quite a bit today, and which is important in stabilizing neurons and axonal transport. And so it might accumulate when there is any dysfunction, and we see an increase in FTD. It is not unique to FTD. It might happen also in Alzheimer's disease, but we do see it higher sometimes in FTD. It's pretty high in something more aggressive like CJD as well. Another protein, which is a synaptic protein, the pentaxins or the NPTX2, might also have a role, but it's also, again, not specific and can be found in Alzheimer's. So if you want to think of the progression of frontotemporal dementia, whether it's semantic or non-fluent or behavioral variant, you can see that maybe 10 or 15 years before clinical onset, changes are happening, not too different than what we see in Alzheimer's disease. It's hard to get good data on the sporadic cases, so a lot of these are accumulated from genetic cases or patients who are at risk. And then later on at the onset of disease, you see a lot of increase in the levels of certain markers like NFL or NPTX2, or even tau levels. So, other helpful methods is fMRI to use bold signals to identify dysfunctional networks, because, any network, like the default mode network, salience network, language, semantic become impaired. So doing these studies can help differentiate the areas that are impaired. Of course, FDG PET was what's currently being used, and it's different than amyloid. Amyloid is helpful if you want to identify Alzheimer's disease, but again, you have to be cautious when you're dealing with very old people, because amyloid might tend to accumulate at that point. There are some different other PET tracers in development. Tracer needs to be something that can quickly bind and then release, so that doesn't cause any toxicities. There are lots of tracers, being developed. They do have limitation. They do have off-site binding, or they bind to other structures. But we'll see how things develop over time. It's a bit more tricky to detect sporadic cases with biomarkers. A lot of time, of studies that have detected certain proteins happened in a late stage. It's also not easy to detect TDP43. It's still not commercially available, only in certain research settings, so they doing it. Mutations in the GRN might lead to reduced progranulin levels, for example, and you can find this in carriers at a young age. And it does also play a role in TDP43 accumulation seen in some types. And as mentioned, most familial FTD are related to dipeptide repeats of the C9orf, and these are toxic repeats and produce polyglutamine, which might be something you can measure and see. We talked about glial acid protein, which is related to inflammation, which also happens in FTD, and levels can be elevated, but they're still elevated in Alzheimer's disease, so not very absolutely good at differentiating yet. There are some trials or some studies going on trying to detect TDP43 levels, and there is some potential for its use, and phosphorylated TDP-43 also. I think I've run out of time, so I'm just going to finish up. Here we've got, we're just going over the treatments. There's no recognized available treatment, definitive treatment for the condition, of course. You can try to treat some of the symptoms. SSRIs might be helpful in some of the behavioral or mood symptoms, some of the behaviors as well. There are certain drugs that have been tried in certain other behaviors, such as violent behavior, sexual behaviors, anti-epileptics. Cholinesterase inhibitors aren't typically recommended. No benefits clear from memantine in any of the studies. This time there is a role for speech therapy in those who have some language impairment, although the disease is going to progress over time. No easily accessible assays to detect TDP-43 tau or phosphoproteinopathies right now. And so that would help with designing certain targeted therapies. Perhaps coming, we'll see some changes over the coming years. There might be more promise in those that are related to GRN mutations. They're easy to identify and track, and progranulin is also easier to measure. So we'll see if this results in anything. There's even, in addition to the CDR that is used for tracking dementia, where you add some behavioral component and language component. So this potential addition can be used in trials if you want to measure response to drug therapy. There's some different trials going on, and they're targeted at increasing progranulin levels at this time. And so, in summary, frontotemporal dementia is still a very heterogeneous disorder, and the clinical profile, allows for identification of the different variants. However, you still have to be aware, for example, of Alzheimer variants that might manifest like FTD. So it's still important to differentiate these. No specific treatments are available. A lot has come from the understanding about the genes that are responsible. A lot of potential proteins are being identified as way to as a biomarker, and new techniques are emerging to identify these. And that's all I have for the update. Thank you.
Thank you, Dr. Tayyam. I have the great pleasure of introducing my colleague, Dr. Haytham Tayyib from Saudi Arabia. He is the Vice Dean for Graduate Studies and Scientific Research at the Faculty of Medicine, King Abdulaziz University in Jeddah, as well as Vice Dean for Graduate Studies and Scientific Research at the Rabi' Faculty of Medicine, King Abdulaziz University in Rabi', Jeddah, Saudi Arabia. He also serves as Chief of the Department of Medicine and Assistant Professor in Neurology and Psychiatry in the Division of Neurology, Department of Internal Medicine, King Abdulaziz University in Jeddah. Welcome.
Thank you, Dr. Marwan. It's a pleasure to be here and hear all of you speak and so on and so forth. And I'm hoping that this talk is as interactive as possible in the next 15 minutes. I was asked to present cases, and I chose a few that we can reflect on and bring up some of the challenges, the clinical challenges that have really we've been bombarded with them since the paradigmatic change in the Alzheimer world in the past bit of time. So. All right, is there a magic word or is so these are some of my disclosures. I currently serve as a president of the Behavioral Neurology chapter and sit on these advisory boards, and these are the objectives, really just to discuss cases together now or after and bring up some of these challenges related to case selection and how to talk to patients and figure out mimickers and ponder some of these difficult questions. So we can start with this case: an 80-year-old right-handed male who presents with forgetfulness, remains functional with this past medical history and a family history of dementia. And a cognitive exam that shows memory impairment, still helpable by cueing, started misplacing or misplaced the clock hands as well. This is MoCA score, Dr. Nasruddin. The neuropsych showed multi-domain amnestic MCI. His MRI showed mild white matter disease. His plasma p-tau 217 was 0.4. His amyloid PET was positive with our radiologists use a beta amyloid plaque level staging, and 3 is a diffuse A beta deposition. His ApoE status is 3-3. Would you consider giving amyloid targeting immunotherapies to this patient? If so, please raise your hand. Yes, this seems like the ideal patient, right? And we'll go through some of the things that I use to justify what I do in clinics. So these are the usual criteria, right? Somebody who's MCI or mild AD, measured as such clinically with biomarker evidence of amyloid and no major contraindications, including the risk of angiopathy and including the ApoE status and so on that figures into that decision, right? This is kind of my thinking at this point. If it's clinically and biomarker wise AD, it's sort of a straight path to discussing amyloid targeting immunotherapies. If it is not, there's a lot of soul searching that happens over here. If you're biomarker wise Alzheimer, but clinically you're not, then there's a little bit of soul searching that happens here. But if you're atypical AD, we still discuss kind of outside what was in clinical trials. We discuss amyloid immunotherapy. This is sort of how my thinking is. If you're typical AD, we proceed with trying to prove that it's what it is and proceeding with amyloid targeting immunotherapy. But it gets more complicated. So there's a couple of patients that I'm present that I saw in Saudi Arabia. So one of the things that weren't mentioned is that I practice in New York a third of my time, and in Saudi Arabia the remaining or the bulk. So this is a 60-year-old right-handed professor, CEO, was forgetful and was still practicing at the time, or was still working at the time I saw him, but it was starting to affect him. The memory impairment, his strong family history of AD, his cognitive exam is suggestive, highly suggestive of this being Alzheimer's disease, and culturally or otherwise, he was like, I don't want to have anything to do with you. See you later or never. Eventually continued to follow up with me, and we were able to give him rivastigmine with no further consideration of additional workup or treatment. Another similar situation, a 71-year-old who again presented with progressive forgetfulness and clinically looked like he had AD as well. And had plasma tau 217 of 0.7, and we had a long discussion in clinic about amyloid PET, and in this neck of the woods, which it's not approved yet, but it's we could get it through back doors, and after discussing how things would go and the costs and so on and so forth, people, they thought we'll think about it, and never came back. So I think a lot of considerations go into the conversation that we have in clinic. So what do I tell people in clinic? And it's one of the crucial things, I think. I tell them that what their clinical exam shows, and then I present the diagnosis as Alzheimer's disease in its early stages, and I emphasize that this is progressive, and that there are symptomatic treatments that we can give that are effective and improve quality of life, but don't stop the progression. And then we talk about amyloid targeting immunotherapies and the fact that they do not stop the decline, but tend to potentially slow it down a little bit, We talk a little bit about what the protocol is like, and when insurance is when the people will be paying for the meds or the process, the whole thing out of pocket. That is a significant part of the discussion as well. And I try not to be a car salesman, or at least I worry about that. I just basically draw the curves for people to make sure that they don't expect an improvement in cognition and so on and so forth. And I talk about the measures depending on, I use language that is understandable by them, but I emphasize that they may or may not appreciate a difference and that they are likely to see worsening. There's a lot of controversy about how meaningful the changes are, and I'm transparent with patients about that, and I think that's important, and it's part of our responsibility in the clinic. And then, depending on how much time and how long the discussion goes, I sometimes use this, showing the placebo on the left and treatment on the right, and that this is basically what happens at the end of the treatment with a small improvement. I think, and I'm belaboring the point, I know, but I think there's a responsibility, especially in this part of the world, to really set the expectations at the appropriate level. And even in where I practice in New York, there's folks that come to me and say, well, we're getting worse. And it's like, well, we kind of said that. And there's at least one patient that actually asked to stop the infusions because so expectations, I guess, is the point that I'm trying to highlight. I do also mention that even though the clinical trials, this is a long-term process, and that even though the clinical trials were a year and a half, we're looking at butterfly effects, and that the benefits may widen over time, and so on and so forth. And Dr. Sabag already mentioned a little bit the comparison with the ADNI population. So that figures into the discussion as well. In this part of the world, and also in New York, I also mentioned that the benefits are not as clearly shown in non-Caucasian populations, and I think that's important in our part of the world where genetics may be significantly different from those in clinical trials. Moving on, so this is a 68-year-old lady that I want to talk to you that came in with short-term memory difficulties. She's a college professor who, other than short-term memory difficulties noticed by her family, was really fully functional. A MoCA of 26 with memory deficits, MRI with mild white matter disease, but with mesial temporal atrophy, plasma p-tau of 0.4, ApoE of 3.4, and the plan was to do neuropsych and amyloid PET. The patient and husband were reluctant because they thought it was too early. And I think this and in the next cases where I'm highlighting the challenge of clinical staging and the potential discrepancy between clinical staging and biomarker staging, of which we don't really have something that is practically usable. So the fact that this person seems to have a high cognitive reserve and seems to be compensating begs the question whether it's not in fact too early, and it's in fact this is the ideal situation to intervene. I highlight a little bit what was shown from the Trailblazer trial, that people with a lower burden of tau seem to have done better according to what the data shows. So starting earlier may in fact be better. She's still unable to, we continue to discuss this with them. So what about him? 87-year-old professor of electrical engineering, who was in fact teaching until about a year when I saw him, with this past medical history and a family history of dementia. And positive p-tau 217 at this level and amyloid PET that's positive and mesial temporal atrophy and neuropsych consistent with AD. So would you treat him? Yeah, I mean, I treat him. He is on treatment. He's 87, so you can sort of say, well, we're sort of getting closer to the age range of recruitment in clinical trials. But again, this person is 87, has high cognitive reserve. How much amyloid is in there? Is he really, biomarker-wise, is he really early, even though he is early clinically? So that, again, the challenge of staging. So what about her? She's 71-year-old, slowly progressive forgetfulness for 3 to 4 years, showing really impairments, significant impairment in some of her ADLs. Their functional activities questionnaire was 17. She had significant depression, and she had rheumatoid arthritis and degenerative disc disease, and was on clonazepam and oxy. And she was apparently depressed during the clinic visit, did terribly, not just on memory, but also attention and a bunch of other measures. So I thought she was, the way I saw her, she was moderate and potentially, but I thought she was potentially also encephalopathic with something else going on. So what we did was we removed some of those. We removed the quetiapine and the clonazepam and treated the depression, and she got better. She was cheerful when she came back to me, much more lucid, and her attention improved, but she still had memory issues. Her tau 217 was 0.6. Her amyloid PET was positive, but she was ApoE44. So we decided not to treat, but this case highlights the fact that the clinical staging is really a challenge that we have in clinic. And the ApoE homozygous status is a good segue to what I tell people about side effects, right? So we discuss the proportion of people that might get ARIA, and I sort of tell them that it's in the name, it's imaging abnormalities, and that the majority of people aren't going to be symptomatic, but that there is a small risk of serious complications. And we discuss a little bit about stroke care and how it might change if you're an amyloid targeting immunotherapy. And we talk about the importance of having to have MRIs every now and then. And these are some of the reasons why people decline. And it's really, to me, it's still kind of an opt-in situation. I don't really try to convince people. I just present people with the information as transparent as possible. It would be wrong not to offer treatment or discuss it, and I think it would also be wrong to kind of push the treatment. What about her? Let me give you a little bit of context. So this is a 71-year-old lady who was I think, English professor. Seems to be getting a lot of professors in New York. With really no past medical history. Came in with mild memory difficulties, fully functional, and on exam has a little bit of spasticity in her forearms. But other than that, was doing okay. This is her MRI. No hypertension, no diabetes, thin lady, not obese. Would you consider treatment with an MRI that looks like this? No, you would think 100 times before doing that. This because of how that white matter looks, right? So we, I was kind of surprised because she didn't have any major vascular risk factors. So what we did was that we did an MRI and so on and so forth, and ran an inflammatory workup, and it all came back negative, and sent leukodystrophy workup, and turns out she has autosomal dominant leukodystrophy. So these white matter changes are autosomal dominant leukodystrophy. And does that preclude her from being considered for lecanemab? Leukodystrophy is not necessarily an angiopathy, and they're very keen on doing it. So this is would you go ahead? She's kind of pushing. So a lot of heads shaking no. So we initially decided to do it, and then we kind of rediscussed it again and said, well, you're kind of doing okay. We don't really know. This is kind of outside the what we routinely do, and so on and so forth. So we're at the moment we're just following. All right, this is a 47-year-old right-handed lady was presented as being forgetful, but really was a language issue in addition to depression. The significant findings in her cognitive exam are word-finding difficulty and difficulties with repetition and a little bit of executive dysfunction, as you can see from Luria over there. And her neuropsych agreed with my initial impression that this was logopenic AD, and this is not really the kind of patient that was tested in clinical trials, but would you consider giving her, since biomarker-wise she is kind of AD? So this person, I saw this person around the aducanumab launch time, and they were keen on, you can see that her FDG PET does show, by the way, asymmetric hypometabolism where you expect it to be, and her CSF did show Alzheimer's disease. So what they ended up doing was they ended up getting aducanumab, I think, here by somebody, and I didn't really, I don't know what happened with them, but the issue of having atypical and atypical clinical presentation is another challenge. It's AD biomarker-wise, it's not your typical patient that was recruited in the clinical trial. Would you consider? Is this the same story? 75-year-old right-handed female with progressive memory decline, but also reduced fluency, a lot of word-finding difficulties, had history of breast cancer and anxiety. All of them were kind of stable, did have some history that kind of suggested REM sleep behavior disorder. These were her testing scores, as you can see, in the mild range. But a lot of word-finding difficulty, a lot of paraphasia, circumlocutions, and impaired fluency, more category than letter, and perseveration, and executive dysfunction. And her testing was as follows. Her p-tau 17 was the intermediate range. Amyloid PET was negative. Her FDG PET showed asymmetric hypometabolism like you would expect in, my initial thought was this was a PPA, potentially a logopenic PPA, since she was grammatic, like Tame was explaining to us just a minute ago. Her CSF seemed to suggest early AD with a abnormal p-tau to A beta 42 ratio, and her ApoE status is 2-3, and she didn't have any abnormal genes detectable on the genetic panel. Would you treat her? Would you consider this AD? So it kind of looks like logopenic on the FDG PET, and the CSF, but it's really not clear to me, given the fact that the amyloid PET's negative. So what we're doing is that we're following. And the last patient I want to present to you is this person with memory, but also behavioral changes. She's one of the feistiest patients I've had in my practice. She came in essentially saying that I don't have amyloid problems. She's a medical editor at one of the journals. So she came adamantly, kind of irrationally discussing some of amyloid and Alzheimer's dementia literature with me. This is some of her past medical history. Of interest is that a recent diagnosis of OCD, where she would kind of scrupulously wipe the counters over and over and over, and a lot of irritability at home as well. And she was irritable in the clinic. She had neglect, which was kind of noticed before she came to me. She started bumping into things, and then she started becoming kind of clumsy with her arms on the left side. So somebody did an MRI, and it kind of looked like So this is her data. So the MRI kind of looked like that, and it was called a stroke. So when I saw her, I was like, well, things being common, this could just be a stroke that was unnoticed, but why is it so asymmetric? So you can see I ran the workup. So the p-tau217 was 0.8. Her FDG PET, it was read as right hypometabolism, but you're not, surprised because you can definitely see atrophy there on the MRI, and the white matter changes. And then her genetics came back as showing a progranulin mutation. So I think that's what she has. And again, so it turns out to be right. She didn't have amyloid. But the point is that the dementia world remains complex, potentially even more complex than it used to be. And contrary to what some of the hype might be about dementia being reduced to a particular plasma biomarker that you follow and you give treatment to clear and so on. And these are my take-home points. And perhaps the most important of all is that we need to maintain our scholarship and skepticism and compassion in order to serve our patients best. Thank you. And I will present the next speaker, Dr. Shahrukh Hashmi. Dr. Shahrukh, Professor Shahrukh Hashmi, currently, Professor Hashmi, are you here? There he is, our man. Professor Shahrukh Hashmi currently directs the research at the Department of Health in Abu Dhabi. He practices as a professor of medicine at the Mayo Clinic in Minnesota. He's an adjunct professor of computer vision at the MBZ University or Artificial Intelligence, and chairs many international professional committees and groups, including being the chair of the Worldwide Network of Blood and Marrow Transplant. He's the founding chair of the American Society for Transplantation and Cellular Therapy. And he is the ex-co-chair of the Center of the International Bone and Marrow Transplant Registry at the Health Services Committee in Milwaukee, in the US. Professor Hashmi will speak to us about the aging brain, premature senescence, and cognition.
Well, good afternoon. Assalamu alaikum. Thanks for having us, and thanks for having me. A little bit different topic, talking about aging brain, senescence, and cognition. This all came up a long time ago, actually, when we started doing clinical trials in senescence, specifically senolytics, and we started one after another trial for Alzheimer's prevention, MCI, and many, many other diseases. I have many disclosures, but none of them are relevant to today's talk. Opinions are my own, not Department of Health, not MBZ UAI, not Mayo Clinic, and other institutions I work in. So all of you know that brain is 2% of the body weight, right? But how come it uses 25% of the total glucose in the body? That's a huge amount. But what people do know about the physiology of the brain and how that's related with dementias. Over the past 2 years, the number of papers that are published in Nature and many other journals, which are relating the accumulation of toxins in the brain leading to dementias, have increased dramatically. And what we do know is not that glucose only. What determines after a while of glucose is actually the ketones. But then comes another research that was just published in Nature just a few months ago. That was really exciting to me because there were 2 papers, one on women and men Alzheimer's risk differentiation. But this metabolism paper was intriguing because it said that it's not the supply to the brain that matters as far as the brain neurodegeneration is concerned. And we're talking about all cells. So we have studies on astrocytes, we have studies on microglia, we have studies on every single type of cell. But actually, it's what returns back. That's carbon dioxide and many, many other toxins. That's equally important. So if there's a blockade somewhere in the brain, with vertebral-basal artery, for example, MCAs or part of the MCAs, then there's a huge effect long term. That's why there's a huge group of basic scientists doing the neuroinflammation clinical trials from basic science translation and then neurodegeneration. But in our field of aging, we actually say that the inflammaging is a field because the inflammation eventually can lead to the degeneration of neurons. And these 86, 90 billion neurons that degenerate start degenerating over time. There's a cycle that is irreversible over time. The neuroplasticity is a totally different concept. We're not talking about that. So in the connections of the brain, which are formed at a rate of what you can see here, as far as if there's adequate nutrition in this brain, for example, the synapses are formed at a rate of 1 million per second in the first 2 years of life. So if somebody has a deficiency of folic acid or iron or B12 at that time, there's going to be a huge effect throughout the life. The whole concept of EQ and IQs has been changing over time because of the physiology of the brain understanding. And that's critical to understand the overall risk of dementias over time when it comes to neurodegeneration and neuroinflammation both, or neuroinflammation eventually leading to neurodegeneration. So this is something that the neurology community, you, all of you, I'm not a neurologist, but are very familiar with, that over time, the brain atrophy happens, the the unusual patterns in the hippocampus first, and now we know it's a basal at the stem as well. You have more signs that we think is much more than hippocampus, that some patients can present with early onset Alzheimer's with changes. That we know how it looks in the MRI. But why does it happen? That's the fundamental question, right? The majority of the people that get phenotype, and let's dissect into the phenotype later on as far as the causes are concerned, it's actually a series of events that leads to phenotype changes, where it's memory, gait, or many other causes that are triggered by an event, whether it's vascular, or it's genetic, or many other causes. So if you see a 40-year-old person with PSIN1 mutation, PSIN2, APP, you've got ApoE4 measurements, it doesn't mean anything, in fact, unless you correlate with phenotype. I mean, a lot of them are actually having no disease at all. So the fundamental question is what causes, even in these people who are genetically predisposed, what can cause early onset dementias? And that's why some of you, when we're talking about clinical trials and discussing the clinical trials in dementias, specifically in Alzheimer's, we definitely discuss, and I do discuss the IND part when the new drugs are coming in. How do you differentiate between other dementias? I want a very clear demarcation that there is Alzheimer's, yes, but there's an absence of vascular dementias, because different studies have shown the overlap dementias to be present in about 20% in one series. In one series, 40% of the Alzheimer's had some degree of vascular dementias. Very hard to differentiate. But the point I'm trying to make is there's an insult that happens after, if somebody has got a genetic condition that can lead to early onset dementia. And that's why doing genomics alone is the biggest mistake one can do. You can do whole genome sequencing, whole exome sequencing in a lot of people. You can do targeted NGS panels. It's an epigenome that changes rapidly, and much more rapidly, just because of the coffee break we're going to take right now and the patterns of the people in this hall. If the choices you make will change your epigenome over time. And all of this affects the brain, right? 25% of the glucose consumption is brain. Ketones. Think about the metabolism and think about the effect on the brain. And this is all epigenome changes. And fortunately, today we have a lot more than just measuring the methylomes, CpG sites. We do histone biomarkers as well for the epigenome of the brain. When we published this paper some time ago, Jim Kirkland had already been leading many clinical trials at Mayo Clinic. And when we published, T14 pathway was just discovered and actually published and many of the biomarkers were discovered in Alzheimer's world. What we were trying to say is that it's very multifactorial. And I love to criticize myself, and the analytic field is the one we started in 2015 with IND discussions with the FDA. And then we opened the Pandora's box, and now there's hundreds of senolytic trials. The first in-human trial, I'll give you a story in a second, but the senolytics act on an area. The senolytic vaccines, CAR T cells, act on another area or another mechanism. Xenomorphics act, which delay the senescence. They don't eradicate the senescent cells, which accumulate in the brain. They act differently. The SASP factors are the most well recognized, right? We've had metformin for a long time, and how metformin acts, that's a very important area. The immune cell activation, as you can see, lymphocytes, NK cells, granulocytes, macrophages. Well, there's no lymph nodes in the brain, so the way it works is very, very unique. And in order to have a complete picture, we need to know the immunology, the T cell and the B cell physiology, what's happening in the brain and the NK cell, which leads to inflammation, detrimental effect. And in our aging meetings, where so many differential diagnoses come up from the multiple sclerosis that leads to eventually a degenerative picture of an aging brain. But as you can see in the box here, these three pathways are very well described, especially the P16 one. P53 upregulates in a lot of conditions, and that could be a real problem for cancers as well. P16 Inc. we can actually measure directly or indirectly by many different methodologies when a person is way before the dementia sets in at the MCI stage, and correlate with correlate with the scales that we currently use in clinic. This is tip of the iceberg. How you have millions of pathways, and we just heard new biomarkers being discovered, thanks to all of you. Some of you are really at the forefront of biomarker discovery, both in the CSF and the blood, and correlating that with the MRIs of the brain, fMRs, and many other things. But millions of pathways, millions of receptors, millions of proteins. You've got the single-cell RNA-seqs happening now. That's what we're doing in our studies now, single-cell RNA-seq, because that's the future of single-cell transcriptomics and proteomics, correlating with the epigenome of the brain and with the genome itself. Is machine learning methodologies that we're using. And that would be the answer, because common statistical techniques cannot predict the precision medicine models for Alzheimer's disease. This is not for you to read from here. It's just to give you a flavor that when we looked into the data that has been published to come up with the targets beyond the two senolytics that we started using, dasatinib and quercetin in 2015, and then fisetin, we found out there was many more pathways, and there could be many more targeted therapies towards those pathways. But obviously, the question is, in a patient, how are we going to measure those? That's the fundamental question, which is still not perfectly answered, despite we having the CSF samples, because you just cannot do the brain biopsies in these people. With traumatic brain injury, for example, there's separate pathways that are involved, and some of the drugs that we use to delay the senescence of brain may not work. Cancer survivors, totally different. Well, we know this actually because the SA beta gal is something we use as one of the markers. Actually, we can measure that as well when we use metformin, rapamycin, and other drugs for aging, for the risk and correlation with the future dementia as to whether it's going to decrease or not. Obesity acts very differently, and this is some of the markers given here, but there's a lot more. So the story that I was going to tell you is just for 1 minute. Cancer survivor. One of my transplant patients, she was 40, leukemia, AML, got transplanted, second time allogeneic transplant, and she came to the clinic one day, and over the past 2 months, the nurse coordinators and the NPs, they were telling that the memory has been decreasing rapidly. And she came and she was talking to me, and she's like, Dr. Hashmi, I'm getting better today. I'm getting significantly improved. Something's changing. I was like, what happened? She's like, I can see far. My myopia, I mean, she didn't say the word myopia, but this nearsightedness is gone away. I mean, and I was very shocked, actually. I was like, how come she's developing a disease of old age, 60, that she should have? She already had white eyelashes. And by the way, those of you who have seen the aging field, not Down syndrome only, the bone marrow transplant patients, which get 10 times the chemotherapy, and they got radiation totally toasted, 1200 centigrades, they develop white eyelashes, white hair at the age of 20. They get dementia at 20, just like the Down syndrome patient gets it, but much worse. Some of them, not all of them. So the combination of chemotherapies and radiation to the brain, the whole body radiation, obviously really increases a lot of factors in the brain that we have measured in these cancer survivors as a model for dementias, right? To see what actually can lead the, what are the factors that can accelerate the senescence. So here is the fundamental slide actually of what I've been talking about, the neuroinflammation and the neurodegeneration link. Over time, humans age at a very variable rate, depending on the gender, on the diet, on the exercise, and sleep patterns. Because the aging of the astrocytes and the microglia, the neurons, have been studied very well, actually, in literature of these individually, and then together with the niche, which is the microenvironment that we talk about all the time. And there's a lot of DAMPs and SASPs involved in both of them, and metformin is a classic SASP inhibitor. The downstream pathway is actually called mTOR pathway that some of you have heard, and that's where the drug sirolimus, which is called rapamycin in organ transplant world, is being used in clinical trials. And many of the trials have been completed for other aging diseases already. So if you want to knock out the SASP and decrease the DAMP production, which leads to fundamental neuroinflammation, and it's not just one area inflammation, by the way, it's uniform inflammation. All the areas, all the lobes of the brain get inflamed. It really can lead to an irreversible severe inflammatory storm that results, when it settles down, in some damage, and some of them are damaged irreversibly. So in order to act on those, we have different pathways of different drugs. I would say that the crunch of the story is prevention is better than cure. I'm going to ask you that question again. But for treatment, the SASP inhibitors, the senolytic drugs, which can eradicate the senescent cells that accumulate over time in the connective tissue. And really, it's a lot of debate that which cells become the senescent cells. We haven't proven it in humans, but we do have studies in many animals. The studies are actually going in animals to understand the brain physiology of aging. The highest ratio of the brain to the body is the shrews, and then the ant. Ant we can't do dissections. We did the sperm whales. They have the largest brains. I mean, a lot of experiments have happened in the past. But now we're studying this when it comes to the aging. And obviously the Greenland sharks and some of the sharks in the Arctic, they live to, and some of the whales, to 300 years. The elephants only 80 years. So that's why we're trying to understand the human physiology relationship of aging with those of animals, because we have the average lifespans of those. And CDS, all of you have heard, is Alzheimer's equivalent in dogs and cats, and happens in domestic. In wild, it's very rare. So there's got to be some reason, something we're feeding them. We're taking much better care compared to the wild, but something's happening to the brains. That's what's causing them to have this disease called CDS, the animals. This paper was published a month ago. I was in Greece, and I was so excited to read the details of this paper, because this was an aspect we hadn't incorporated in our research of Alzheimer's. We started the study with dasatinib quercetin, Jim Kirkland. We helped the protocol develop in many institutions in the world. In North Carolina, Dr. Orr published the first paper in 2023 of senolytics in Alzheimer's. All of you saw that. Phase 1 study, and it was successful, very safe, and did the CSF and the blood biomarkers. But then James Kirkland, Tamara, with the Harvard group from Boston, they published the paper, the phase 1 trial last year in Lancet, showing a very good, nicely done phase 1 trial of senolytics, dasatinib quercetin, for the prevention of Alzheimer's, not for the treatment at all. Details to be discussed in 15 minutes. It's impossible to go over the clinical trials. But then came the estrogen factor, because this recent study in Nature was really looking at the estrogen receptors in the part of the brain. Obviously, we have much more sophisticated machine learning studies we're doing all over the world, in fact, because the fMRI techniques are improving, but we're putting a lot more for the ROIs, the regions of interest. Even in 2.0 Tesla, we can actually do wonders with machine learning. We can see actually the receptors in this lady in the C, much more in the pituitary area. Obviously, the pituitary gland causes eventual release, the master gland of all the hormones. The estrogen receptors are much more here. It's a negative feedback loop, right? So this is another factor now we're going to incorporate in clinical trials to understand the physiology. I mean, there's many groups, as you know, in Alzheimer's, studying the women versus men differences postmenopausal. This postmenopausal patient, the receptors dramatically increase over time. So the time is up, and I would like to ask you the question now. In the light of what you just heard, it's impossible because it's a short talk, but how do you prevent the premature aging of the human brain? We're talking about Homo sapien brain, which is only one chromosome difference than a Neanderthal brain. So the answer is the pathways are so numerous, and the overlaps of so many phenotypic symptoms that happen because of the Lewy body, frontotemporal, Alzheimer's. There's so much overlap in these things, but the fundamental hallmarks of aging, what we call, are similar. So the answer lies in a very simple approach. No drugs are going to, it's unlikely, even if you give 1 trillion doses of the drugs that act on the amyloid or the p-tau protein, it's not going to help unless you take care of the appetite, circadian rhythm. The person who discovered that one had the Nobel Prize because of a good reason, the effect of circadian rhythm on the brain. Not to eat the junk food, eat walnuts. Actually, walnut looks like a brain, right? And the berries, the antioxidant. But that's just an example. And the sleep patterns and the exercise. I mean, there's hundreds of papers on exercise and prevention of memory loss, prevention of dementia, separate papers that looked into different outcome statistically. So with that, I'm going to end. It's in 15 minutes. I tried to explain a bigger picture of aging brain, human brain. Thank you very much for having me.
Thank you, Dr. Hashmi. We're going to start our first symposium. This is sponsored by Lilly. The speaker is Dr. McSweeney. She is a consultant interventional neuroradiologist, co-founding the Cognition Health in 2011 to provide specialist service for accurate diagnosis and access to the latest treatments for progressive neurodegenerative diseases and neurodevelopmental conditions and traumatic brain injury. Cognition Health is in 10 countries, including the US and UK, where individuals can participate in global clinical trials for new diagnostic biomarkers and brain and mind medications. Dr. McSweeney focuses on deploying the new Alzheimer's therapeutics and including therapeutics for CTE and other things. I welcome Dr. McSweeney to give a talk on changing the trajectory, a new era of Alzheimer's disease care. Dr. McSweeney.
Good afternoon. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Marwan. Dr. Marwan did the introduction. I'm very glad. It's a sponsor session by Lilly. I'm so glad that we had a couple of patients who started this treatment, Dr. Amiri, recently over the last 3 months in UAE. As far as I'm aware that there's around more than 20 patients who started on Consuela, and you have few of these patients. And we would like to know more about the expert, how to deal with these treatment. Can we have it on the screen here, sir? It's coming, right? Excellent. So next, we will see a video. Yes.
Thank you.
There's no sound?
At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
Slide ready. So next slide, please. Next one. That's my disclosure. Next one, Dr. Emery. Okay. So the question which is coming from Suhail and from the audience, what is your experience with ATT, Dr. Amiri, and what is the cause of that delay, if there's anything?
Thank you. So I'll just answer both separately. So first, just to say that our own experience with ATTs has been quite extensive because across our 10 centres, we've been involved in clinical trials for new disease-modifying medications for Alzheimer's for quite some time. And so like within that, focusing on the ATTs, we've managed now over sort of like, well, 9,500 treatments with this class of medication. So we've seen a lot in this context. And I should just say that in the clinical trials, as I said, we've had a lot of experience, but also now with the ATTs coming on the market, we've actually been able to treat patients as well outside of the clinical trials within our memory clinic. And what I should say really is that firstly, we've had so many patients coming forward and requesting these treatments, both through trials, but now on the market. And I think one of the most important things in terms of the missed opportunities is the fact that it's so important today to think about Alzheimer's disease really as a new paradigm and that it exists on a continuum. And I hate to say it, but everybody in this room, absolutely everyone, is on this continuum. And it really is a matter of having no symptoms, no biomarkers, maybe a genetic predisposition, but essentially being normal. Then there's a long period of time when people can be completely asymptomatic, but actually start to develop biomarkers. And this actually makes this disease an absolutely brilliant condition to treat because there is actually such a long warning period. And then there's a period when people start to develop the mild cognitive symptoms, and and then they obviously will progress, or if it is Alzheimer's pathology, they will progress to the phase 2, phase 3, phase 4 to 6. And what I really do want to point out on this slide here is that the time for treatment, as we all know, for these new ATTs is during the MCI, mild AD dementia stage. And there's really just sort of like two subtitles underneath on this graph I want to draw your attention to. One is the one about no functional impairment progressing to the mild impairment of complex function. And I cannot emphasize enough how people who actually sort of like do have a lot of formal education, they do have a very high premorbid IQ, they are actually picking up really quite early difficulties with functional problems because they are doing complex things. So I would really like to say that, you know, like please be sort of like aware in terms of not having people miss this opportunity today by picking up these mild MCIs and then obviously when they progress to the mild AD dementia before getting to the moderate phase. And I would just also like to say behavioral symptoms are very often a very early presentation, just a sort of inexplicable anxiety in people who haven't previously suffered from anxiety or depression. The disease progression, again, it is a case of picking this up as early as possible. And actually, due to the Braak staging, which you heard about earlier today, these symptoms in the typical Alzheimer's patient are very predictable. And again, can be very subtle. They're very slowly progressing, certainly at the beginning. And that is why they are so often missed. So again, I think it is listening to your patients so carefully, because in the very early stages, they have insight and they do know there's something wrong. I think the other thing I really want to emphasize is that the phase when the treatment is appropriate is stage 3 and stage 4. And you can see here that once you've reached stage 3, you're already tipping into this rate of rapid progression. And at stage 4, and I'm sure we've all seen it, I hate the expression, but it's almost people fall off a cliff. You know, they suddenly start to deteriorate, maybe over sort of like 4 to 5 to 6 months. So, you know, it's at the time they're progressed, they're really presenting, and it's obvious that there's something wrong. They're already at the stage of rapid progression. So it's really, please don't miss this.
So that's something very important, and that's what we notice as a neurologist, geriatrician, and psychiatrist, that as patients pass early stage of Alzheimer, that they will go very down and they will be dependent on a caregiver. So a question which is coming here, you mentioned that neurologists, geriatrician, internist, psychiatrists should be partner in decision making with these patients and should empower their patients to take the part in the treatment decision. What does that look like in real life? our community here, the family is playing a big role with the patients when they will come with a disability to take it. How do you approach these patients?
Yeah, no, thank you. I really do want to emphasize how important this is. And actually, the people or the person who first identifies that there's an issue is the patient. I mean, they really are the first people to notice. Then soon after, the family, close relatives will just start to pick up subtle changes. And they know the individual so well that it's easy for them to see that. And I hate to say this, and I think we've seen it in a number of presentations, it can then take anything from a year to 2 years for that individual to persuade their doctor that there's something wrong. And during that time, particularly today, this vital period of time for the possibility of a biomarker diagnosis and access to these new treatments is rapidly passing. So I think it really is. It is the individual who knows first that there's something wrong. Ultimately, they will later tend to lose insight, and that's actually when they will not want to go and see a doctor. But most people want to know. And actually, I think there's some very good data on this. And I would say that we certainly experience all of these aspects when we see patients. But this late evaluation, diagnosis 2 to 3 years after onset of symptoms is in the context of these medications, often too late. Underdiagnosed, 50% of people actually aren't accurately diagnosed. Today, with access to biomarkers, and here with p-tau217, I mean, that's just fantastic news that you're able to access that so quickly and easily. And then there's the problem without biomarkers of misdiagnosis, which is just as bad both ways. And then I think this is very interesting that it's 89% of people that were surveyed in the US said that they want to know if they have Alzheimer's disease. And I think this is important for two reasons. One, to take appropriate action if that is the diagnosis, but also if you have a reversible cause for cognitive impairment, you want to know because you want to potentially have that reversed. Early diagnosis, again, nearly half of care partners want to know because they need to plan. And then this thing about shared decision making, I mean, this is from oncology, and I think it's the same experience. But I think this is great. 67% of clinicians believe they understood the patient's quality of life priorities, but only 37% of patients felt the reciprocal of that. And also, most patients do appreciate the opportunity, even if their answer is they're not able to afford it. They like to have had the opportunity to have considered that and made the decisions themselves with their families, rather than the doctors making the decision automatically and proactively for them. And I think that is really important in today's world. And then, oops, sorry, I've gone too far. And then this is, I think, summarizes that in that this is looking at the priorities from the patient's perspective, and all of those things there in the middle, the maintaining daily activities, maintaining their health, mental health, because it is upsetting and depressing, and it is important to manage very carefully, giving the individual the diagnosis. But they do want to preserve their cognition and their memory. They want to just, preserve their independence. That's the most important thing to all of us, and maintain their personality. And these two statements, I absolutely promise, are the most common things that our patients say in our clinic. The patients say, I wish my doctor had suspected Alzheimer's proactively and investigated and given me a diagnosis some time ago. No one ever says, oh, I'm glad I didn't know about this until now. And then similarly from the partners, they feel exactly the same. And I can't tell you how upsetting it is when we see patients and it's too late.
Before going to the second questions, I can hear this voice from the audience. What we as a neurologist, as a geriatrician, as an internal psychiatry doing for the community, building this awareness that there's a new hope, there's a treatment. How about getting these patients so early to be scanned and to interfere? So I can mention that Dr. Manal, for example, she's very active in the social media, on the YouTube channels, that she's building these awareness between the community in Arabic language. We have other members who start to come on the newspaper to educate the patients about the early detection of Alzheimer's disease. Currently now, as I'm speaking, many patients are coming asking, we heard about these new treatment. We are hearing there's a new hope for our partner, our parents, that we can help them to be treated. So can you tell us more about the new innovation about Kinsella in treating Alzheimer's disease?
Yes, of course. And we have exactly the same experience. And we spend so much of our time, energy, effort just educating the public. That is probably one of the biggest sort of like things we do. But
One of the things that I admire nowadays, that for the last maybe 8 years, 9 years, the Saudis, they have the Alzheimer Association, and they're doing huge awareness in their community. I wish that we started this 10 years back in UAE, but I think that over the last 2 years, that awareness start to come more. Now, patients asking for a hope.
yeah, 100%, and never underestimate hope. It's huge. So the reasons I sort of believe in Kasundla, I'm just moving it along, is I have to say, and this is off the record, but just seeing is believing, and having seen so many patients on treatment and on open label extensions through the trials, I've just seen it. But obviously, as a doctor, and for this audience, the most important thing is the data. And I've just got 2 or 3 slides here, which in fact you've already had a preview of earlier this afternoon. But it's really just to say, obviously Kisunla is a medication designed to remove the amyloid protein from the brain. But does it slow down cognitive decline? And the answer is statistically, this has been shown to be the case. And so there's just 2 or 3 results I think are absolutely summarizing this. So primary endpoint of the integrated Alzheimer's dementia rating scale. And this looks at both cognition and also functional impairment. And what you can see here is when you take the overall population in the study, so this is in the Trailblazer 2 study where there are approximately 1,700 patients, what you can see is that there's a 22% slowing in the decline of this particular test. So suffice to say, lower number is worse. So you can see that here. And then if you take, this is interesting, if you take the low, medium tau population, who tend to be the patients who are a little bit less symptomatic, you can see that this result is even better. So there's a 35% slowing in progression of symptoms according to this test. Now, the next thing, which I think is also very important, and particularly for the way the treatment is licensed, using the CDR, which is a more sort of like general cognitive scale, the time to worsen, if you look at people progressing to the next stage, and again, imagine your mild AD dementia, if you're progressing to moderate AD dementia, you're getting sort of like outside the realm where treatment is appropriate. So 37% reduced risk of progression to the next stage in the total group, and then 39% in the low medium tau group. And then the other result, which I think is very important, and this is again emphasizing the reason for early detection, is in the MCI group with the low medium tau levels. So the, let's call it the mildest group in the study, a 60% slowing of cognitive and functional decline at 76 weeks.
So just guess about it. We have a screening tool in the community for those asymptomatic patients or early MCI, 60% decline.
Yes, I mean,
prevention.
This is significant without question. But obviously, and I know this is the sort of like question on everyone's lips is, but everything in life is a risk benefit, and there is risk with giving these medications, but there's a massive risk of not treating people, and nothing in medicine is 100%, but 99%. If they have high amyloid, they've got typical cognitive symptoms, they've got Alzheimer's disease, they are going to progress. There's, that's a certainty pretty much. So what are the risk factors with ARIA? So the frequent symptoms, headache, confusion, nausea, dizziness, I mean, these are just usually sort of like very mild. Obviously, there are more, and there's always the confusion between this and potential ischemic change, gait disturbance, visual symptoms, neuropsychiatric, and obviously very rare, but seizure, focal deficits. And the big sort of confusion really is whether this is misdiagnosed as a stroke and therefore mistreated. And I think that's the most important thing, is to make sure that your patients, their patient partner, which is very important, is very switched on, and the doctor is wide awake. The prescribing physician really needs to be paying attention to any of these potential side effects. And then having a low threshold, particularly in the first 6 months, 6 to 7 months, when ARIA is most likely to occur, to do an MRI scan if necessary before the next treatment. There are mandatory MRI scans at 2, 4, and 7 treatments, but an extra one if you're worried. But you can see here, I know we're running out of time, so I really will just say, because all of this information is published everywhere, but the important thing is that both with ARIA-E and ARIA-H, they occur anyway in these patients, but they're exacerbated by these treatments. But the most important thing is that the most people who've developed these symptoms, which is the minority, it's asymptomatic. And that is why it's really important to do the mandatory MRI scans, so that you don't treat on top of somebody already having symptoms. I'm going to rush through this a little bit because I can see the time, but it's important here. There is a treatment management program. So obviously baseline MRI must not already have ARIA, so less than 4 microhemorrhages, no superficial siderosis, no macrohemorrhages, and no ARIA-E. And the big thing really is whether or not the patient is symptomatic. If they're asymptomatic, the majority, if it's mild ARIA, then that's fine to carry on. If it's moderate or severe, moderate certainly interrupt, severe probably stop treating. If it's symptomatic, then interrupt before continuing treatment. Check MRI, make sure the ARIA-E has resolved and the ARIA-H is stable. And again, to make everybody secure, there's a whole program or a whole grid which explains the classification of mild, moderate, and severe ARIA. So there's no reason for confusion. But you need a good neuroradiologist.
So very interest data, very interest figures and numbers that you showed us, and it has been used in different parts of the world. I believe, as I said, that there's more than 20 patients in UAE since the beginning of the year started on this treatment. The audience, there's many junior doctors, there's other specialists who are sitting there, and they would like to know what's one message that they can go today with it.
Okay, the one message is the secret, and that is early action. And I literally cannot emphasize that enough. And in fact, just before coming into the auditorium, I did a sort of simulated test, which is actually on the Eli Lilly stand. Yeah, and I would actually, if anyone is in any doubt about the importance of early action, I would try that, because on the sort of like voiceover, it actually has the individual who you're sort of simulating saying, I wish I'd known about this earlier. And actually it's really powerful. It's the first time I've ever done it. And I was really,
it's
really
in the booth
impressed.
outside.
Yeah.
Prof. Yusuf, Uthman, and the others. Just go outside. It's very nice with the virtual investigation.
It's actually quite frightening. And then I think the sort of the last thing is obviously sort of like identify and recognize the right patients. And we've been through that and listened to so many excellent presentations today and yesterday about that. Engage in shared decision making. I do think that's important, because you also need the individual and their partners and the family to sort of like, when I say sign up, I mean like sign into this, because it's not just a drug, it's a whole treatment program. And as we heard, it's exercise, it's diet, it's sleep, it's everything. They have to put everything into this. And I'm very strict with my patients. Then act within the treatment window, and follow up for efficacy and safety, and stay wide awake when you're managing these patients.
Great. So we are at the end of this satellite symposium. I'm so happy that after more than 100 years after Prof. Alzheimer diagnosis, 2 patients on autopsy in Paris and describing all these tau amyloid after more than 100 years, there's a hope, there's a treatment which is coming in the market. It's not the end of the story. There's many new medications coming, different protocols, how to approach these patients. Is not just, this is part of the journey of these patients, but at least nowadays we have hope for these patients. We'll keep the questions till the end. Okay, so I don't see any raised hand there for any question. There's one there. Oh, Robert, you have a question. Please go ahead. Can we have a mic there, please? I can give you mine.
Thank you. Thank you for your comprehensive work. I'm surprised you haven't mentioned the observation that brain atrophy is enhanced by these treatments. Also, do you know if the patients can guess if they were in the clinical trials, if they were in the active or placebo group? And what about the possibility that placebo effect is responsible for the observed difference between the two groups?
So I think if I can answer them in backwards order. So the reason I said that from my perspective in terms of treating with Kisunla, I just go on the data from the clinical trial. And the clinical trial has been through strict stringent assessment and everything through the regulatory authorities. And that is the data. And the data is showing a significant slowing in progression of disease, but also symptoms. I think from your second question, which was related to the
placebo effect.
Yeah, the placebo effect. Again, I mean, that has to be answered by the results of the clinical trial, because the clinical trial was a randomized control, double-blind clinical trial with people 50-50 on placebo and on active medication. Now, what was quite interesting as an individual, as a principal investigator undertaking or managing the clinical trial in our sites, is that during the trial, when the patients developed ARIA and had to have treatment interrupted, they were actually so delighted because they interpreted that as being on active medication. Of course, we had to emphasize that ARIA happens anyway, so we would not know if they're on active medication or not. But patients certainly were delighted to get into a clinical trial, even at that time not knowing what the result would be. And as we know, lots and lots of clinical trials that patients have participated in have not resulted in the medication eventually getting onto the market.
Did you ask them if they knew which group they were in?
I don't, but obviously it's human nature for individuals to wonder which group they're in. But no, I mean, we say very carefully when we do the really very comprehensive consent process at the beginning of the clinical trial that, we don't know. I mean, we don't know. We are blinded as the investigators as well. So, of course, patients will wonder whether they're on the active medication or the placebo, but we don't know and they don't know. Except in the open label extension when everybody does know.
If the patient could guess, that would invalidate the results.
Well, I think your premise there would be the same across every single double-blind randomized controlled trial in the universe. I mean,
you can detect that, you can evaluate that by asking them if they guessed and see if their guess is different than 50-50.
Well, I won't know if their guess is correct or not.
At the end of the study, you would know.
Oh, when we get the results eventually, actually, what is quite interesting is when we are eventually unblinded, which is usually a long time after the end of the study and after the end of the open label extension. I think it's almost impossible to sort of like tell because that's such a long time after the end of the study. And we've got so many patients, I can't remember how every single individual person went. I don't think that there is an argument that the drug is in some way invalidated because people are guessing whether they're on active medication or placebo.
Thank you for that questions. I will go to the next speakers, then we will keep the questions till the end. So thanks for Professor Amiri to be with us today. We will go to the second satellite symposium by Biogen, and the speakers will be Dr. Marwan Sabbar. Marwan, well-known figure, and he's the chairman of the Congress. Welcome, Marwan.
Dr. Suhail. Thank you. So today I'm going to talk about lecanemab, but and unlike my previous conversation, which was a broad overview of the therapeutics, it's going to be specific around understanding the biology, real-world experience, and how we treat Alzheimer's disease. These are my disclosures. So we have to talk about, this is a very similar concept to donanemab, but I'm going to give it kind of from a different standpoint. So when we talk about clinical meaningfulness, we're talking about trying to articulate, why do we use these drugs? Skepticism aside, why are we treating a patient? And the answer is we want to prevent, delay, or postpone them from progressing to the next level. So that would mean prevent, delay, or postponing them from getting to dementia or more advanced dementia. And so we articulate clinical meaningfulness, which is, by the way, a regulatory discussion. And what we show is that extended independence, lecanemab extended independence in activities of daily living, 10 months, which is quite a significant decline, slowing in decline. Now, when we talk about amyloid, we talk about amyloid biology as a very dynamic process. The reason this is important is that we know that the monomeric species is a nascent protein, meaning that the brain does not think of it as a toxic species. And this is so important because the first generation of monoclonal antibodies said amyloid is amyloid, N-terminus, C-terminus, mid-domain, plaque, monomer, it didn't matter. When in fact what we've now learned is that the monomer and the dimer are nascent proteins. The brain does not recognize it as a toxic species, and only when we get to the oligomeric species of amyloid does the brain say, this is abnormal, this should not be here. That's when you get the microglial activation, the excitotoxicity, the tau reaction, and the neurochemical breakdown. So we understand that there are species of toxic amyloid, and that is the oligomeric species, the protofibril, the fibril, and the plaque. And when you get to the oligomeric species, you get all these changes occurring. And the reason it's important is also because lecanemab targets the protofibril, has high specificity for the protofibril with an affinity of 1,000-fold compared to other things. It does also target the fibril, the oligomer, and the plaque, but it specifically targets the protofibril in a very high affinity way, and that's considered to be important in terms of a therapeutic target. And so this is important, is that toxic soluble oligomers are considered to be toxic, and they're in fact causing direct toxicity to the synapses and the synaptic proteins themselves. And so it actually, when you have the oligomeric species, it damages the synaptic function, it causes synaptic dysfunction, and which in turn can lead to a long-term impairment on memory, because once the synapses are damaged, they're not communicating with each other. And you see that in this assay, in the bottom left and the bottom right, it's showing that not all species of amyloid are toxic. The monomer is not toxic. The fibril is not toxic. It is the oligomer and the protofibril. So I actually want to spend a moment talking about this slide. What this is showing you is the phase 2 study. Okay, so the phase 2 study, this is not the phase 3 study. This is a phase 2 study showing that the 10 milligram per kilogram group dropped your amyloid levels by about 85%, and that when you went to the there was a washout of 2 years. This was during COVID. There was basically no treatment and a long period of time before they went to the open label extension, and that your amyloid levels started to creep back up, but that the placebo group stayed high and the placebo group stayed high and then started to fall once you got to the open label extension. What we're seeing is also that the plasma A-beta 42 to 40 goes up. Remember, when it's going down, amyloid levels go down, that means it's being sequestered in the brain, so that's a bad thing. We do not want our plasma amyloid levels to go down. We want them to go up. And because if they're going up, that means the brain is clearing the amyloid. So I actually like this slide in particular as well. I want to explain this to you. So this is the phase 2 trial, not the phase 3 trial. And what it's showing you is that the patients that got the placebo declined about 1 point on the CDR, some of the boxes. And this is super important because effectively what you see is that in 18 months, the 201 study, this is a phase 2 trial, had very little decline in the treated group. And then this group actually was in this, there was no treatment in this in this period of time. So for 2 years, neither group got any treatment. And what you show, of course, is that in the 2-year period of time, the treated group never caught up to the placebo group, always stayed below the placebo group in terms of CDR, some of the boxes. So I want to say to you that people who don't understand CDRs, this is a structured interview. So I do a lot of clinical trials. You basically do a questionnaire, actually an interview of the patient, interview of the informant, 6 pages, and then interview of the participant, 3 pages. There are 6 domains, and you score 0, 0.5, 1, 2, or 3 on each of the 6 domains, and then you come up with those sum of the boxes. That's what they mean by CDR sum of the boxes. And so we're saying that there was preservation for long periods of time. So let's talk about the phase 3 Clarity AD trial. I want to make several points about the phase 3 Clarity AD trial. Number one is the 1-to-1 randomization. All patients did have amyloid in their brain confirmed by PET. All patients were mini-mental 22 to 30. They had to be impaired on their Wechsler memory scale. So Wechsler memory scale, they had to show some amnestic components on Wechsler memory scale. And importantly, and I think this is the thing that I tell these companies, and by full disclosure, I have relationships with all the companies. I say, stop using the word placebo because it is not a placebo. So 55% of patients in both groups, meaning lecanemab and placebo, were on standard of care. It means they were on donepezil, rivastigmine, galantamine, memantine. And so they are not on true placebos. There's no true placebos here. This is actually the correct term is lecanemab plus standard of care and placebo plus standard of care. Okay? So it's important. You're asking, do these drugs work? You're asking if the drugs are they better than the treatment? And the answer is yes, because this placebo group is on the standard of care. These are not true placebo patients. And they're 1-to-1 randomization, as you see here, and then we look at CDR. So understand what I'm saying to you is that you are trying to divine a clinical efficacy signal based on a patient interview to determine if removing amyloid has a benefit. It is not as nuanced and subtle as the MoCA. I would love to say it's nuanced and subtle. It is not. We're using a blunt instrument to make a clinical determination. And so why do I say this to you is that we show is that the patients on lecanemab plus standard of care was 27% slowing in the rate of decline on the CDR compared to placebo plus standard of care after 18 months. And to the point about the placebo effect, know that placebo effects never last more than 3 to 4 months. Okay? And so an 18-month trial has effectively built into the fact that any placebo effect has already come and gone. And so the realistic expectation is that the patients at the end of the study were 27% less impaired on CDR sum of the boxes by the end of the study. And then when you look at their ADCS-ADL instrument, so ADL instrument is the physician like myself is interviewing the participants' informant. Can they drive? Can they dress? Can they bathe? Can they write a check? Can they use their cell phone? Can they, do personal care? That's what the activity of daily living scale is. And they're saying is that the patients on lecanemab were 40% less impaired on activity of daily living at the end of the study compared to those on placebo. And so I say this to you because I really like to look at this slide. I want to show you a couple things here. First thing I want to show you is that the patients, this is a baseline on the placebo, and when you see this gray matter, white matter blurring, that's a positive scan. That means there's amyloid in their brain. You saw that plenty of scans of that this morning. This is a positive scan. So they're saying effectively no change in their amyloid status at the beginning and end of the study. But when you see the gray matter and the white matter very clearly differentiated, that's a negative scan. So this patient has gone from a positive scan to a negative scan for research purposes. And when we look at the amyloid levels, you see again about an 85% removal of amyloid by the end of the study. And what you see, this is flipped from the phase 2 trial, is that the plasma A beta 42 to 40 ratios go up. Again, going up suggests that amyloid is being cleared out of the brain because your plasma A beta 42 to 40 is increasing. So let me tell you a little bit about the 36-month data. I want to start out by saying this is the 18-month data showing you that the 27% difference, black line and green line. Green line is the lecanemab, black line is the true placebo. Again, both groups on standard of care. And then, so it's about a half a point on the clinical dementia rating scale. And when we look at the modeled ADNI data, so ADNI, as you heard from the man who created ADNI himself, Dr. Weiner, 20 years later, 7,000 publications showing you that ADNI was a very good way to predict who is going to get worse, what's the rate of decline, how much they're going to get worse. So in this group, what they did is they matched patient for patient, how a patient right out of ADNI, not on a monoclonal antibody, to the treatment trial. And they showed that when you projected them out by the end of 3 years, patients who were on lecanemab were likely to be one CDR point slowed compared to placebo, to a modeled group. And so I actually like this slide. Of all the slides, I like this slide the most. And why do I like this slide the most? Is because it tells you a very important thing. So this is saying to you at the beginning of the study, there was in the lecanemab Clarity AD trial, it was about 70% were on MCI and 30% were on mild dementia. What this is saying to you is that at the end of the study, 30% fewer patients with who got lecanemab were progressed to dementia compared to placebo. So this is a Kaplan-Meier survival curve suggesting that you were able to 30% fewer people were in dementia compared to mild compared to placebo, and if you were in mild dementia, 30% were fewer into the moderate dementia compared to the placebo. So what this is suggesting is that, and these are real good numbers, this is suggesting that this is slowing the rate of progression to dementia. And people ask me, why am I treating this? What am I getting? What do I achieve? And the answer is that by over a period of time, you're less likely to have progressed to dementia. Our goal is to prevent, delay, or postpone you from getting to dementia, because dementia is the dependent state. In mild cognitive impairment, you're still independent. You may have memory issues, but you're still independent. When you progress to dementia, you're no longer independent, you've become dependent. So I also want to say to you that when they looked at amyloid status, the patients who had modest, even less amyloid actually had even better effects compared to the overall population. So people ask me next about safety. Just like donanemab, there's always the discussion about safety, and what you have to understand is that adverse events are common even in the placebo group, and they don't differ statistically by placebo or lecanemab for adverse events or SAEs, but ARIA events do go up with lecanemab compared to placebo. So ARIA stands for amyloid-related imaging abnormality. It is a safety risk, and what is holding most people back is this fear, okay? Now, I have to tell you, I have 50 patients on lecanemab. They're doing fine. I had 6 ARIA, 5 were asymptomatic. 1 had symptomatic, he was 4-4. He had talked me into doing it. I was really scared to do it. But the other, I remember one of the patients who had ARIA, I called him up on the phone. He's like, I'm in Mexico on a beach vacation. I'm doing fine. Why are you calling me? So he was not having any symptoms of his ARIA. So the point is that most ARIA is asymptomatic, number one. Number two is that ARIA tends to occur in the first 180 days. Number three, ARIA is strongly dependent on your APOE4 genotype status, homozygotes having a high amount, and that the effects. And number four is that radiographic ARIA does not correlate with clinical severity symptoms. So patients with mild ARIA radiographically can have severe symptoms. Patients with mild ARIA clinically, mild symptoms can have severe radiographic changes. So you need to understand that ARIA is part of the risk, but it is, for the most part, manageable. So I'm going to show you a case study. This is a 79-year-old gentleman with 18 years of education, self-referred for memory loss, cognitive changes, and histories obtained from his spouse. He has been having repeating himself, asking the same question for the last 3 years. This could be a Dr. Hatham patient, and self-reports agreeing with the spouse, noting a decrease in sense of direction and poor recall. When we examined him, his APOE4 3-4 plasma shows that his A beta 42 to 40 is reduced, which suggests there is Alzheimer pathology. Neurofilament light chain is normal, so there's no neurodegeneration. P-tau is elevated at 0.44, and p-tau 181 slightly elevated at 1.35. His MoCA is 22. His functional assessment staging score is 3. The one thing we haven't talked about today at all is that you must do assessment of the MRI for microhemorrhages, because above 5 microhemorrhages on a baseline screening MRI, you have a very high risk of developing ARIA. So MRI is part of the risk stratification. ApoE is part of the risk stratification MRI. So this patient had no microhemorrhages and was not on anticoagulation. And so we call this mild cognitive impairment due to AD. And what we show is that he had on serial MRIs no ARIA, and after a year, this is the pre and the post patient. This is now considered to be a negative study showing there is no evidence that the amyloid has been removed. So the next thing I want to talk to you about is the real world evidence of use of lecanemab. So this is a study that I'm leading, actually, showing that these are patients who actually received the prescription of lecanemab. I didn't treat 3,000 patients. I'm saying that I'm doing the study of the analysis of the data. I just want to be very clear on that. 3,200 patients have received lecanemab, and what we really wanted to look at was it used appropriately, used on label, used safely, how long was it used, etc. And what you see is that, and we had at least a 4-month follow-up. The one thing I want you to see here is very important, and I like Dr. Suhail's enthusiasm. I want to say to you that patients stay on this drug. When it comes to MABs, if they don't have a complication, they want to stay on these drugs. They show up to their appointments, and so you're going to see the same thing. They're going to commit to their infusions, and they're going to stay on their infusions. So this is showing there was high adherence. 85% of patients were still on treatment after 4 months. And what it shows here on label is that patients got 2 infusions a month of lecanemab, got them every 16 days as you would expect, had their first MRI after about 6 weeks. I want to tell you that the data so donanemab is about a year approved, lecanemab 2 years full approval. Now we have thousands of patients worldwide receiving treatment. The ARIA rates reported post-approval for both lecanemab and donanemab are actually lower than was reported in the clinical trial, because doctors like us are being super careful, being super choosing of our patients to say these patients are appropriate or not. And so I think what is done is we've actually gone to the extreme, and what we're seeing is lower ARIA rates than was reported in the clinical trial, which is a very good thing. So we're doing our job with safety, we're choosing our patients carefully, and so I would say to you that it suggests that this can be managed well. And you're seeing that quarter over quarter, the use of ARIA of lecanemab is growing. In summary, both insoluble A-beta plaques and soluble oligomers contribute to AD pathophysiology. Lecanemab targets both insoluble A-beta plaques and soluble oligomers. Lecanemab quickly reduces amyloid burden and that in lecanemab treated continues to accrue benefit even 36 months later. Clarity AD shows that area E is manageable, and in the long-term use of lecanemab, treatment with the DMTs is clinically meaningful. It slows or prevents the progression to dementia in 30%, and DMTs now have long-term data with 3 years data for lecanemab, and we are looking at now post-lecanemab. I want to say to you now, I have patients of my own who are have no more amyloid in their brain, and I've now put them on maintenance therapy once a month. That's the new approved label. I have patients now that were waiting for the subcutaneous formulation, which will be approved in the United States, I believe, in August of this year. So patients with long-term data will actually be on subcutaneous treatments by the end of this year. And just, I think this week, if I'm not mistaken, lecanemab received EMA approval. So we know that there's some data to suggest that lecanemab can be used safely and responsibly with reasonable good efficacy benefits. And with that, I thank you. I know we are ready for our coffee break. I don't know if we want to take questions or we'll just go to our coffee break. Okay, thank you.
Recording stopped.
I am trying to find out. I'm trying to follow up on the observership. Only I have a smaller question. Yes. Yes. Okay. Yes. Yeah.
Recording in progress.
Should I start with this? Thank you. Assalamu alaikum wa rahmatullah. Ladies and gentlemen, thank you all for coming here and congratulations to the organizing committee for having such a beautiful conference. I'm Dr. Nasf Al-Zubaydi. I'm the chair of Mental Health Council in Saha, and I'm trained in geriatric psychiatry and cognitive neuropsychiatry. It's my pleasure today to introduce Dr. Hamad Al-Sinawi, who is a senior consultant old age psychiatrist and the head of Department of Behavioral Medicine at the College of Medicine and Health Sciences at Sultan Qaboos University and the chairman of Oman Alzheimer's Society. He completed his residency and higher training in London and specialized in old age psychiatry. He established a memory clinic at Sultan Qaboos University Hospital, which provides training to medical students and psychiatry residents. His research interest is in cognitive impairment and mental health well-being, and he has several publications in high-impact journals and 3 book chapters. He is a member of the National Bioethics Committee in Oman. He has a weekly column of which I'm actually a fan of. Today he's going to be speaking to us about ethics and dementia. Ladies and gentlemen, please applaud Dr. Hamad Al-Sinawi.
Assalamu alaikum wa rahmatullahi wa barakatuh, and thank you for the organizing committee to invite me. It's my pleasure to be with you and Thank you for making it so far. It's been a very long day, and inshallah, my talk will be interesting and stimulating. This is my declaration. I don't have any conflict of interest. I'll be sharing real cases of patients that came to my clinic. The pictures are not representative of real patients. I have changed some personal information just to respect of patient confidentiality. These are my objectives. I will start by exploring the concept of medical ethics and how ethics intersect with dementia care. What are the common ethical situations that we encounter while dealing with patients and caregivers? What are the international frameworks and what can we do to improve the quality of care in terms of ethics in dementia care in the region? So basically, when it comes to definition, defining the term ethics, ethics is a set of beliefs and rules that govern the way we deal with our patient and caregivers, and a form of moral principles that govern the way we deal with our patient and the community in general. These are what is known as the medical ethics principles. They are inherited from a Western culture, and they are applicable to all different medical specialities. So things like autonomy, respecting patients' choices as long as they have capacity, believing that whatever you provide to your patients is of benefit for them, do no harm for your patients, not deliberate harm, consider justice when dealing with your patient and the rest of your community, and also respect their confidentiality by not sharing their personal data. This is an interesting way of differentiating between justice, equity, and equality, and sometimes the clinical situation or the place we practice determine that we go for justice might not always feel right, because sometimes you have to think about allocating resources for people into different settings. And sometimes when you are dealing with a certain situation, you need to be aware of your own biases. Where do your loyalties arise with? Are you always by default loyal to your patients? Whose best interests are you discussing anyway? It's also important, since we are practicing in an Islamic and Arabic culture, to be mindful of the role of Islamic values in shaping our ethical principles. So in Islam, we have something known as al-maqasid, maqasid al-sharia, and these centers in the way we need to incorporate when we are dealing with our patients. So things like when we are dealing with our patient, we have to be mindful about protecting the religious principles. We have to be mindful about protecting life. So we don't perform any procedure that leads to patient's death. We have also to be aware of protecting patient lineages. Maybe this is not applicable in dementia, but things when it comes to reproduction and fertility treatment, you have to make sure that whatever procedure you approve is not going to affect the lineages of the person. Also the intellect of the person, and also protection of the wealth and property. So why do we need to talk about dementia and ethics? Basically, as we've seen from previous speakers, dementia is and some people use the term a global epidemic. The number of elderly people is rising worldwide. Aging is one of the first risk factors for dementia. As we've seen with the previous presentation, the number of people with Alzheimer worldwide is expected to increase through the coming years. Dementia is a very costly condition or disease to care for, although most of the time there is uncalculated informal care that up to $2.8 US are the amount of money costs and spent in dementia care. Two out of three people still think dementia is caused by normal aging, so stigma and attitude and lack of awareness in one of the barriers to early detection, and also up to 70% of people with dementia reside in the developing country, where areas and a system are not yet developed to address such needs. This is a study we published looking at the prevalence of economical burden of dementia in the Middle East, and it shows that this is an issue that needs to be further discussed in terms of making the services equal and available. We also need to talk about dementia and ethics, because stigma is a big issue. People still, regardless of their educational status, they find it stigmatizing to come to seek early diagnosis. The word dementia in Arab translates to al-kharaf, which is very stigmatizing, and I haven't come up with any term that is more acceptable. People sometimes use الاضطرابات الإدراكية, but that sounds too academic to be included and used. But I think most people are happy to use the term Alzheimer's to refer to other dementia. So we say dementia or Alzheimer's-like dementia. Also, ethics is important because patients gradually lose capacity, they become victims of abuse, embezzlement, and sometimes their best interest does not always align with the best interest of their caregiver. The role of family is very important in the Middle East because the family will eventually take over control of making decisions. Again, not all such decisions are in best interest of the patient, so you have to be mindful about how much of the patients are influencing your decisions. Difficulty sometimes in balancing between the welfare of the patients and this of their caregivers, and also lack of any guidance that will govern the way we deal with our patients. There's a stigma. So we talk about caregivers, and caregivers, as we know in the Middle East, is mainly done at home. Most of the government GCC countries don't have a formal care home, so the family eventually take over. And sometimes a single person end up doing all the care. They are involved in making all the decisions. They can be burnout. Their decision might not always be reflective. Sometimes they can be under lots of emotional stress and they are in denial. And all the psychological and stress and burnout can influence the decision they make. This is from an ADI attitude toward dementia, and it shows that up to 35% of caregivers globally denied the person with dementia the right to know their diagnosis. So this is a big ethical question. Do people with dementia have the right to know the diagnosis? Should we respect their family's wishes if they want to hide the diagnosis from the person with dementia because they are worried about his or her emotional state? Some of the common ethical questions that we encounter about hiding the diagnosis. Also, how do we balance safety versus freedom? If a person demands to live alone while we know that he is unable to cope because of his deterioration in cognition, shall we respect these wishes or shall we force the person to move and to live somewhere else? Is it okay to mix medication with food if the patient refuses to take the medication? How do we respond if a patient asks about a dead partner or parent? Is it okay to lie about the person? Is that ethical? Can we tag the person if they are wandering and we don't have a system of making sure they are safe and protected? And when do we start de-prescribing medication? When can we say we have to stop medication now because the person is worsening anyway? Duty of care, we always, as doctors, we are trained to have duty of care toward patients. When it comes with people who have cognitive impairment, the situation is slightly complicated because you only have the patient, but also you have the system of caregivers. So you have to look at the welfare of everyone else, the patient, the healthcare providers, and the rest of the family. And when it comes to therapeutical lying, although most of the governing bodies, like the GMCs, is against the lying or hiding the truth from the patient, some people talk about having more of a compassionate way of reorienting the person. So if the patient asks about a dead person or a dead partner, instead of telling them that the person died, and every time you tell them this, they go through the grief all over and over again, one way of suggesting of how do you deal with this is by reorienting them. So if they ask about a person, say for example, a dead father, where's my daddy? You can say the person is not around, which is true. You haven't told them that he is dead. But then you direct them to talk about certain memories about that person. So in this way, you save them from going through the emotional burden of feeling the grief over and over again. So this is one of the frameworks, ethical frameworks adopted in the West. It's from the Non-Field Council of Bioethics in the UK, and it's a framework suggested to us how to handle ethical situation in dementia care. So the first step is to have a clear belief about the origin of dementia. It's a cognitive disorder caused by brain disease. There's nothing related to bad luck. It's not a punishment from God, and it's something that related to a brain disorder. So understanding the nature of the condition allows us to communicate clearly to the patient and the caregiver. Also, about believing that your quality of life does not stop at the diagnosis. So people with dementia are still people. They can still practice their freedom, and they are respected part of the community. A person with dementia does not necessarily get stripped up from all his rights the moment they receive a diagnosis, and this is very important so we don't end up depriving them from their ability to make choices. Their values and their well-being is also important, as well as the values of people who are caring for them. People with dementia are respected members of the communities. They can still contribute, and with the right support, they can have a good quality of life. Every person has to be taken in consideration, so case by case. This is where person-centered care is very important in terms of getting the right needs to the person according to what do they require at different stages. These are some of the Mental Capacity Act, for example, applied in the UK, looking at how do we assess capacity, which help us make the right decision when it comes to deciding how can a person operate in a certain way, how can they make decision regarding their wealth, and how can they make decision about where would they live, and different kind of decisions. I'm going to go through a few cases from my clinic and probably will focus about the ethical questions. So we'll skip this one. This is about a 65 years old Mrs. A who is married. So she had a stroke, and because of her medical comorbidities, she ended up moving to her with her eldest daughter from a previous husband. The current husband, from first husband, sorry, who's dead. The second husband is 10 years younger, and he lives with his family in a different town. So because of her medical condition, she moved with her daughter. He ends up visiting every month. He will take her out for coffee. She will stop by the ATM machine, and she will withdraw some money and give it to him. The daughter was worried that this is a form of financial abuse, and that this act is not in the mother's best interest because this person is draining her out of her money. The mother felt that this person is her husband and she loves him, and he has the right to take some amount of her money because she has enough anyway. So the daughter asked for a capacity assessment. During the assessment, the patient appeared to have full capacity, and the conclusion was that people are allowed to make kind of unwise decision. It's her right to do what she feels with her money. She has full capacity. She understands that she believes this is a form of love, and she's entitled to make that decision. However, I think one of the challenges is that how do we know that this capacity is fading? So when do we decide to revisit and reassess this patient's capacity to make sure that she is not falling a victim of abuse from the second husband? This second case is about a 90-year-old patient with advanced dementia. He's bedridden. He started refusing feeds. The family were very adamant this patient would have a PEGS tube. The doctor who was in charge of this case felt that PEGS tube is not going to provide a prolonged life. PEGS tube has more complication than benefit for these patients, and that the family are being too emotional by clinging to this kind of invasive intervention as he prescribed it. So the question here, can the doctor impose his medical decision on the family? Can the family override the medical procedure, and despite of their emotional involvement? In that case, the family decided to discharge the patient from the hospital and go somewhere else to have the PEGS tube inserted. This was a little bit tricky because it involved a person from a Western nationality who came to visit a relative in Oman. So she had her daughter and her husband's daughter. Daughter and son-in-law. They were working in Muscat. So the patient came to visit with her husband. And patient has early Alzheimer's. So one day she showed up in the A&E with such bruises. When she was examined, when the history was taken from the husband, he said she fell down. When he left the room, she whispered to the nurse that actually she did not fall down, but the husband is getting angry sometimes because of her behavior, and he did slap her a few times. So the bruises were induced from a form of physical abuse. The tricky situation when we took more information, the question the nurse had whether she would respect the patient's request for confidentiality, because the patient asked the nurse not to tell the husband about this information because she was worried that he might leave her. The end situation was to understand that this abuse was not deliberate and it was done because the husband was a burnout caregiver. So having a family meeting, trying to resolve the issue, inviting in a formal caregiver would help this for solve the situation. One of the challenges here is that we don't have any formal rules or guidelines to safeguard these patients, and we don't have a form of respite to admit these patients. So the idea was not to criminalize the action of the husband, but to understand the context that it occurred while protecting and safeguarding the patient. This is a very common situation where a patient with cognitive impairment will continue to drive. And basically, one of the issues that the family is in conflict because they feel they don't want to take away the keys because they feel it was going to make the person angry. They feel it's depriving him or her from the right to continue driving. At the same time, they might minimize the risk this patient is going to impose on to himself and the rest of the public. And because we don't have a regulation where the police will stop or remove the license from people, sometimes we end up suggesting that the family will just deliberately damage the car or dismantle the batteries. Or because if they take the car away, the person becomes very angry and agitated. So this is like colliding with the family for the best interest of the patient. This was another interesting situation where a patient with Alzheimer's start to develop wandering because when he was young, he would go around looking for breeding camels and go around and bring them at the end of the day. So what his son observed that if the father is indoors, he will become extremely agitated, angry all the time, restless and shouting. So what he thought of, he will build up a big fence around the house and allow the patient to walk around. When we heard this situation, some of us pointed out that this feels like a cage because actually what the son was doing is not actually protecting the father, but he's like a big cage where this patient is wandering in. But at the same time, we have to balance between the reason behind this decision. At the end of the day, the patient is still safe and protected. The family will still look at him and make sure that he comes back inside the house when the weather is too hot. So it's about balancing doing things with the right intention, but it might sound or feel different when you're looking at it from a different angle. Okay. So what are the recommendations to address ethical issues when it comes to dementia care? I think it's important to establish regional rules and regulations that are consistent with the values of the people in these communities. We need to develop policies that addresses patients' protection and safeguard. We need to train students and health workers to detect symptoms of abuse and continue to have this conversation about the importance of looking out for ethical situations and addressing them. We need to conduct research study for the best practice to address ethical situation and support people with dementia and their caregiver make advanced directive because that would be the key in handling lots of situations. This is my summary. So dementia is a global issue. Ethical issues is something that we encounter in our daily practice. We need to be more vigilant in developing policies and training a healthcare provider in solving such situations. These are my references, and thank you very much.
Thank you very much, Dr. Hamid, for this insightful talk. Our next speaker is Dr. Walid Al-Karidi. He's a dedicated physician specializing in internal medicine with a subspecialty in geriatric medicine. He earned his Bachelor's of Medicine and Surgery in Saudi Arabia 2008 and went on to obtain the American Board of Internal Medicine certification in 2014, followed by a subspecialty certificate in geriatric medicine from Canada in 2016. Since 2018, he has served as the assistant professor and consultant at King Saud University. He also currently holds the position of General Directorate of Home Health Care at the Ministry of Health, a role he has undertaken since 2021. Previously, he served as the Director of Home Health Care Department at the King Saud University Medical City from 2020 to 2021. With a strong academic and clinical background, Dr. Al-Karidi remains committed to advancing the field of geriatric medicine and improving home healthcare services. Ladies and gentlemen, please welcome Dr. Walid Al-Karidi.
Thank you so much. So I think my talk is going to be a little bit of a lighter talk. We'll give some sort of an overview about how are we approaching dementia care in Saudi Arabia in light of these advancements and all the technological advancement. So I will highlight the growing burden and unmet needs of dementia, which we are affected by in Saudi like any elsewhere. Review some of the best practice and evidence-based model of care that we are trying to follow and adopt, as well as try to maybe wrestle with the business arguments and the convincing arguments for policymakers to prioritize care for dementia. Because as you know, like the case of dementia and age-related conditions, they differ from country to country depending on the prevalence as well as the makeup of the population. So what is affecting Western societies, the US, UK, with the growing ratio of older adults and age-related conditions, the effect of all these conditions on the healthcare system and society have a bigger toll compared to countries like the GCC and younger populations. So I think I borrow this slide from Dr. Hamid and his group. So with the most recent prevalence studies. The good thing is that we are seeing a lot of studies emerging in the region to inform us about the true prevalence of the condition, which can help us make the case of the how can we increase the sense of urgency to the decision makers. So from this study, we got that the prevalence is something around 4 to 6%. Being most prevalent in in Tunisia and lowest in Qatar. As the situation in Saudi is almost comparable to what's happening in most of the GCC countries. However, in Saudi, the oldest older adults are the the fastest growing segment of the population. Today, just with the latest census release, we have around 1.6 million older adults in Saudi, comprising around 4.6% of the total population. This segment of the population is expected to grow exponentially, and it is definitely one of the goals of the Vision 2030 to increase the life expectancy to 80. And is one of the most successful targets that we have reached so far. At this moment, the life expectancy in Saudi is 78 years old. So with all the advancement in health and social services, we are able to reach that target. However, this comes with a challenge, especially with age-related conditions such as dementia. If you don't mind, before going to that picture, for the next two slides, because we haven't released these data yet, they're going to be published hopefully soon. So if you don't mind not taking pictures for just for the next two slides. So based on the most recent, so we're trying our best to study the prevalence and get to use big data to understand the prevalence of the condition. So one of the studies that we are trying to further analyze is based on ICD coding. And the good thing is that in Saudi, we have widespread universal HIS systems, either in the private sector as well as the governmental sector. So based on these data, some of the results that we have so far that dementia is affecting around 6.4% of older adults, and the cases that we were able to count is almost around 1,100 or 115,000. We used the ICD-10 coding, and we also used some identifiers such as medications, either for dementia or antipsychotics, and this went through multiple iteration of filtration and a focus group to get to that study. that result. So the other thing is, the good thing is to understand where are these people distributed. Saudi Arabia is huge in terms of geographic distribution. We are not surprised to see that most of the cases are distributed within major cities such as Jeddah, Mecca, Riyadh, and Eastern region. However, we did have some results that deviates from what we think from either from our clinical work or from other studies. For example, dementia not being the most common disease, and there might be either vascular or mixed dementias being the leading cause, and that has to speaks into the limitation of the depending on ICD codes or big data analysis in terms of accuracy or providing accurate data. However, it does give us that layer of assurance because so far we did not have nationwide studies to give us a good understanding about the prevalence. Most of the studies that we have either single center or done in small like for example health cities. So from these studies, we found that the distribution of Alzheimer's disease across the region is almost similar. It does, and as I mentioned, it affects the major cities more than the southern cities and the northern cities, and it could be related to the absence of medical records in these areas, or it could be because of the consolidation of people around major cities such as Riyadh. We also, just a few weeks or a month ago, there was a study that was really published from King Abdul, so National Guard Hospital, and that would represent one of the biggest studies so far, also confirming our results. However, the finding shows a little bit of deviation, like or maybe the prevalence is less than we expected here in that study. However, that cohort is so the National Guard. These are hospitals that caters for soldiers or officers in the National Guard. So most of them are either younger population or their families, and they might represent a different cohort than the general community sample. So I would urge you to take some of these results with caution as well. So why in Saudi or in the GCC region we have to actually prioritize dementia care? We are not isolated from the burden and the effect, either economic or societal burden of dementia. Late diagnosis carries significant ramification and repercussions. Definitely, if we do not act now, we will have to deal with the significant consequences, such as unavoidable hospitalization, unmanaged behavioral symptoms, and family and caregiver burnout, which is definitely is one of the core elements that we really struggle with, especially in the absence of a holistic care model to cater for people with dementia. This eventually spirals down to healthcare costs, and it will stripe the healthcare system from priority funding for areas that the public health would require. So definitely we need a strategic, so it is a strategic window for us to act now before the healthcare system strain and all these issues get spiraled down into, culminate into significant negative outcomes. So I shared that slide from Dr. Hamad as well. Sometimes when you are trying to make the case in the with the policymakers, you have to actually raise the bar and try to make the economic business case. So as Dr. Hamad mentioned, dementia is one of the costliest conditions to deal with. Most of those who quote this figure, they would also say that dementia, if dementia is a country, it would rank on the top 20 countries, and specifically it would rank like the 16th of those countries in terms of GDP costs. So dealing with dementia is something that will if you don't confront it or confront the effect of dementia on the healthcare system and the societal system, it will definitely have a significant effect, not only on the families, caregivers, but also on the system as a whole. So the annual cost for dementia per patient in the States is around 20,000 US dollar. Around 50% of that cost is shared or put on the burden of the caregivers, and most of these caregivers are informal. Most of these caregivers are families, and if you don't have a holistic and proactive care, you cannot avoid hospitalization, admissions, polypharmacy, and so on. So there has to be a system in place to tackle these issues and deal with them. So we did a current stats analysis in Saudi, and we looked at what hurts us the most, and we share the same pain as most of the countries do. So dementia care is often crisis-oriented, as it is in most of the countries. There are multiple care transitions, and that's one of the areas of pain that most of the families complain of, that they have to go from a neurology clinic to a geriatrician clinic to a geriatric psychiatry clinic, then from the emergency back and forth, and so on. So there has to be some sort of a model for us to be able to address what matters most to them and meet them where they're at. Definitely, there's also aggressive and end-of-life care is not addressed, and we learned a lot from COVID-19 when it hits, how disproportionately affect vulnerable groups such as people with disability, older adults, and in particular people with dementia, rationing all the services and resources away from these groups, and how it affected them. So as we know, we have to have a life course approach to dementia. And dementia, if you deal with the condition itself, it spans or goes across multiple phases, starting from an asymptomatic to the latest stages of functional impairment and all the impairment that comes behavioral, psychological, cognitive, and motor. So whatever model has to address the dementia continuum as well as the life course approach. So as I mentioned, the pain or the challenges or the struggles that we deal with in Saudi or in the region is no different than what's going on in the world. Multiple studies in the past few years have emerged also to support that. Limited public health awareness about, and a very high stigma about the condition, as Dr. Hamid mentioned. Shortage of specialized healthcare professionals. Around 50% of the cohort of experts are in that room today. So, you can imagine that we do have a lot of gap in terms of specialized healthcare professionals catering for people with dementia. Also, there are insufficient integration of social work. Social work for us needs to be upskilled, trained, equipped to deal with the issues and the needs of people with dementia and their families, and to how to navigate them through the system to support them. Because as you know, there's a split between the social system and the healthcare system, and sometimes it's really hard to get all the benefits between these two systems. So we need someone who is able to navigate with the patient and help them get their benefits. We also lack a lot of models to support caregivers and payment for caregivers or ways to reimburse them for the care they are providing. And given the geographic distribution and the huge geographic distribution of Saudi and how big the country is, there might be issues related to unequal access. And Dr. Hamid as well, he was talking about justice, equity, and equality, and these are very important principles for us to address when we design care around either a common condition such as dementia. And we all struggle from the fragmentation, as I mentioned earlier. So what is the solution for us in Saudi? I think one of the promises and the key strategic initiatives are 1 minute. Oh my goodness. Okay, so one of the key strategic initiatives that had is the model of care, which is our story, or one of the north stars that we have guiding us to provide a holistic care for the whole system. In the model of care, we have 6 systems of care integrating into 6 layers. And it focuses on activating the person and the sphere around them, which is the families and the community, then the virtual care sphere, and then you can and trickles down, or it goes through the different layers of primary, secondary, and tertiary. And the 6 systems include being well. You have planned care, maternity, urgent care, chronic care, and end of life. So through that model, we can actually embed and incorporate the dementia care models. And if I take 2 minutes just to bring the care ecosystem and how to tie it into this. So through this model, we can try to plug in the care for dementias. For example, dementia is a chronic disease, so we can activate the system of chronic disease management for that issue. In the Keep Me Well system, we can focus on brain health and prevention, and we can leverage the urgent care for people with delirium, as well as BPSD management. And for maternity care, maybe not, we can plug in the sex-related issues that Doctora mentioned. So other than that, the end of life is something that's also an unmet need, and we can incorporate dementia, palliative dementia care into that system as well. So we also have other system-based enablers, such as the population health management, and we have the value-based health action plan for healthcare in Saudi, which is also another system-based enabler in Saudi that we can use. So we are not going to reinvent the wheel. We are going to learn from the leading international models. You guys all know about the care ecosystem, which have shown to reduce ED visits, reduce polypharmacy, and there is a significant return on investment by reducing avoidable admissions. It also proved to improve family burden and indirect costs. There are multiple systems and model frameworks that we can build upon since the early 90s. However, the most successful, I think, so far is the care ecosystem that depends on having a care team, navigator, a clinician who is either a nurse, pharmacist, and also a widespread access to protocols and basically guidelines that can help the care providers. So these are multiple studies showing the success story of the care ecosystem and how it could be scaled and rolled out into a country. It proved to improve quality of life with significant, statistically significant reduction, improvements in caregiver depression, with a number needed to treat of only 5 people to prevent ED visits and 12 to prevent moderate to severe depression. What an amazing holistic care model that will have significant, not only improvement for the whole dementia care, but definitely not only for Alzheimer's disease, but all the other types of dementia. And these are real hard outcomes that really matters for people. It also proved to improve polypharmacy, and for those who care about money is what matters most to them, and especially for decision maker and for those who ration or would like to design healthcare system based on cost. It did also improve significantly reduced cost of care by 3,000 annually. This ended up to become one of the most widespread models in the States, which is called it's a payment model, and I'm sure for those in the States, they know about it, the guide model. And this built on the success of the care ecosystem. It does address the main domains, having and compensation for these areas, especially the It's kind of an alternative payment model to address these areas that are not usually reimbursable. And that's what we're looking for, a holistic and compassionate care. There are other frameworks, and there are multiple frameworks that has been put forward by the WHO as well, such as the Global Dementia Observatory and the ICOP, which also addresses dementia as one of the pathways, which we are also trying to adopt in Saudi as part of our efforts in the ministry. The Global Dementia Observatory, it tackles 7 key domain areas from governance, policymaking, risk reduction, and it ends up by having data to support decision making. We are almost in the second or third phase in the ICOP implementation. Just before yesterday, we announced our geriatric for non-geriatrician program, helping the integration of the ICOP in Saudi. There's also, but before I end up, I just want to let you know that we have to. This is just a study to show how successful is the care ecosystem and the guide model, and how they were able to actually upscale it and scale it at a national level. And these are the reason why it was able to be rolled out and scaled up at a national level, reaching into like 22 sites in 2024. And it's because it's flexible. There is also a lot of free access to resources that people can use. It helped. It also tackled meaningful and important outcomes for the patient, the caregiver, and the healthcare system all at once. So that's how you can make the argument. Eventually, I just want to end up by this last slide. I apologize for the time. We truly need to have a human rights approach to dementia care, and because it's not a privilege, it's a right. And if you think about it, and if you take that let's say perspective when you address dementia and the people with dementia, you will know that you're not just giving them some sort of an extra service. It's definitely their right, either because they're people with diagnosed with disability, or because they have a lot of unmet needs that we cannot really match. So the WHO provided these principles or values to include them in decision making, policy making, and also planning. That the healthcare system and the healthcare provider are accountable for their care. And finally, we cannot discriminate against them in terms of either services and benefits. Eventually, Dr. Hamadi just talked about the legality, accessibility, and autonomy, which is very important for us to take into account. And sorry for the time, and I appreciate your listening. Thank you.
I felt like a bodyguard pushing him to finish. I'm really sorry about that. It was really an excellent talk, and I feel guilty. I think a professor there has a question. We do have 2 more sessions though, and I'm worried a bit about the time. Yeah, so we're going to take questions after 2 more sessions. So our next speaker is Dr. Fatima Abdallah. Dr. Fatima holds a diploma in nursing and began her medical journey working in the adult ICU. She later pursued her MD degree from the Arabian Gulf University. Following this, she completed her residency in internal medicine at Salmaniya Medical Complex in Bahrain, and then advanced her training with a residency in adult neurology. She further specialized with a clinical and research fellowship in epilepsy at the University of Calgary in Canada. She's certified by the Arab Board in Internal Medicine and holds the Canadian Board in Adult Neurology. Her research interest spans a wide range of neurological disorders, with publications focusing on multiple sclerosis, stroke, cognitive function, myasthenia gravis, epilepsy, and Parkinson's disease. She has also contributed to both local and international research collaborations, including partnerships with the International League Against Epilepsy and the International Movement Disorder Society. Her work continues to contribute significantly to the field of neurology in the MENA region. Ladies and gentlemen, please welcome Dr. Fatima Abdallah.
Assalamu alaikum and good evening. And thank you very much for the organizer for inviting me to speak on in this meeting. So my talk will be about lifestyle unmet need in our region. So just to save time, so I know we all know that the dementia has global challenge in terms of healthcare and social care, and it's even in the Middle East also region also it has a high prevalence, and it's actually the prevalence is alarming, and it's also the same study which is published by Dr. Sinawi, one of the author, and presented by Dr. Walid. So the prevalence of dementia actually also growing in our region, so it's very alarming. And it's estimated that the direct and indirect cost nearly 12 billion in our region. And it's what's alarming also that the cardiovascular disease burden, which is a risk factor for dementia also, is increasing. And in this study between 1990 and 2021, so as you've seen in the red curve, the curve is increasing exponentially. When we see the incidence and the prevalence, so there are some countries in our region which also already they have increased in the in incidence, particularly in Syria and in UAE. And then Egypt, and that's usually needs further intervention to ameliorate the effect of the care and treatment of patients with dementia. So I've already mentioned that the WHO action plan was published, and then there are risk reduction guidelines which were published by the WHO, and most of them are the cardiovascular risk factors, including social activity and hearing loss. And if we go and review the guidelines and then the recommendations, and if you see which I highlighted, so the level of evidence is very low to no very low in terms of the evidence available for such recommendation, especially for those patients with mild cognitive and dementia. And in the Lancet Commission have categorized those risk factors and divided them in early life, which education was important risk factor for dementia, midlife, and late life. And if you see, like most of the cardiovascular risk factors were categorized in the late life category. And in this publication, so the modifiable risk factors accounted for 35% of the risk. But then later in the later publication, if you've seen that most of the cardiovascular risk factors became in the midlife age time, when they have added, so there were 12 risk factors which were increased to 14. So they've added the lipid, high lipid profile plus the visual loss as another risk factor for the dementia. And then if you see, like most of the cardiovascular risk factor, which were considered in the late life, they were actually moved into the midlife. And you know, because of the, you know, that the pathogenesis of Alzheimer disease usually starts decades or years before the onset of the symptoms. So that's why the intervention has to be at earlier time. And based on the trial, so the cardiovascular risk factor, so they have arranged a keyed risk score, which includes the cardiovascular risk factors, aging, and dementia. So the higher the rates of the number of risk factors, the higher is the risk of dementia, and that's prediction of those person individual in the midlife. So if those all available, like if the risk is, if the score is 15, so usually they have more than 16% risk of developing dementia, and the lower one is 1%. So now in the next few slides, I will review some of the clinical trials and lifestyle intervention. So there are two strategies where they have measured the single domain lifestyle and the second and multi-domain lifestyle. So we'll begin with the single domain lifestyle where only a single intervention or single lifestyle factor was assessed on those trials. But unfortunately, the majority of the trials, they were either negative or they had very minimal effect on, especially on cognition or the risk of developing dementia. And similarly, they have many of them. They had randomization or methodological limitations, so that's why the outcome was not as great. So in this slides, I've listed those trials where they had control group, so where they have assessed, there is an intervention and control group, and where they had cognitive assessment before the intervention and after the intervention, and those trials which included at least 500 participants. Out of those, the first one, it was the dietary intervention, where they have assessed the omega-3 versus olive oil supplementation, and they showed no difference between both groups, and the follow-up was for 2 years. And the physical intervention with moderate intensity exercise for 2 years, that also did not show any difference between the control group and those who were the active group. With the cognitive stimulation, so there were at least some beneficial outcome in terms of, so there were two trials, active US and IHAM US trials, and although in the first trial there was no effect on the incidence of dementia in those on those who were followed for 5 years, but there were some improvement in their reasoning and speed training process, although the memory was not affected. And then in the other group, there were several important improvement in their attention and speed processing. So with multi-domain, so we know like usually the person when patients, when they come, so they have multiple risk factors, and I think it's multi-domain lifestyle strategies that will be more beneficial to at least to address multiple risk factors and to see the effect of the intervention. And we have like 3 stuck. We have the 3 major trials which had multi-domain preventative cognitive impairment. So the most important one, the finger trial, which was from Finland, which so for them, like they have assessed the neuropsychological cognitive assessment for those patients. So there were positive effect on the executive function as well as the speed of processing of the data, but there were no effect on the memory between those who had the intervention. So usually they have taken the diet, exercise, cognitive training, and plus vascular risk factor, and they have been followed for 7 years. The second trial, the pre-DIVA. So in this study, they have assessed the incidence of dementia and multi-domain cardiovascular risk factors versus the usual control they followed for 6 years. And it has not shown any difference between the cognitive assessment on an MMSE and that, and it did not reduce the incidence of dementia in the group. And then the last trial, which was from France, so they have used multi-domain cardiac risk factor, including omega-3, or just consultation with omega-3 or omega-3 with placebo. There was no significant difference between the three groups. So we know like the genetic background plays an important role in patients' risk for development of dementia. And the large genome-wide association studies, it's very important for us to assess those patients. So maybe such life intervention, maybe they were helpful, but it did not because of the genetic background of such patient. And the largest and then the only study which addressed this question, so this comes from UK, so where they have included more than around like 200,000 people with dementia and without dementia, and they have assessed multi-domain risk factors, including smoking, physical activity, diet, and alcohol consumption. And they have categorized those patients into favorable lifestyle, intermediate lifestyle, and unfavorable lifestyle if they had it all. And they have generated a polygenic risk score based on their genetic background. So there were more than 200,000 genetic alleles they have identified, and they have grouped those patients depending on the association, the genetic association with Alzheimer's disease. So they have been divided into low and intermediate and high genetic categories. And if we see, so those patients who had unhealthy lifestyle, they had higher risk for the development of dementia, independent of genetic background. And for those who had healthy lifestyle, and they had decreased incidence of dementia, decreased incidence of dementia. But on those patients who had a high genetic background, although the risk was reduced, but still did not eliminate the risk. So this means that still lifestyle is very important in preventing the risk of dementia, although still the genetic background is also an important factor. So if we see, like, unfortunately, so multiple, there are several studies that have been done, but we have not seen the outcome of those results as we expect. And we know, like, the unhealthy lifestyle, it runs throughout the life. And the genetic background, that's unmodifiable risk factor, and most of the cardiovascular risk factors are in the middle group. So in this review on Lancet review, what they have seen, those patients that so instead of just focusing on the modifiable risk factors, so then we need to also look into the brain reserve as well as the cognitive reserve of those individuals in order to protect them from developing the risk of dementia later in their life. And if you see, like with the yellow arrow, so most of the interventions has been carried out during either late adulthood or mid life to check the incidence and to prevent the development of dementia. And while still the onset of the dementia, the pre-symptomatic phase, usually it is a decade before that. So maybe it's important to address the cognitive reserve and brain reserve from early childhood in order to prevent such patients to develop later. And as we know, like the brain usually at birth, it's not fully developed, and still there are maturation and myelination of the brain, which continues until the adulthood life. So that's why it's very important to address that stage as well. So how about I will show you just a few studies on the cognitive reserve. So initially I will start with so if you give me just a few, I'm almost done. So so we know, like, education is very important in reserving the brain reserve, and then the green bars, which which highlighted. So those patients who had a higher education, actually, they had a higher thickness of the cortex. And similarly, in Alzheimer patients, the level of education inversely actually correlated with the thickness of the brain. And how about exercise? In exercise also there are data where there is effect of data, and it's studied. So there are 120 older adults who been having exercise for 1 year. So they have shown that there is increase in the volume of the hippocampus, and that training actually increased the volume of the hippocampus by 2%, and those that prevented the brain loss by 1 to 2 years backwards. So that's an important thing. And if we see also like in the graph on the left, so even with exercise, there are increased in brain-derived neutrophilic factor, which is also important for neurogenesis in the temporal lobe. And similarly, as the volume of the hippocampus increases, so there is improvement in the cognitive function of such patient. So similarly, also active person versus inactive person. So we know like the inactive person, and this in the Harvard Aging Brain Staging Brain Study Group, they have confirmed that inactive person, usually they will have more amyloid deposition in their brain, which was showed by the red arrow, and this is the orange line. Even it was correlated with the cortical and brain volume loss, and the thinning of the cortex of the brain was also correlated with the deposition of amyloid. So that's an important protective factor. I will just have a few slides on the ketogenic diet, which is it's been growing in the field of the Alzheimer disease. We know it's its effect in patients with epilepsy, and it's used especially in pediatric age group. But in Alzheimer disease also now there are research showing that its benefit, either ketogenic diet or low carb diet, which also induces ketosis. So in this study, actually in an animal model, it showed that ketosis can restore memory in a symptomatic animal. It also reduces the oxidative stress, and the amyloid also, it blocks the amyloid entry into the brain. And in this example, it shows the deposition in the hippocampus. So this is the carbohydrate, and this is the keto diet. So less amyloid deposition is there in the brain. And it also improves the mitochondrial function. Similarly, if in an MCI patient, so they have noticed, like this is in only 23 human, it showed also that with low carb diet, there were improvement in the verbal memory on those patients. And there was also a trend that insulin level, the fasting insulin level, was associated with a better memory testing in those patients. And since we are like in our region, so fasting also, like we usually fast yearly during Ramadan time, so 30 days. So in this small cohort and 50 healthy Muslims, so between 21 to 28. So what they have done, so they have assessed the cognitive function pre-fasting, and then 1 week after the Ramadan fasting, and then they have used the attention switching task and delayed switching task using the Cambridge neuropsychological test. And what they have shown actually, so the black bar, actually it's improvement. So they have shown improvement in those patients who been fasting in terms of the cognitive assessment. So there are also lots of data about the supplements, probiotics, and we already yesterday heard about the gut and GI access, but I don't have time to cover, and my time is up. But to summarize, at least we know that lifestyle is very important in ameliorating the effect of dementia, and I think it has to be a multi-domain strategies from childhood like until elderly life to prevent such dementia, and to not like we don't actually going through this preparing in this study, like we don't have much data about dementia in our region. I think it's and very important to have those data, and there is the international collaborative, the finger study. I think it's the way to go, where we should have to have collaborative work with the international institution to study dementia, as well as we need also regional collaboration to combat the effect of dementia. With that, I would thank you very much.
Thank you, Dr. Fatima, for an excellent talk. So the last talk for today is my talk. I'm going to be speaking about behavioral and psychological symptoms in the behavioral variant of of Alzheimer's disease. It's a cognitive test to operate this tool. So. Okay. Due to the limitations of time, I'm going to be rushing through this presentation. My objectives is to speak about the behavioral variant and to review the diagnostic framework, which is pretty recent, characterize different aspects of BPSD in the behavioral variant and outline assessment approaches, and compare management strategies. Just a quick historical background. In 1999, Johnson et al. Described 3 patients who they thought had frontotemporal dementia, but upon postmortem examination, it turned out to be that the pathology was Alzheimer's, and then the idea started that maybe Alzheimer's presents in atypical ways, and now we have a few variants of Alzheimer's documented. In 2022, there was a consensus on research criteria and diagnostics, and also neuroimaging patterns that are seen in the behavioral variant of Alzheimer's disease. Just quickly going through the diagnostic criteria to clinically say this is probably or possibly BVAD. You need to have at least 2 of the core symptoms, which is disinhibition or apathy or loss of empathy or presentative stereotype behavior or hyperorality. At least 2 of those specific cognitive profile where there's a relative sparing of language and visual spatial abilities, and other causes are excluded, including BVFTD-linked genetic mutations and some supportive findings like hallucinations, delusions, and on top of that, having CSF amyloid or tau. I wouldn't take the plasma as of yet. To say it's probable is having all of the above plus tau PET positivity, and of course, definite is the postmortem study. Now, why do I speak about BPSD? Because BPSD is the reality. If you're running an Alzheimer's service, if you're running a memory clinic, you would know that just like this. What's suggested here is that 97% of patients present with some type of behavioral psychological symptoms. And the question always remains, do you address the pathology or do you address the symptom, or is it a bit of both? Why is it a burden? Because it causes significant changes in the quality of life of the patient, there's a caregiver stress, and there's stress on the society at large, plus expenses on healthcare facilities. Now, the profile in the behavioral variant is a bit different, and it looks a lot like frontotemporal dementia, where there's apathy, there's exit-seeking behavior, there's hoarding. A lot of the time, it's aimless, it's repetitive, it's stereotypical. There are vocalizations. There's picking of the skin, picking of the hair, picking of objects. There's environmental dependency, where a person gets triggered by the environment. If there's a wheelchair, they're just going to push it. If there's a door, they're just going to slam it, and so on and so forth. So one easy way I find to assess behavioral symptoms is the the ABC, which is basically you look into the antecedent of the behavior, try to understand the context of the behavior, and then you understand the behavior itself and the consequence of the behavior and the consequence of your intervention. It's good to use a standardized method of assessment like the MPI or the CMAI, depending on what you're looking at. For example, a CMAI is focused on agitation. It's quite comprehensive, whereas the MPI is a quick tool you can use in clinic. Now, when we say apathy, we find that some might struggle differentiating apathy from depression. And apathy is lack of motivation, lack of initiative, and lack of interest, whereas depression is the persistent low mood, sadness, and hopelessness. It's quite prevalent in dementia. It might be the most prevalent type of BPSD in dementia altogether. And you see the highest prevalence is in the frontotemporal dementia, and then the next highest is the Alzheimer's disease. Okay, either I forgot how to use this or... Okay. So the issue, non-pharmacological interventions, we always advocate, any geriatric psychiatrist would advocate for non-pharmacological interventions simply because they work. The issue is that most of the studies were done in nursing homes, and the interventions were, I can't find the word, but were done, I guess, by trained healthcare providers, occupational therapists, nurses, etc. And they were done in a controlled environment, and they were done a few interventions at a time. So it's a bit difficult to pinpoint which intervention did better. However, we know for a fact that they work. So we have a few systematic reviews here, and hold on. Oh, okay. I'm struggling here. Apologies. So there was a quantitative systematic review of 56 trials and looked at various apathy scales like the NPI and the AES, and they found that they use exercise, music, multisensory stimulations, animal-assisted therapy, special core programming, and so on. And they found that non-pharmacological approaches reduce apathy with one-to-one individual therapeutic activities being the most consistent. So one of the most consistent interventions is one-to-one therapeutic interventions and exercise. However, this is focused on apathy, and the other studies are basically saying the same thing in different words or different interventions. So the next one looks into, it's a randomized controlled trial, nursing home residents with dementia looked into high intensity and functional exercise program. As I mentioned, exercise seems to be quite, has a positive effect, and it's replicable in studies. And after 12 weeks, the exercise group had significantly lower apathy scores versus control, and so on and so forth. So the other studies also show you why guidelines focus on non-pharmacological interventions. It's simply because there's a lot of evidence telling us that it works. Now, when it comes to apathy, one of the biggest issues is the pharmacological interventions with apathy. Now, this was a study published, I think, a year ago, and it shows the effect of methylphenidate on apathy. And there have been some studies replicating this finding, where people on methylphenidate versus people on placebo, and the outcome shows that the NPI scores of apathy are dropping in the people with the methylphenidate. Now, this is again a Cochrane review which looked into different medications. I'm struggling to read the slide myself, my apologies. The first one is a forest plot which looks into the role of methylphenidate again, and it shows consistently that different studies show, and the combined effect favors methylphenidate with very low bias. And the next slide looks into cholinesterase inhibitors' effect on apathy, and you see there's a bit of bias there. Some of the studies and some studies cross the line, but the combined effect also favors cholinesterase inhibitors. Having said that, a forest plot with the outcome being the side effects does not favor methylphenidate, as it might worsen impulsivity, might worsen agitation, aggression, might worsen insomnia. So it's really tailoring your intervention to your patient. Now, this is quite a comprehensive review which looked into many medications, and I just want to highlight a few. Again, donepezil showed some effect, but for some reason, the effect was better in the subgroups with better frontal function. So, in other words, not the behavioral variant. We also see that donepezil does better with apathy and Lewy body dementias as well, as per the Domino study, if you're aware of it. Galantamine shows evidence leaning towards a modest effect, so most of the effect is modest at best, unfortunately. Memantine was inconsistent. Ginkgo biloba had some 3 RCTs that reported significant improvement in apathy score, so probably this is a region where more research is warranted. Modafinil, conflicting studies, and the studies reviewed in this systematic review did not show effect. Antidepressants, multiple studies have failed to show the role of antidepressants in apathy. So one take-home message today is antidepressants do not work for apathy, unfortunately. Antipsychotics, again, not your best bet. Their overall use is discouraged due to the severe side effect profile in dementia. Pain management, however, showed significant improvement in apathy, and you would see in nursing homes sometimes there's the paracetamol empirical treatment, which seems to help with BPSD altogether. THC and cannabinoids, no significant impact on apathy. This is another study from the American Geriatric Psychiatry Association, and the summary is pretty much the same. Acetylcholinesterase inhibitors have the strongest evidence for benefit, modest benefit across AD/DLB. Memantine, mixed evidence. Typical antipsychotics, largely ineffective. Atypical, some evidence, slightly indirect. Antidepressant, generally ineffective. Psychostimulants, modest benefit. Other agents, mixed need when we need more evidence on that. I'm going to have to rush through to also speak about other behaviors. Now, the other frontal behaviors, which are the repetitiveness, the hoarding, and what we call the vocalizations, the exit seeking, what we call in clinic the frontal lobe involvement or the frontal syndrome. And again, non-pharmacological interventions are the first line intervention, and a randomized trial of tailored activity program, tailored, one-to-one, meaningful tasks administered by a trained healthcare provider. And it was looking into picking and hoarding, universal engagement, and it showed reduction in agitation and repetitive behaviors compared to usual care. And another study looking into supervised strength and balance exercises plus guided walks in 12-week assessor blinded RCT, and intensive exercise group had significantly lower apathy and restlessness. And music therapy, again, has repetitively shown efficacy in different kinds of BPSD, including the frontal symptoms. Other interventions that might work are the multisensory stimulation, the simulated presence therapy, and the behavior management and validation techniques. Now here the validation was for the caregiver, and there's also a lot of evidence that tells us caregiver training and psychoeducation decreases BPSD in patients. So this is something we need to be cognizant about. Now, in terms of medications, there's a lot of extrapolated evidence from frontotemporal dementia research telling us that a antidepressant might help in such situations. So in a small open-label study, 38% of dementia patients responded to sertraline with drug-responsive behaviors, including reductions in pacing and other aberrant motor activity, and so on. And there's another study where sertraline was added on top of donepezil, and it also showed 60% of sertraline group achieved more than 50% reduction on the behavioral scale. Now, this is a study where this is a systematic review done by Nizar et al., published 2021, and it looked into the role of trazodone, fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, antidepressants, and how those antidepressants would improve disinhibition, irritability, aggression, and aberrant motor behavior, that is, frontal behavior plus aggression. And as you see, the forest plot here favors antidepressants. This is every study separately, and the combined effect also favors antidepressants. However, this was specific to frontotemporal dementia, so it's extrapolated evidence at best to be used with Alzheimer's. Now, this table was taken from the British Columbia Guideline for Managing PPSD, and it tells you clearly BPSD, not amenable to antipsychotics, is a list which people might call frontal behaviors. So usually frontal behaviors do not respond to antipsychotics. Antipsychotics might tranquilize a patient. So if a patient is doing less of those, it's probably because that patient is sleeping or drowsy, which is not where we want our patients to be. So I'm right at time. I'm very proud of myself. So a take-home message is that the behavioral variant is quite distinctive type of Alzheimer's that presents early with predominant behavioral changes, often preceding memory decline and mimicking frontotemporal dementia. The diagnosis hinges on having two core behavioral features, plus executive or memory deficits, non-drug approaches tailored and delivered by trained caregiver or trained healthcare providers is the best way to go. That includes exercise and many other interventions. Pharmacotherapy, however, has a modest effect at best, and in many cases, it really depends on the symptom or the pathology. Ongoing research is needed to develop targeted RCTs for hoarding, pacing, exit seeking, picking, and other frontal behaviors. Thank you very much.
Thank you. Thank you all for attending today. The faculty will do the award ceremony now, in case we haven't done that. Tomorrow we start at 8:30. And I want to thank you all for being here. I hope you're learning something, and I'm enjoying the dialogue. We're doing the
How about Nasir al-Zubaydi? You want to do that one? Can we do that?
Recording stopped.